morning, all. Good morning.
We are just waiting for Dr. Sanjay Michael sir to arrive. So once he comes, we will start the symposium.
हाँ ये फोन मेरे पास नहीं कर रहा है
Dr. Gore, good morning.
Iman, I saw you.
Dr. Gore, I was expecting here.
Yes, I mean you are the first person to come.
Yes. I was expecting you also.
This is
you would have prepared for a talk and it would have been a panel.
I'm prepared for none, actually.
That's okay. You just 15 minutes.
15 minutes.
So you can manage.
अच्छा तो कहाँ बैठना है?
मैं तो पीछे बैठा हूँ आराम से।
मेरा
ऐसा कैसे?
introduce
मेरे ये जो नाटक होता है ना कौशिक आपके, like I see through them now.
Yeah.
But I mean it. I mean.
Sir, not ready,
यहाँ पे बैठो मिर्जा सदन। अच्छा वाईफाई के हाँ
Amran?
ओके यहाँ पे ही है मैं क्या करूँगा मेरे को पता नहीं है नेक्स्ट मार्च तक मौसम होना तो पहले मैं इतना सुखी था ICMR था दोनों काम कर रहे थे it's like यहाँ पर भी जाना पड़ेगा वहाँ पर भी जाना पड़ेगा
I can understand. अभी मैं शादान को बोल रही थी शादान कह रहा है बस मैं नेक्स्ट उस पर पहुंच जाऊँ मैंने कहा देख take slow relax because
he's like too like fast.
Good morning, Dr. Satya.
But when you reach that level, then
good morning, sir. Good morning, all seniors and madam.
Good thing, but
which is not a good thing because you get frustrated doing the same thing again.
Good morning, yeah. Good morning, ma'am. It's nice to see everyone here.
So that's what I was just telling you. You just take slow. Don't think you have Please just try it.
Maturity. मैं बुराई कर रहा
अब तो कोई बात नहीं करता
मर गया क्या
बुराई का बस सही करूँगा तो मेरे साथ ही करना
No, say that. Gosh, get it.
Good morning, Pragya.
Promotion होना चाहिए पहले मैं तो उसका सीखी था.
Good morning, sir. Good morning, sir. Everyone.
Yeah, बस
How are you, sir?
बस मजा है. क्या करना है? कुछ तो भी करते रहता हूँ.
so grateful and honored that he has spared time despite of his busy schedule in Delhi. I know how much busy he is. He is the head ECD, he is a director at NARI, he is helping in fight against the COVID-19. So, ICMR, as you might be looking the newspaper articles and the media reports, so he is everywhere. But he is very close friend. He has spared time, so I am so thankful and I welcome to RMRC Gorakhpur and his new building and here in this workshop. The second prominent figure today is with us, Dr. Mahendle. Dr. Mahendle, he doesn't need any introduction. He was and he is still the face of ICMR. He was the additional DG ICMR. Before becoming the additional DG, he was the director NIE Chennai. His contributions are immense in ICMR. I am so grateful that Dr. Mahendle has spared time and he is with us. He has been my mentor and guide. So, sir, I thank you and welcome you here. We also have with us Kaushik Bose. He is supporting in our communication related activities, and because of his support, along with Shadan and the team, we have been able to make some impact. Whatever you see the ICMR anywhere today, it has happened during last 3 or 4 years because of the hard work and commitment and support provided by the GHS and our team and all the NGOs that we have been able to do some dent in the media, particularly during the COVID-19 period. So thanks, Kaushik, for being here and joining us. I welcome all the speakers and the participants, those who are connected virtually. I can see Dr. J.P. Narayan. I can see many directors of the institute, many scientists, those who have joined here, and those who are going to speak today. All the participants from the RMRC Gorakhpur, Dr. Dhiman, who is again a senior scientist from the ICMR system. He has worked a lot in the area of climate change and the effect of climate change and vector-borne disease. He is here. So thank you so much and welcome to the RMRC Gorakhpur. We have the honor of having the other speakers like Dr. Priya Abraham, who is the director of NIV Pune. Then Prigya Yadav, who was again a star in the fight against COVID-19. She is going to speak on COVID-19 vaccine development. Dr. Priya Abraham will speak on the variant of concern. Today we are talking about the new variant. Kaushik is going to speak on the risk communication. Then Dr. Subir Majumdar, he has been the director of the National Institute of Animal Biotechnology. He has joined virtually. He will speak on the One Health. And recently, we have constituted a consortium on One Health Consortium. And this is a DBT funded consortium, and we are the partner. So he will touch upon some of the aspects on the One Health. Dr. Manju Rai, who is heading the vector-borne diseases in the ICMR system from the ICMR headquarters, through the ICMR Institute, VCRC, NIMR, and she is going to touch on the ICMR initiative on One Health. Dr. Sanmitra Pati, who is the director of the RMRC Bhubaneswar, she will share her experience on the research on NSAIDs in India. She was supposed to visit here, but because of cyclone and the other important activities, she could not come here. Dr. R.S. Yadav, who is a vector biologist, currently he is working in the WHO Geneva. He will touch on the global scenario of vector-borne diseases. Dr. R.S. Sharma, who was running the program of the urban malaria control in the National Vector-Borne Disease Control Program, he will be connected virtually. He will talk on the vector-borne diseases, urban health. Dr. P.K. Srivastava, National Vector-Borne Disease Control. He will join us around 11. He is coming from the Banaras. He will speak on the lymphatic filariasis. Dr. Dhiman has already informed he has been working in the area of climate change, so he will touch on the climate change and vector-borne diseases. Dr. M.M. Gore, who was the officer in charge in the NIV field unit that was set up here in the Gorakhpur, that has now been transformed and upgraded to a research institute. Dr. Gore will share the journey of establishing the NIV field unit and the fight against the AES. Dr. Manesh Murekar, again a very prominent figure, and he has been working with Dr. Mahendle in the NIE Chennai. So I requested Dr. Manu Murekar to visit Gorakhpur and share his experiences, but he is also joining the set of the VCRC Pondicherry, but he said he will be joining virtually. So he will share his experiences and work in the area of AES and future directives. Dr. Amita Jain, who is from the KGMU Lucknow, she will touch on the AES ideology in India. Dr. Bondre was the officer in charge before I joined here in Gorakhpur. He is going to touch on the JEA's research contribution of ICMR. Dr. Mahima Mittal, who was in the BRD Medical College as a professor of the pediatric department, head Gorakhpur. She will talk on the JEA's experience in managing pediatric cases. And Dr. J.P. Narayan, who is our scientific advisory committee member, who is also helping us and guiding us for the Kelong felicitation. So he has joined virtually, and he will give a final remark after the symposium will be over. So once again, I welcome you all, and now I will request Dr. Ina to take the proceeding further. Over to Dr. Ina.
Thank you, sir. Thank you for welcoming everyone. Now, building upon yesterday's tremendous success, we now move to the symposium on talking about the future activities and the scientific work that has been carried out in the area of emerging and re-emerging infections and pandemic preparedness. So, not wasting the time further, I would like to invite Dr. Sanjay Mendle for his keynote address. Dr. Sanjay Mendle is presently working as Director of Research at PD Hinduja Hospital and Medical Research Center. He has been previously a former Additional Director General of ICMR and Director NIE, National Institute of Epidemiology at Chennai. His research career included 6 years at BG Medical College and 32 years in various institutes of Indian Council of Medical Research, starting with NIV, as we told yesterday. His area of research includes field-based studies on dengue fever, health system-related studies, finally cohort studies, and health high-risk population that provided initial estimates of HIV incidence, epidemiological and social behavioral studies related to HIV/AIDS. He has been involved in strengthening public health training and capacity building. He was involved in the career building programs at NIE, Masters in Public Health Program, and other online training programs. He has been involved in major national level program evaluation studies, and he is recipient of many honors and awards. He's a member of many national and international committees and joint working groups of ICMR, DBT, National AIDS Control Organization. He has published more than 200 research papers in national and international journals and book chapters. He is nationally recognized as infectious disease epidemiologist and public health specialist. He's also a fellow of American College of Epidemiology, International Academy of Medical Sciences, and National Academy of Medical Sciences of India. So I request sir to please enlighten us to your keynote address.
I can come there. Good morning, everybody. Dr. Samir Panda, Additional Director General, Indian Council of Medical Research, Dr. Rajnikant, Director of RMRC Gorakhpur, all my friends who have joined remotely, my seniors like Dr. J.P. Narayan, from whom we have learned a lot in the area of public health, many colleagues in ICMR and my friends sitting here, some staff members and family members of RMRC Gorakhpur. Nice to be here with all of you. What I have been asked to do is just to share my views on lessons learned from COVID pandemic and then preparing preparedness. I do anticipate some kind of an overlap with the next session because the next session is also kind of geared to a very similar kind of a topic. And
But I suppose each one has different perceptions with respect to whatever we have learned during this particular COVID epidemic. And so what all we are going to share, certainly will have something for each one of us to carry. In the process, we will also learn a lot of things. Nice to be here. Thank you, Dr. Rajnikant, for this particular opportunity to be here with all of you today. So I'm going to start with, say, what are the different dimensions in which we have learned a lot of things, the lessons learned. Talking about human behavior, one of the things which came up very prominently in this particular pandemic as the lesson learned is human behavior is very complex. Not that we didn't know that, but we realized that whatever we are trying to do as a part of prevention and control, we kept on facing a lot of challenges. And many of them were essentially related to human behavior. Let's talk about and let us think about the typical triad, which is being talked about nationally, internationally, everywhere, that of masks, the social distancing and hand hygiene. But all of us know that whatever we prescribe, whatever we advise, how difficult each one of these is to follow in practice. So this is an important lesson to learn. There might be a technique, there might be a technology, there might be a strategy to prevent a particular disease or a control a particular disease, but to actually bring it in practice may not be so easy. This is what we learned, and it is an issue related to human behavior. And having worked in HIV/AIDS for nearly 19 to 20 years, Dr. Samiran and I, and many other researchers who have worked in this particular area, would agree that this is something which is very difficult to change. We require absolutely sustained efforts for a very long time to eventually bring about a change in human behavior. We know the issues related to vaccination. Although we talk about crossing the 100 crore mark, now reaching the 130 crore mark in India, all these have been tremendous successes. We know that. But we also know that there has been some level of vaccine hesitancy in the country. There are many who have taken the first dose, but who haven't taken the second dose. This is again an issue which is related to not only behavior, but probably also related to awareness, which goes one step behind that. There were issues in social gatherings, domestic, travel, international travel, etc., where again, a lot of human behavior was considered as important. And some level of self-discipline in this particular area was also considered very important. But we realized that there are a lot of deficiencies as well in this area. So how to really tackle them is going to be an issue not only for the COVID pandemic today, but also for things which are going to happen in the future. We depended a lot on the strategy of quarantine, home isolation, particularly when we realized that treatment of milder infections is possible at home as well. But then there were certain protocols which were given, which were suggested, but we found them that there were even deficiencies in following them. So this is what we learned. In the area of treatment and care, we definitely realized that this treatment and care was an area which showed lots of changes over all this pandemic period. Treatment kept evolving. And as Dr. Rajnikant said earlier, Dr. Samiran mentioned yesterday, this is an evolving epidemic. So there is a lot to learn in this particular epidemic. We probably are not at a stage to say conclusively that we know everything about it. Probably it might take a few more years to completely understand the pathophysiology of this. And some of these issues I'm going to flag in my talk as well subsequently. But what we really require now is the policy making, even as far as treatment is concerned, which is based on hard evidence, which doesn't seem to be there today. Lots of antivirals are being researched extensively, but have they really succeeded in that, in reducing the mortality or the hospitalization? There is no conclusive evidence as of now. Therefore, probably it might be necessary, one thing which we learned also, we have to have a flexible approach in eventually deciding. So some earlier guidelines, we were quite that time blind, if I use this particular word. We decided, okay, let's try this out. But then we realized one or two things which we had indicated earlier, probably global evidence emerged, and we realized that probably there is a need to step back. Even the drugs which were used very and were supported extensively earlier, including the hydroxychloroquine, tocilizumab, remdesivir, and many reports supported them, but eventually we backtracked on some of them as well. But this is good. I mean, we should not feel defeated because of it. Because if we are willing to change or willing to show that we can change, following evidence which emerges, it's a good sign. It's a sign that just tells us that we can improve based on the evidence that we have. We also understood that follow-up is going to be a critical aspect. Even today, we really don't have enough evidence to very conclusively say as to what is going to happen as long-term sequelae of those who have suffered from COVID infection. Particularly, we have seen the disease progression has been severe among people who have been aged, more than 65 years of age or more, or those having other comorbidities as well. But did they, or were many of them left with other long-term sequelae? This is only going to be possible through long-term follow-up studies, which we will have to generate evidence on. And unless that happens, this will remain and continue to be a challenge. But this brought up one issue on the forefront very clearly. We did not think about this earlier, but like we learned to work from home in many areas. Many industries started working from home. Medicine also started working in a long distance, what we call as telemedicine. Earlier, probably people were very hesitant to make use of telemedicine per se, but again, at a various level, now I work in a private hospital. So it was eventually, again, it was a process of evolution, but protocols were finally defined as to how could this telemedicine work efficiently, how could the images be transferred to the correct consultants of what were done. All these were lessons learned, and I think we learned this over a period of time, and to some extent we realized that, and this knowledge is going to be very useful, particularly when we are talking about the populations which are far remote and less accessible as far as healthcare is concerned. So these are critical points which we learned in this area. In the area of vaccines, I think this is the area where we learn probably the most. First thing is we learned that we can make a vaccine in a record period of time. All these years we have talked, all of my career in public health was built around this particular knowledge that any vaccination takes few decades to develop and eventually field test and come to the benefit of the people. But here is where we were shown that a vaccine can be developed not only in few decades or years, but a few months. And then in less than a year, it can be made available for people. This was an unbelievable success, scientific success, I would say. And it just did not come up so, just like that. People have slogged over this for several years. We have now perfected the techniques of viral isolation. We have now perfected the technique of sequencing of the whole genome of the virus, which helped us to understand what is the area we need to focus on and then work on the vaccine construct, which will be useful in the long run. So we could make that. We could also develop newer platforms. See, all these areas, all these years, we were essentially talking about live attenuated vaccines, killed vaccines, at the most vector-based vaccines. But this is for the first time we started talking about mRNA vaccines, DNA vaccines, peptide vaccines in a very big way. And this is going to be very useful because development of these platform technologies is going to stay with us. Many of our industries have learned the technique that how such platforms which have been comparatively new, how they are now going to be useful in future to develop vaccines in a record time whenever the need arises. Well, there are pluses and minuses of both these approaches. The older approaches and the newer approaches, they have their own strengths and weaknesses. But this particular, say, newer technology and the mRNA vaccines that have come here, that have given us an evidence that we can produce something in a shorter duration. They may be having some limitations. They might be requiring very stringent storage conditions. They might be requiring more frequent boosters and so on and so forth. But only time will prove it. I suppose this is also a good lesson that we learned. One important thing that we learned is we were always recognized in the recent times as a big strength in the whole world as far as vaccine production is concerned. But we proved that we are a giant in vaccine, not only vaccine production, but also, and we were able to fulfill the needs of our own country. Not only that, we were also able to give away the vaccines to the neighboring countries or even the countries far away from us who were not able to procure it from anywhere else. So this positioned us in a very nice way as a global leader in vaccination. We were always a global leader. Indian companies have been providing vaccines to more than 200 countries all over the world in the last few decades. But it could happen even in a case of a vaccine, which is a relatively new vaccine. This is again a new lesson that we have learned. But there is a lingering issue that we are going to have, and that is of adult vaccination. There is some level of vaccine hesitancy. There is some level of resistance to adult vaccination. And probably the hesitancy which we see for COVID vaccination is a result of that. We will have to address this particular issue in the long run. As far as evolution of strategies and policies is concerned, we realize that there are problems related to international trade and travel, interstate mobility, coming to consensus for developing diagnostic algorithms which will be all acceptable at a global level. And then the dynamics and logics of lockdown. A lot has been said, a lot has been discussed. I don't want to get into it. I only would like to say here that people who make these kinds of strategies and policies also have some evidence backing based on which such strategies are made. They have the backing of technically competent people and task force who are advising them to eventually make such kinds of policy. So probably as a nation, we have to have some kind of faith in the system and go by that. There may be disadvantages, as all of us know, could be hardships which people might have faced, but also we have to understand that they were kind of inevitable at initial point of time for sure. There are still some lingering issues related to all kinds of gatherings and get-togethers like functions and events, admissions and reopenings of schools and colleges, and then offices, public transport, sports complexes, religious places, markets, telecommunication through public systems, etc. They are going to remain because there are issues which we have to really trade on very cautious terms. We can't just have very drastic actions taken. We just can't stop it totally. We just can't open it out completely. We have to have the correct balance for the best public health benefit. That should be the goal. And let's also always believe that there are some intelligent people who are behind these kinds of decisions. We have every right to express ourselves. There is absolutely no issue about it because as they listen to one side of the story, they also listen to the other side of the story. And that helps eventually in the policy making. That's what I firmly believe. But we do need to strengthen our health system. That's a clear message that came out of it. We do need equitable access to testing, prevention, and treatment. So these were the three pillars based on which we, sort of fought this whole pandemic in our country. We required to strengthen our diagnostic sort of abilities, also the treatment facilities, and then eventually the prevention and control of this particular pandemic here. One thing and important that is to be understood is, although this whole thing started like with some kind of an international, sort of origin, eventually once the disease comes in and once the virus comes in the country, the way it spreads, it just goes beyond the boundaries within no time. We know that it just crosses boundaries, it affects large geographic areas within no time. And that's what we have to understand, that this is always a cascading effect or a circling effect. It starts with one epicenter and then just ripples go on and then they create other ripples. And that's the way this whole infection keeps spreading in a very big way. We also need the ability to mobilize nationwide, statewide, and district-wide rapid response. This, I believe, is the key. We now have been pretty competent, possibly at this level, to have a national level response. If COVID is a classical example where we know that all the strategy making and policy making happened at the national level. But eventually, I believe we should develop this particular ability to make this happen even at the state level. On the one hand, we keep calling that state is a health subject, but it should also have an equal capability of making decisions to that level, which are very competent and not necessarily rely on the state level authorities. To think of having such a kind of a competency and capability at a district level would be a dream. But it would be a dream for any kind of a public health person, because that would kind of indicate that we have reached a level of maturity when we will be able to handle even a very serious problem, even at a peripheral level. That will be an absolute achievement as far as I am concerned. Therefore, we will have to focus on training of healthcare workers in preparedness for healthcare threats and challenging situations. I will make few comments related to that also. But one more important realization that we have is that the human health is closely linked to animal health. And so we cannot approach at this particular problem or look at this particular problem in isolation. But so the important word that is coming up now, terminology which is coming up, is that of One Health. So we have to study the human health together with animal health, because that's going to find us better solutions to many of the emerging problems, or at least ability to predict things much better than what we are able to do. So that focus is important. Then as far as the impact is concerned, there was a tremendous impact at people faced economic hardships, vocational challenges, impoverishment at different levels. And this affected the comparatively weaker sections of the society much more compared to the upper echelons of the society. But it did impact the families, the communities, and the country. Even strategies like working from home, we know that there were lots of examples of stressful situations arriving in the family where people were not used to sitting together in a home for several months at a stretch. It created a lot of stress. It created a lot of problems. Physical health, so therefore physical health was one problem on one side because of the sedentary practices and lack of exercise, etc. But it also created a lot of mental health related problems and issues as well. So we have to understand that. So strategy making also can make an impact of this kind. We have to be aware of that. In addition to that, the migration and population movement. See, when a great amount of population moves from one city to another city, the city from which people have moved out, the economy, not only the economy of that place gets affected, but suddenly people where they go and land up, economy also of that state, even the sanitation infrastructure of that also gets affected. That's something which we have to keep in mind. So one of the lessons learned is how and what can be done to really ensure that people don't leave this place and we are able to manage this epidemic in the place where they belong or where they are staying as of now. Finally, talking about the perceptions and realizations. So we understood that the virus does not discriminate between socio-economic classes, genders, level of education. It can infect anybody and everybody. We realized that. So we had to fight a huge global level pandemic, but we could do it. We saw the effects, we saw the impact. People who came together, who fought it together, those nations did find successes in control and prevention. Where there were internal problems, lack of collaboration, lack of cooperation, we did find that there were issues related to prevention and control. We also realized that family and community support structure is extremely important here. Simple things like a nuclear family, both husband and wife are getting affected, the poor child, what to do about that particular child. It became a problem in case of so many so many people in so many instances. But we really need to deal with these kinds of situations, understand what we are going to do. We understood the timely use of technology is important because that really helped us in a very big way. And we realize that global response and cooperation is very important. So with all this that we have learned, what do we do now to achieve some level of preparedness for future? Because we know that this is not the end of the story. This is just probably going to keep happening. But public health importance, if we look at any particular infection or any specific disease, following criteria we think about is the way it transmits. The higher is the transmissibility, the more is the public health significance. Non-availability of an intervention may be of a curative type or a preventive type, like a treatment or a vaccine. Then severity or high case fatality rates, human or animal interface, serious economic impact it can cause, major impact on economical weaker sections of the society and vulnerable populations, the ability of that disease, the attached social and societal stigma, and evolutionary potential. And now look at COVID. What COVID did? COVID satisfies each and every criterion which belongs here. Look at cancers. Cancers are a public health important problem, but cancers are not transmissible, as you know. So there are certain criteria which get defined. There are certain criteria which do not get defined in case of certain diseases. But COVID was such that it really satisfied all these criteria, which classically help to put a particular disease in classification of public health importance. Yeah, right. So let's take an overview, a quick overview of what are the emerging and re-emerging diseases. Thinking of globally, we have a list of HIV/AIDS. Let's start from 1980. So early 80s was where HIV/AIDS came in. Then SARS, plague, Ebola, Marburg, Nipah, anthrax, MERS, meningitis, cholera, H1N1, H5N1, etc. But we were not far behind. See, if we just talk what happened in India, starting from 1990, we have also seen a large number of and I'm pretty sure this particular audience need not, I need not talk about what is emerging and what is re-emerging. There are re-emerging infections like Vibrio cholerae and plague that we have seen in our country in different pockets, as has been shown here, like also chikungunya. But we have also seen Chandipura, we have also seen Crimean Congo hemorrhagic fever, we have also seen Nipah outbreaks. So these are something which are emerging. Still, we do not know the extent to which they reside in our country, and they have a potential to anytime flare up any kind of an epidemic. We do not know. Just to say that they are there, very much there, and we have noted, we have investigated many of them in the last 20 years or so. And one of the important factors that brings these things together, what result into emerging infections, is a kind of a interface between animals and humans, as I said. Well, we do not have a direct contact with wild animals, we know that. But we do have domesticated animals who are who act as a link between humans as well as wild animals. As well as some activities happen by which humans try to invade the forest directly, and then some of the things what are happening in the forest, the wild animals, etc. It is possible that these infections and these agents can possibly come into the human fold. So this kind of an interface exists. Many of them happen because of causes like encroachment from our side, agricultural or deforestation, agricultural use of such lands, which are forest lands, for example, and then global travel, urbanization, formation of new cities, and all of that. That brings these together. So frequency of emerging infectious diseases has significantly increased since 1940, reaching a peak in 1980 to 2000. And most of them have been caused by zoonotics. The origin has been zoonotics. So nearly 75% of all emerging infectious diseases affecting humans are believed to be zoonoses. And so zoonotic EIDs from wildlife have reached the highest proportion in the recent times, and we need to be worried about those. So we have to prepare roadmaps for epidemic management at the national and the subnational levels. And deliberately, I'm all the time talking about not only focusing our attention on the national level, but also creating some level of preparedness at the subnational levels also. That will make the things much more manageable in a large country like ours. Otherwise, if we just keep relying on the center or on a central program, it's always going to be tough for us. And while we do that, we have to focus, or we have to keep our focus on certain important areas. So if these things are happening, we have to predict, we have to be clearly, it has to be clear in our mind that there may be outbreaks, there may be epidemics which might happen. They are related to things like environmental change, land use or air pollution, resulting from deforestation, developmental projects, uncontrolled urbanization, formation of megacities, climate change, changing agricultural practices, etc. But also there are additional aspects which are going to be useful and we have to keep a tag on that. It's that of microbial adaptation and change. We are seeing it. We are actually witnessing one such thing which is happening now. The variants that are emerging in the area of COVID. But so viral mutations as they happen, on the contrary, the antimicrobial resistance as that is happening. Because viral mutations, we would be worried about two things. We would be worried about the transmissibility. We would be also worried about the virulence. But the antimicrobial resistance is we're worried about our ability to treat patients if they are bacterial diseases particularly, because we don't feel that we have big confidence that we can treat viral diseases with treatment per se so effectively. We have to keep also on the scene, the focus, the international trade and travel practices, which involve animals, birds, vectors, contaminated foods, etc. Some of these are controlled and regulated, many of them are not. So how do we really take care of this? Because if this is not going to happen in a very regulated fashion, then are we truly capable of preventing or putting in boundaries between international travel, international spread of such diseases? For example, we are sitting in Gorakhpur now. Something happening in our country, can it really be presented from filtering out in Nepal or vice versa for that matter? So with our boundaries being so porous here in these specific areas, so we have to keep thinking about particularly such terrains where we cannot have a rigorous control or policies which can prevent these trespassing, so to say. And then we have to also look at the public health infrastructure preparedness to face the unknown, like we faced the unknown of COVID-19 2 years back. This was something which we didn't know about, so this will require a lot of investment, then capacity, training in rapid response, and then also surveillance, the laboratory support and immunization. Fortunately, all this could be put in place in 2 years as far as COVID is concerned. And that is one of the reasons why India probably is believed as one of the success stories. When people in the initial phases had believed that India would go a very, very wrong way as far as COVID is concerned, but it did not happen. And indeed, people in the West were quite surprised to see why it was happening. We probably still do not know why this is happening or why it happened. But whatever happened could be related to any of these factors which we probably need to be aware about. So classically, for prevention and control of any emerging and re-emerging infections, the WHO recommended strategy starts with putting in an adequate surveillance. But that surveillance, which is doing the risk assessment and then initiating the response, what is really critical is the surveillance picks up what? The surveillance picks up the situation where such epidemics are likely to happen. It is not a good idea that we have surveillance that detects the cases when they happen. We should have the ability to pick up the cases and from that forecast that an impending threat is eventually going to hit us at some point of time. That's the goal of any kind of a surveillance system. We should have lab preparedness. For this, you require state-of-the-art laboratories. Nowadays, all of us know that in addition to serology, we have to rely on molecular diagnosis as well. We do have to rely on virus isolation, sequencing, because all this is a package which helps us eventually to decide what our response and fight is going to be like. So we have to have all that capacity over a period of time, and not only at the national level, but also at the subnational level. then the prevention and control of zoonosis becomes an important area of concern. Again, this is something, the whole area of zoonosis, as far as our country is concerned, is being managed by a department which has got no linkages and no connections with human health. And the same thing can be said about human health. Human health doesn't bother to go into and have a dialogue with the animal health department per se. But this picture has to change. This picture has to change sooner than later if we have to achieve good control on the emerging diseases. We should have adequate infection control and prevention practices, risk communication. And I'm sure one of the talks in the next sessions is going to talk about communication, risk communication in particular. And Kaushik will be able to highlight important issues related to that adequately. And then we have to have public health emergency preparedness, regional preparedness also has been advocated by WHO, and then monitoring and evaluation. Why is this critical? It's because we may be having strategies, we might be implementing policies, certainly, but we have to know whether they are working or not. And if they are not working, what is the reason they are not working? And if we find the reason, can we do something to improve and sort of eliminate those reasons to make those policies and strategies work? So this is a very critical area, which also is very important. So WHO has recommended on development of national action plans to prevent epidemics, and what has been suggested is that there should be, this helps in one important aspect, it just reduces the timeline. If you work on your preparedness, you are already thought of things, nascent outbreaks, you already, like here is where I would like to talk about ICMR's foresight in establishing virology diagnostic research laboratory network all over the country. One of the important outcomes that is expected or deliverables that is expected of this laboratory network is to be able to predict the outbreaks which are likely to happen. And so pick up these nascent outbreaks. This is important. And also simultaneously with technology collaboration, we have to start working on certain products which will be at a stage. If something strikes, very quickly we can go into either therapeutic intervention or in a preventive intervention. So that kind of a development must happen, and that should progress to that level. Also, it is important to focus on severe emerging diseases with potential to generate a public health response. Those are that we already know about. But we have to keep in mind that there are going to be certain conditions which we do not know about, but they are likely to hit us. And what is going to be our strategy with respect to that? Okay. Then for prioritization, the top global diseases, the WHO carries out very routinely this exercise of classifying the top global disease priorities here. We have to align ourselves to that. It is not necessary that we adopt the same statement and the same list which WHO has given. It may not be universal, but it gives us some indicators as to in which direction we have to move. But as a part of ongoing process, we have to reassess our priorities and epidemic threats and defining priority pathogens for our own country, of interest to our own country. Developing R&D roadmaps to accelerate evaluation of diagnostics, therapeutics, and vaccines. Time and again, I will stress on this. Three important things: diagnostics, therapeutics, and prevention. They are going to be the most important approaches. Nothing new. We all know that. But we have to work in that particular direction. And then outlining appropriate regulatory and ethical pathways. This is another very critical aspect. So we have seen these situations now. Serum Institute of India came up and said they want to try out their recombinant BCG vaccine as a possible prevention tool here. So did we have the adequate regulatory pathway ready, the DCGI permissions, the trial sites ready? And from that context, I think, Dr. Samiran, I would appreciate the recent ICMR initiative of establishing clinical trials network, intact network all over the country. I believe this works well in tandem with the DBT efforts which are also going on in creating additional clinical trial sites in the country. So if we have such a large number of clinical trial sites that are created all over the country representing different geographies in India, such kind of hastening of product testing would be greatly facilitated, and I must appreciate that particular effort. So evaluation of diagnostic therapeutics and vaccines would require clinical trial sites and adequate competence for that. We should definitely build it. Then this should be an annual exercise of prioritization to review and revise the list of prioritized diseases and pathogens, and a separate process for dealing with a new disease or pathogen, and one that is presenting in a new manner and likely to cause a public health emergency. So, for example, if Lassa fever is happening in Bangladesh, we possibly cannot be saying that, well, it's not my problem. Why should we be worried about? Again, the same issue is likely to come up. It's just our neighbor, and it's possible that this particular thing might just filter out to our own country. So should we consider that as a priority for us? Well, it's up to us to decide which criteria we use. But something happening in our close neighborhood and where we have close ties, we have to keep in mind that we have a potential of acquiring or getting that disease. One good thing that has happened is that human transmissibility is various criteria have been defined, like that it has been given a weightage of 32%, 21% to medical countermeasures and severity 14. So how much it comes to? It comes to almost 70%. So these three factors alone decide what are the priority areas really. There are several others that have also been given weightages, like human-animal interface, other than public health context of that affected area, potential social impact and evolution potential, etc. But the first three are critically important. Why? Because they constitute 70% of the total 100% weightage. So if we use that as a decision point, then our job becomes little easy as to what is to be decided as a priority. Then is vaccine research important as far as India is concerned? This particular graph shows, if you just look at the left side, y-axis here, you can see this is the probability of success, and you can see how poor that is. Probability of success is always very poor in vaccine. You start with a very large number of constructs and end up with very few successful vaccines. On the right-hand side, you see the cost of that. So the cost of completing a particular trial, going through all this target antigen identification, then preclinical studies right up to phase 2 and 3 studies would cost to something like $500 million. Huge cost that is involved in that. And so what is important here is the observation so far is vaccines are developed when they are to be used for routine immunization or for high income populations and where a high return of investment is expected. So which essentially means that poor economies possibly can't focus more on developing their own vaccines. This is the so-called belief so far. I suppose we have to change it. And technology will help us change it over a period of time. Just the impact, there are a lot of indirect costs due to diseases which we have to keep in mind. And they involve the deaths of healthcare professionals, the quarantine, which necessitates expensive, rigorous screening and closure of borders, etc., reducing of trade and travel, then effect on food supply, etc., etc. So the World Bank had estimated at a time when this Ebola struck that there were indirect costs of nearly $4 billion alone as a result of an Ebola epidemic that happened not a long time ago, pretty recently. So because rebuilding is always expensive, vaccines can be a wise option if technology permits rapid vaccine development. And fortunately, we are quite capable of that. And that's the reason why India must be self-sufficient in vaccine. And we have demonstrated this in the recent time. So in case of biological threats, self-sufficiency of vaccines is crucial. Of course, this is particularly important for emerging acute infectious diseases. We have to keep that in mind. The vaccines for the chronic conditions have been on a slow path. We'll have to wait for a long time for successes to be seen. But we will start seeing the successes in that direction also. So Indian vaccine industry is globally competitive, already exporting vaccines to several countries. So we have shown our competence. Every reason we have to do it, particularly because we have the academia industry interactions, which are very good in our country, but we should make the best use of it. They haven't really truly been used to their best potential, in my view. If that starts happening, we will see much better products and outcomes. And one of the visions of India, that's called CEPI, or Coalition for Epidemic Preparedness Innovation. India has been a founding partner, along with Wellcome Trust, Government of Norway, and Bill and Melinda Gates Foundation, World Economic Forum. These people have come together and said that we are going to continuously keep working on areas of which are pathogens which are emerging here. So currently the emphasis is being given on Lassa, MERS, and Nipah. These are the three which are being worked on with great enthusiasm, considering the overall world perspective here. And so India is hoping to have a rapid scalable response to infection rate through a well-coordinated prepared public health system and a globally competitive vaccine industry by 2025. That is a good objective of CEPI in India. And we already are seeing things. Just to end, putting the discussion in the right context of the current status of the COVID-19 pandemic here, there are unanswered questions. There are questions related to rates of asymptomatic and mild symptomatic infections in case of emerging variants. Do we know? We do not know. Yeah. And as they are emerging, this kind of evidence will keep emerging. Can the disease progression from COVID infection to COVID disease be arrested by a non-vaccine intervention? Essentially, I'm talking about a therapeutic intervention over here. But then the ability is to diagnose early and to treat early. Then to actually, which pathophysiological phenomena lead to deaths? Is it the cytokine storm? It's the airway problem or anything else that is killing people here? One good thing that has happened is mortality has drastically come down. So we have had some success in bringing down the mortality to a large extent. But we must have probably a greater control on the mortality even in our country. What's the optimum treatment for COVID patients? We still are in search of a correct protocol, which is affordable, which is effective, both at the same time, and for a countrywide application. Is there any role for chemoprophylaxis or immunoprophylaxis in COVID infection? Are there true differences in COVID incidence and disease in different geographic areas? Is this because there are differences, or is this because there is a differential reporting, or is there are differences because there are differential detections? All these questions are to be rightly answered. We probably do not have the correct answers to all of them. With the some level of innate immunity in Indians, people keep talking about that. Which among the targets of humoral or cellular immunity should be pursued? We do understand humoral immunity to some extent, but we haven't understood the cellular immunity to COVID-19 until now. How long would the immune response to natural infection or immunization protect? This is an important discussion currently happening in the national scenario, the need for boosters in particular. There are people who believe we still have no need for any booster. But on the contrary, there have been continuously reports getting published which talk about falling levels of antibodies within a short period of time. Is this where the cellular immunity is important or believed to be important? I think this needs to be researched. Then what will be the defined protective level as far as herd immunity is concerned in COVID? What's the role of booster? What's the role of childhood immunization? These are two very important aspects being researched or being talked about extensively in terms of policy making today in India. What should be the policy for childhood immunization? I talked about that. And will the vaccines work against the emerging variants? Again, this is something which is a very tricky question, which we do not know about. We are hoping that they would, but there is no certainty about what is going to happen. And therefore, how to link the COVID-19 vaccination policy with emerging vaccine variant? Now today, we have been discussing for the last 3 days here. Today we are talking about a new variant, the 14th variant today. But will there be no 15th? We do not know. There will be 15th, and then will we start the whole discussion all over again now? will the same vaccines work or not? So should there be any kind of a common ground on which these kinds of variations need to be tackled, particularly with respect to vaccine development? I think that's a critical aspect. So correctly assessing the social and societal and socio-economic impact is critical. I did talk about the disproportionate impact on the society, particularly some sections like pregnant women, children, immunocompromised individuals, comorbidity, people with comorbidity, etc. There are major social disruptions which we have seen. Here, the various effects of fear and the pressures on survival, the serious economic impact, and then even the disruptions in the healthcare systems. We have to all keep this in mind. So, and this is potentially, we are talking about one such pathogen which has an evolutionary potential also. Because in terms of rapid pathogen evolution, increasing severity of the disease, increasing transmissibility of the pathogen, I think the second aspect is what we still have question marks about. In terms of variants that we are seeing, we are not getting a very clear evidence of increasing severity of the disease. But as far as the other factors in evolution are concerned, we are seeing the pathogen is evolving for sure. The transmissibility also is being linked to that. So we have to keep in mind that the new emerging infections will have these kinds of potentials for changes. Then the 4 pillars for containment of outbreak, containment of any outbreak in future are going to be diagnostics, vaccines, prophylactics if there are any, and effective drugs or therapies. So they are important things. So focusing on these areas becomes critically important and is also important in case of COVID. So we do need lead agencies and partner agencies, standard operative procedures as far as India is concerned. Mechanisms to pick up signals for emerging epidemics becomes critical. Framework for local, regional or nationwide implementation of prevention and control measures, and then ongoing community sensitization for these kinds of problems which are likely to emerge. And so ICMR institutes do have some role to play in this. So funding for surveillance to predict outbreaks and investigations of outbreaks, identification and preparation of clinical trial sites, which already some progress has been made in this area. Then infrastructure development and strengthening of laboratories and training of lab personnel. This is another thing. Through the VDRL network, ICMR has taken a good step. In addition to that, ICMR institutes have shown exemplary contribution as far as COVID is concerned. And I believe these capacities will keep improving. What we do need then is fast-track review mechanisms, regulatory, ethical, etc. Because if clinical trials have to happen, they have to be backed up properly with these. If they are not happening, then we will land up into kind of problems which are not correctable. And then the role of communication is pretty important over this scenario. So just end with this. So emergence of public health challenges is inevitable. Let's accept that particular fact. Let's not say COVID is the end of it. We have to be much better prepared through epidemiological intelligence, capacity building, technological improvement, and infrastructure development. All this is essential to tackle any kind of an impending threat, public health threat. So fight with commitment, coordination, and collaboration is the key if it is in the right direction. I think with this thought, I would like to end my talk. Thank you for this opportunity.
Thank you, sir. This is a paucity of time. We are not taking too many questions, but we still have, he has so many questions. I'm sure we can take 2 questions.
None of the questions is just query if anybody is not clear about anything. Otherwise, it was such an exhaustive and informative talk. It was indeed a treat to listen this talk. So thank you so much, sir. You spoke about from prevention to vaccine development, from psychosocial and societal impact to mental health issues. You also touched on the One Health and the genetic infection, from strategic planning to central, state and nation level preparedness and planning. You also spoke about the transborder infection that is very important, particularly for this region when we are just neighbor to the Nepal. You also spoke about the response and action and monitoring and evaluation, and also mentioned about emerging infection. It was indeed a wonderful talk. I think you deserve a standing ovation. Thank you so much. Thank you. So I don't think there should be any question. It is just if any query they can ask.
See, he has posed so many questions for all the researchers to work on.
Two or three can take the reporting for tea.
Can I start?
Shut up.
So I have a question here. So you rightly pointed out that pandemic preparedness and epidemic preparedness should start at subnational and national level. But as we've seen in COVID-19, it's an increasingly globalized world, and we can't work in silos at the national level also. Especially in the context of the Lassa fever that you spoke about, there is an outbreak in Bangladesh, and what is India's preparedness towards it? So are there steps being taken at the researcher level, maybe at ICMR or at the government's level, of regional cooperation on research, especially in the context of neighboring countries like Bangladesh and Pakistan, because we've seen that these outbreaks are very similar to our neighboring countries. So what are your thoughts on that? And also segue into that question is also on South-South collaboration, in terms of we've increasingly seen that the Western world responds to an outbreak or an epidemic in a certain developing countries have to respond in a certain way because we don't have that adequate resources, and also the climate is similar to what are your thoughts on that, and where are we in India on those things?
Thank you very much. As far as the neighboring countries are concerned, there have been very two distinct initiatives which I can think of. A couple of years back, there is a SARC countries association addressing health-related issues which has already been established. And they have a changing secretariat which keeps moving around from one country to another. The whole idea is to discuss the areas of common interest and to form priorities. I think what needs to be further followed up is to draw the common protocols or, draw the projects of mutual interest, common interest, and find appropriate funding agencies to make that operational. That hasn't happened. That's one I can think of. And one more thing I can think of is that Alien Network also was established long back. ASEAN, which also was related, which focused more on issues of vaccines. Dr. Ganguly was the ex-DG ICMR, was very instrumental in establishing this particular network. It also made some level of progress, but I suppose the current leadership could also look into how that can move forward. One good example, you talked about South-South partnership. Very recently, in the last 4 or 5 years, there has been very strong movement which has happened in this particular area in ICMR. South Africa programs have been talked about with the help individually, directly, which are supported by the ministries of India, as well as some international partners which we are working with. And currently, as I'm aware, between India and South Africa, the programs in the area of one is tuberculosis, second is HIV and AIDS, and the third is in the area of capacity building and training through mutual exchange of scientists that have been initiated. Already they are underway. We might be able to see their publications, we might be able to see their reports in the near future. So I agree completely with you that if we just tackle or look at the problems in a collective way, and with people who have common interests in that, we would be able to better address them, and which will have a larger implication.
Thank you, sir.
Anyone else?
Can I ask you a question?
Because no one else is asking, you can ask, no problem.
So,
Someone wants to ask from the virtual.
Chat, check the chat box. I'm not sure whether.
If anybody from the
Virtually who's connected, they want to ask. Give them a chance.
Excuse.
Any question from the virtual connection? No.
No.
So if no, then we can break for a tea for 10 minutes and come back again.
We can talk privately.
You're answering us.
No, you were supposed to ask another question.
We can take it up in that.
Okay. Okay.
क्या हाल है नीरज?
Preparedness. So first speaker is Dr. Samiran Panda, who is going to speak on the overview of COVID-19 pandemic response in India. I will request Dr. Ina to brief about Dr. Panda.
Thank you, sir. Dr. Panda, the additional DG of ICMR, is an astute clinical researcher of 30 years standing. He also serves as head of epidemiology and communicable disease division of Indian Council of Medical Research and director of one of the premier institutes of ICMR, named National AIDS Research Institute, located in Pune. As the head of the division and institute, Dr. Panda leads a large team of investigators pursuing applied basic research in the field of outbreak investigation and synthesizing evidence to inform policy, engaging communities in developing public health interventions and training grassroots level workers as part of community empowerment has all along been his forte. Dr. Panda has many scientific articles and book chapters including his credit, reducing infectious disease related stigma, addressing vaccine hesitancy, engaging myths and misconceptions around disease are some of the interest areas of Dr. Panda. Currently, he is focusing on climate change, interface between communicable and non-communicable disease, responses to two pandemics, the one caused by HIV and the other current one due to COVID-19, have witnessed active leadership of Dr. Panda for the containment. Dr. Panda is the recipient of ICMR Award in 1995 and Fogati International Award was elected as a Fellow of West Bengal Academy of Science and Technology for the year 2020. Sir, I request you to please start your talk.
Thank you, Rina, and thank you, Professor and Dr. Rajnikant, my friend and director of RMRC Gorakhpur. What I will try to over the next 15 minutes is to have an overview of the COVID-19 response in India, not necessarily to cover the topic in its entirety, but the appreciation of us around the COVID-19 pandemic response when it comes to a country. We are talking about India, but that holds true for many countries, I guess, globally, not if not for each and every country. So, the earlier presentation by Dr. Sanjay Mehendale, that would help me to avoid some of the topics and also try to find links with whatever he has said during his deliberation. When he say response, probably my next slide, if you say that, it's not changing, Yogesh. Okay, all right. Sorry about that. If you want me to stop in the sense that, okay, you do not want to listen, to things for long, I'll say, okay, this is the slide and that's it. Meaning, I'll spend a little more time, if not the whole of the time that has been assigned to me on this. In India, each one of us, pandemic, by the definition, the nature of it is such that each one of us has our take on the response. And we also have a judgment in terms of, well, somebody did this, while the pandemic was on, was it right? Was it wrong? Could it have been done a little more better? So each one of us has an opinion. So while having that opinion formed, I think it's very important for us to appreciate, first of all, these 7 elements. Each one of them requires a minimum of 2 hours. So it's a 14 hours thing, which I have to cover within 15 minutes. So I'm not going to cover each one of them elaborately, but health emergency governance, like when pandemic hit India, the decision was to shift the response from the Minister of Health, because disease is a health issue, which everybody readily appreciates. But then the decision, conscious decision from the government was to shift the responsibility to the Department of Home and the Ministry of Home because of certain reasons that we need to also think over. So why was it so? Then healthcare surge, the need for it suddenly coming up, and what was the response with regard to that? And was it all available? Or as we move, we sort of try to strengthen it. It is almost like what, you start taking a voyage, but your ship is not yet entirely built. So while you are sailing, you are still building the ship. So healthcare search, the necessity of it would require strengthening it. And that's not an easy task because you would not be able to figure out what would be the demand on this healthcare search that has suddenly emerged. So we do talk about emerging and re-emerging infections, but we need to talk about the emerging healthcare search related needs. Then effective alert system, do we have that? And where do we have it? Maybe at RMRC Gorakhpur, maybe at, there are so many ICMR institutes, but is it good enough? Can it be called an effective alert? Or the alert should also be there in the community because things do happen in the communities, not necessarily in the institutes, neither in the hospitals nor in ICMR institutes. So maybe the alert system needs to have its multiple eyes and ears, some of whom should really be in the community. And then health system resilience, how long it could sway and still manage. As we know, the houses are built in our prone areas. Similarly, under pressure, what is the resilience of the healthcare system? And then public health and social measures. What are those? PHSM in abbreviated form. And then I sort of wrote first BTD, then I changed it to DTV, and then I realized, we really don't know which country would be in which stage. T stands for diagnosis, T stands for treatment, and V for vaccines. So maybe in India, we had the diagnostics addressed first, and then came the treatment-related issues, of course, drawing upon experiences globally, and V is the vaccine development. But it's not a must that in a pandemic in future, or in the years to come, it would go in that order. But these are the three essential elements, and Dr. Sanjay Mendele was briefly referring to that. And CI for communication, and then infodemic management and community engagement. So these are nice abbreviations, if you remember, and these are the 7 key elements around which you can think of responses. How did India do? Was India aware of it? And then we will realize that it's not just India. It was a challenge for each and every country because it was a pandemic of completely unknown, caused by a completely unknown virus, which we gradually started understanding. So what happened at the beginning, and of course it was China, everybody knew about Wuhan, but the first case was detected in Kerala because a medical student, he traveled with his friends, of course, and not straight went from Wuhan to Kerala. So he actually traversed through multiple cities, and these contact-related issues then came into consideration. It was a minimum of 4 cities they touched and interacted with people, not knowing, of course, that there was not a plan behind it. But then, with the hindsight, we realized that, the travel and the intermixing, we call it contact matrix, if that's a technical term. So, of late, while huge amount of tourists were going to Simla, again that same consideration came in, contact matrix, and in a tourist spot, what happens, suddenly the population density gets increased. So how would one know that, we have to remain aware of it until and unless we know the characteristics of the virus or the bacteria or the microorganism we are talking about, which is so easily transmissible while the population density in an area increases and it gets transmitted through the infected water droplets while somebody is speaking or talking or singing or sneezing or coughing. So until and unless the transmission dynamics is understood, and that becomes very difficult when a disease is very new, a microorganism is very new, and then the responses start evolving. So the point I'm trying to say is that it is easy to criticize with your wisdom or our wisdom a little later than the beginning. But maybe we need to sort of get wiser as we move along with time. And then knowing the potential responses. So it is not only knowing the epidemic, but knowing the responses. So from there, we can sort of keep ourselves prepared about, there could be, different kinds of responses and we need to be aware of it. But when I say responses, please do remember CIC because infodemics is also one of the responses. So responses need not be necessarily always the right kind of response that we think is right. There will be responses which will be uncontrolled, and then we have to have a mechanism to address that. For example, infodemics, whole lot of wrong information is going all around, whole lot of myths and misconceptions that wanted me to address. But I think if we remain aware or appreciative of the fact, then we can have our response element also in place. Big trees, small trees versus forest. What do I mean by this? So the responses, when we say response, probably responses is a better word to use because there are multiple responses and it's not just the ICMR response. That we might fall into this trap. We are in ICMR, and there might be a thinking that, ICMR did this, ICMR did that, and it was so helpful. Yes, ICMR did a lot, but that is not the whole of it. So by that I mean that the response or responses can be considered as a forest. Maybe we played some, big tree role, or some of our roles were small trees, but that was not the forest. That's exactly the point I request all of you to appreciate, so particularly while we are talking about a pandemic. So pandemic in India, or for the matter in any country or globally, requires a multitude of responses. And ICMR played its own role, but research or biomedical research is not the only dimension. So that's my point. Now, all of us are familiar with this. The green bars actually talk about the two waves. The first one that you were seeing is it peaked around September 2020. And then the right-hand side one that you were seeing is around mid-May this year, 2021. And the blue line is actually talking about the test positivity rate. So you see, the more we are capable of testing individuals, then it is possible for us to have some idea about the waves coming up, which is great. So until and unless we have the ability to test, we will be able to track the epidemic. So that's an easy to understand response, but not necessarily an easy to understand response element for us to have in place, because we never knew what would be the requirement for the test algorithm, test diagnostics, etc. And this was a preparedness which we had. And Dr. Sanjay Mendel in his talk did mention about it, that the BSL-4 laboratory, and those of you who know it or were interested, it got functional, it started functioning by 2012, which is much earlier than the BSL-4 lab in Wuhan, which was 2017. So that, who did it? There was no COVID-19 then, 2012. So then who did it? So the policymakers or the program planners who would think of the necessity of having a BSL-4 facility within India, their farsightedness and their ability to read. So this is also one kind of response. So responses need not be immediate in nature. Not necessarily. So we can, as a country, we can remain prepared. And in order to be able to prepare, we have to have some kind of ability to read things in future. Of course, we cannot see future, but we can have some indications about it. Because in this building, I actually, took a photo of Einstein saying, he is saying that learn from the past, live in the present, and use all of them to get yourself prepared for future, if possible. So that's there. So I think that this is also a response. So you see, if we think of existence of this in NIV, National Institute of Biology in Pune, and if we start talking, what do you see? There was NIV, there was BSL-4 lab, and what fantastic work there. I said, look, we are not describing the response well. The point I'm trying to make, that this response happened quite some time ago. So the responses also differ in terms of them being present and keeping yourself prepared, or your ability to read that something is coming, and then you respond, and then you prepare yourself again, not only to mitigate the impact of the present one, but for future. So responses do vary, and they are not there at a given point in time, but they're spread over a period of time. Now, this is one, as all of you know, when we started, it was just the travelers were getting tested. And then gradually it got expanded, the scope, who all could be tested. But now at the extreme right-hand side, if you look at the arrow, which can be considered as an x-axis, on demand, and that was in September 2020. But gradually we could include more and more participants who could be tested. So this is a response which we were able to expand gradually, and then of course NIV's role, and so that was about knowing the beast, if you like it. If you do not test, how do you know? But then that numbers which are getting generated through the tests also need to be collated somewhere, analyzed, and so data. Now, in a pandemic situation, as it is said, water everywhere, not a drop to drink. Similarly, data everywhere, not much data to use. So until and unless we are very aware, and this is a research institute, and if we do not talk about it, if the program doesn't talk about it, we can generate data which can give rise to scare, but not a decision-making, contribution. So that's why I thought this is also a response for which, we can have this response sort of done by us, quite well ahead of the actual event. And so how do we generate the data and the data quality control? As I am talking with the scientists here, I would say that the National Institute of Medical Statistics came up with a very good data quality related resource person. Yeah, exactly. And so you can access that through the website. And then responsible data sharing, because everybody says, oh, we have to be transparent. Why don't you share the data? As if the data is given, there are people who can solve the problem just like that, which is absolutely wrong. There are people with different kinds of intentions. So responsible data sharing. What is going to be done with the data? Of course, if it is a good quality data, and then if you have 2 or 3 different kinds of databases, do they talk to each other in a manner that you can even do the analysis which is required for a country level decision making. So you see, this is something which was developed by NIV, and this kind of kit, ELISA COVID coverage, that helped in doing a national serological survey, which revealed this kind of upwardly going graph line, which indicates that more and more people are getting infected. But I was talking about data. Now listen to what I had to hear from the journalists. They said, well, now in Pune, and because the ELISA kit was available, so people were able to figure out how many people were, having presence of antibody. So in Pune, in Delhi, and Baroda, they found that 50 to 60% in these cities, people had presence of antibody, meaning that they got infected. And then the inference was, so India has attained herd immunity. So you see, how do we extrapolate a finding to generalize? So Pune, Baroda, and Delhi became India. So I asked exactly the same question to the journalist. So since when Pune, Baroda, and Delhi have become India? And then they realized, so we are extrapolating. So I'm talking about, so it's a tool which is there, which is making, enabling you to identify the antibodies. You are doing your national serological survey, but you don't remain as a national serological survey only. It will be done in other cities. And then if you are not aware about the data quality that Dr. Srikanth and I were sort of alluding to, we will be misinterpreting or will be extrapolating it too far. Now, you see, we did not have the flock swabs to collect the nasopharyngeal specimen or the viral transport medium developed within the country, RNA extraction kits, RT-PCR kits, but now we have them all. So this is also a kind of response. And you get to hear about Atmanirbhar Bharat, but that's about, our ability to develop these kind of, test facility. But this is not the only response. That's what I want to underline. So this is part of the response. So we did talk about diagnosis, we did talk about treatment, and we did talk about vaccine. So let me touch upon the treatment a bit. And nobody knew globally. But you see, it is not India which developed all the treatment system. No, not at all. In a pandemic, you need to have your, openness to the global knowledge. And recovery trial is something which contributed, that steroid from the UK, of course, as a contribution, that steroids help. And what India did, India did this placid trial by which we revealed or we were able to understand that convalescent plasma was not that helpful or promising as we thought convalescent plasma to be. And then again, there was this solidarity trial that we also participated, ICMR institutes and India took part in the paper. So what I'm trying to say here, that we need not to get back to our country being such an old civilization, we'll have all the answers and maybe some traditional things will help. We need not to get into that trap at all. We are researchers. So we need to be open into quickly generating evidence and discarding a particular evidence if it is clear that it's not working. So we need not to be sold to an idea of being a very old civilization and having all the answers. That's what I'm trying to say. And so when we have suspicion, but we do not have all the answers for treatment, maybe we have some answers, we had, not all the answers, we still have around COVID, then we may need to also think of the home-based care. And what kind of home-based care need to be offered. And that also is not carved in stone. You can keep on changing or deleting items which you did. And some of the items which you were seeing on the right-hand side were removed. So basically what I'm saying, home-based care, community engagement, all these are very, very important. In the meantime, ICMR, being a research institute, actually had 4 kinds of call for proposal: clinical research, diagnostics and biomarkers related research, epidemiology and surveillance, and operation research. Now, I will just focus on operations research because we did talk about epidemiology and surveillance, which is about the National Serological Survey, and the National Institute of Epidemiology played a great role there. Diagnostics and biomarkers, National Institute of Biology, and all this would happen because other ICMR institutes helped them join hands. Clinical research was happening, as I said, but I have not said anything about operations research. And all of you, particularly those who have not seen this, you can go to YouTube and you will see that how the drone was used, and Shadam was there while I was there in Manipur, and there were other ICMR staff as well, from which were very young scientists, but they got encouraged. So the operational research. So it is not only just having vaccine or having a medicine, how do you move them to the underserved population and the hard to reach areas. So that is also a part of the response. So we should not forget about that. So innovation can happen at different levels, and the research organizations have a great role to play there. So as you can see that there were different guidelines which were issued by the Minister of Health and Family Welfare, and the research informed actually program. And in vaccine development, Dr. Sanjay Mendele has very aptly highlighted what was the role that was played, so I will not elaborate, but had it not been possible for us to at NIV to isolate the virus, it would not have been possible to move further ahead. I'm sure that Dr. Priya Abraham has another session, so I don't want to steal the thunder there. I will move on. And you see, even if you have a vaccine and you do not have the approval, what will you do? So just having a vaccine is not good enough. And we realized that India was well prepared in terms of realizing that even with the phase 2 trial data, in a situation which is captured by the term unmet medical needs, any disease which causes immense amount of death, which leaves you with disability, or for which you do not have ready to use medicine, that is termed unmet medical needs. And there, your regulatory authority within India, that's why it is proactive. Allow phase 2 trial. So that's also a response, but we frequently forget, because when you deal with the biomedical research, it's all about, knowing the disease, diagnosis, treatment. It doesn't work that way. So you see, I'm just trying to sort of show you the horizon, how wide it is. And I was so impressed by this new building where I'm sitting and talking. One room says health policy and economics. So maybe one of you or two of you need to specialize on that. Another room could be, outbreak investigation. So until and unless we develop our skills around different, areas and facets of pandemic response, we will not be really able to, as a research institute, to be able to contribute to the program. So coming to the considerations for approval, the regulatory authority in India, which is DCGI, Drug Control General of India, did talk about risks, benefits, the ability to slowly roll out, and the whole journey needs to happen with the people. It is not, ICMR, Minister of Health and Family Welfare, saying that, look, guys, this is good for you. No. We have to be, because public health is all about for the people, of the people, and by the people. People have their role to play as well. So maybe one of the scientists, or a group, and really specialize on community engagement. I did talk about CIC, communication, infodemic management, and community engagement. That's why it's so very important. Do remember, but is this a wrong statement that what do you think? Vaccine does not prevent infection. Is it right? It's right. Okay, you say it is right. Maybe you like me, that's why you are saying. So
100%.
Generally, it sounds wrong, right? Vaccines do prevent infections, right?
Yes.
But probably not. Because you see, vaccination does. So vaccines don't prevent infection. Vaccination.
Inside the bottle, they don't do anything. You can keep your bottle inside your pocket. It is not going to affect you.
Exactly. So Dr. Sanjay Mendel was talking about vaccine hesitancy. So if you have the vaccine, there in the cold room that Dr. Nikant has told you, what does it do? It doesn't do anything. So what helps people to go ahead and get vaccinated, or what inhibits or prevents people, or what contributes to the hesitancy? And is it only the problem with the people? Are we not contributing to the hesitancy by saying something in the public? We have to also question ourselves, our colleagues. So it is not that people don't understand science, that's why they're hesitant. No. Maybe the way we are communicating is also contributing to the hesitancy. Of course, India had this whole experience of immunizing children, and that was a huge number, 27 million passports every year. And that's why India was well prepared, but this was about adult vaccination. So you can have some, advantage of having that immunization experience, but you need to also reorganize yourself, retweak your ability in order to be effective. Of course, India, as a part of its response, has different experts groups and advising on vaccination, intervention, treatment guideline development, and that was one of the key thing. And I was talking about CIC, and I'm sure Mr. Kaushik Bose is going to address this, so I will not elaborate upon that. I'm not educated enough to talk about that, but I appreciate this. So my point is to be able to appreciate the wide nature of the response elements. And then do remember that there was an anti-mask meeting, and this was 100 years ago. And on a Saturday, people were meeting, and we are seeing the same thing today. So the behavior change communication, and I do expect that some of the scientists from RMRC Gorakhpur, specialize or focus or develop their skills on that. So you see, and the way the masks are being used. Journal as a title, which got published in ICMR, where we highlighted, issues around masks. And the communication and I had the opportunity to see what Dr. Rajnikant showed, that compilation from RMRC Gorakhpur, ICMR, from headquarters done exactly this one. So I was trying to, while developing this presentation, I was trying to figure out, so what could be different kinds of responses? So it's not just science communication, it's communication in the popular media, social media, press briefing, each one of them. And not that, maybe Dr. Rajnikant is very good in something, but maybe he's very bad. I am very bad in talking to common, I don't know. So maybe we need to sort of appreciate that rather than each one of us trying to talk about everything or do everything. Dr. Priya Brahmi, I'm sure that is connected. She released a very nice video on infodemics. So if you are interested, you can listen to that. But it doesn't stop within the country. While you are talking about the pandemic, it doesn't, respect any boundary. So you have to also have the communication with the other countries. So your international relationship and the diplomacy is so very important. And that's an example. And this is very elaborately explained in the book, going viral. So I'm not going to elaborate on this. And there was 1947 when Amrita Kaur Maharani, who actually contributed money for development of that wing in AIMS, she was receiving, the vaccines, polio from Canada. But now, 2021, Canada is asking for, everybody got so elated, oh, this is, you see, vaccine, Maitri, and whatever. But well, the politics around it also is a response. So, and we need to see, is it going right? Is it going wrong? And it's okay to ask questions about it. So we need not be just, looking at this picture and go extremely elated. You see, now that time, 1947, when we got our independence, we are receiving vaccine from outside country, and now we are giving it to other country. So that's a great leap. No. The epidemic and the pandemic also is posing challenges. So it's not a quick inference that we can afford to take. So I will end by this slide where something is written there. If you cannot read it, I can read it for you loudly. The best match means matchstick, okay, in the world will not light a candle unless the wick be first suitably prepared. So the preparedness for the pandemic is so very important. After Dia Galayani, we saw it was fantastic event last night, and I stop here. Thank you.
Thank you so much, sir, for a wonderful talk, for giving the overview of the COVID-19 pandemic. It is possibly a time we are not taking any questions right now, but people can talk to you during the lunch break. So the next speaker is Dr. Priya Abraham. Since we are running very short, very delayed in our schedule, so I'll just request all the speakers ahead to please stick to 5 to 15 minutes of schedule. And please, excuse me, I will be keeping the introductions very, very short. Thank you so much. So I'm introducing Professor Priya Abraham, who is the director of ICMR National Institute of Virology, which does not need any introduction now. So she took the charge in 2019, I think just before the pandemic started. So before that, she was earlier heading the Department of Clinical Virology at CNC Vellore. And during pandemic, she has been at the forefront in the fight against pandemic and involved in several research activities, starting, as we all know, whatever ICMR has done, starting from isolation to vaccine development to diagnostics development, she has been at the help of it. She has received many awards and she has published multiple papers in many international journals. So with this, I am request ma'am to please start the talk, give us enlighten us with your talk on variants of concern. Thank you, ma'am.
Thank you very much, Dr. Rajnikant Srivastav, Dr. Samiran Panda, Dr. Sanjay Mahendrale. Am I audible?
Yes, please go ahead.
And my esteemed scientific colleagues, both online and offline, it's a real pleasure to be speaking at this symposium on emerging and re-emerging infections. I'll be talking about SARS-CoV-2 variants of concern, and I'm going to zip through the slides because we are very much behind time. So NIV was the first to publish the first 2 strains of whole genome sequences of SARS-CoV-2 on the 8th of March. And even then you could see that the 2 strains were quite diverse. There were about 240 sequences in the GISAID then, and these belong to the S and the L clade as per GISAID classification. In barely a week, this number of submitted sequences doubled literally, and still you could see the first 2 strains continuing to be fairly diverse so early in the pandemic last year. Now, for the purposes of everybody to understand the different nomenclatures, because of the diversity of strains, SARS-CoV-2 has been described by 3 databases, by the GISAID, which was earlier used for influenza, a next strain classification, which is mainly based on temporal dating. And today we have the pangolin classification, which has nothing to do with the animal pangolin, but it's a phylogenetic assignment of named global outbreak lineages. So these were the early clades that were seen in all over the world. And in India, our first 2 clades were S and L, L being the Wuhan clade. And then over time, over the whole of 2020, we progressed and it began to diversify more into a major clade known as the G clade. There was also the O clade. And G, many sublineages within that. This is the delta sitting here. The delta clade is also by next strain, known as the 21A, 21IOJ, and also known as the B.1.617.2. And what you're seeing here are the different marker mutations associated with the different clades as the virus evolved. Today, Omicron is known as a GR clade, and it is known as a 21K beyond 21J here. And its pangolin nomenclature would be B.1.1.529. So over the whole of last year, starting with the early GISAID clades of S, L, O, V, as I mentioned, it evolved to G and the sublineages within G. This is what last year looked like. And I would just take a little time to make a few definitions of variants. And a variant is a genome that contains a particular set of mutations. What are variants of concern? It is a variant that has been associated with at least one of the following: increase in transmissibility or a detrimental change in COVID-19 epidemiology, increase in virulence or a change in clinical disease presentation, decrease in effectiveness of public health and social measures, or decrease effectiveness of available diagnostics, the vaccines that are on board, or therapeutics, be it monoclonals, or now we have even antiviral drugs that are available. Variants of interest is a notch lower than a variant of concern. It is phenotypically changed compared to the reference isolate, has a genome with amino acid changes, which are associated with suspected or established phenotypic implications, which may be reflecting on a changing epidemiology, changing antigenicity, changing virulence, or changes that may again negatively impact on diagnostics or treatment or vaccine protection. So a VOI has also been identified to cause community transmission, multiple COVID-19 cases or clusters, and are likely to be detected in multiple countries. Another name for a VOI is also a variant under investigation. And then we have variants under monitoring. These are variants that have been monitored by public health agencies, but they do not match up to the criteria for either a variant of concern, a VOC, or a variant of interest, a VOI. And these may be variants that were previously designated as VOCs or VOIs, but have been downgraded by public health agencies because they have lost their significance has come down and they are not so much of concern. So this is an overview of the VOIs that the world has witnessed so far, starting with Alpha, that was first seen in the United Kingdom in September 2020. I'm showing you the head-to-head nomenclatures. They have a number of amino acid mutations. I'm just mentioning some of the key ones. Beta, first isolated from South Africa. Gamma, travelers from Brazil. And Delta, found from in our own country in October and later began to develop from December and really peaked from February, March onwards. And today we have the Omicron, which has many, many mutations and is seen over several countries. This is the most recent addition to this list. Then, of course, as I mentioned, we have VOIs, lambda mu, and then many variants under monitoring, which the WHO keeps monitoring, which may get upscaled to a VOI or a VOC or downscaled based on its epidemiological behavior. So in December of 2020, we realized that, yes, the World Health Organization has announced a variant of concern. That was the Alpha variant that had huge capacity to be transmissible then. We thought that was the end of the world. And the government very quickly came into forming an Indian consortium of SARS-CoV-2 genomic surveillance. It is also abbreviated as the INSACOG. It started with 10 regional genomic surveillance laboratories, of which ICMR NIV is one such. And we have feeder labs from other ICMR institutes and other VRDLs. And this number, believe me, is growing now. We'll have at least 13 in this category and maybe more ICMR institutes that will be feeding their sequences to us. We double check the sequences and then it will go on to the IHIP portal and eventually get on to the GISAID. And we see that this is following a hub and spoke model where we have the 10 key RGSLs followed by other labs and medical colleges that are joining. And we are at this point still contemplating the role of private labs, not yet in this consortium. So the first alpha variant was detected and cultured at the ICMR NIV for the first time. We were able to get 385 samples from different states of India, mainly returnees, UK returnees and their contacts. We found about 212 to be positive, of which about 36% had the so-called alpha variants or the alpha VOC. What we found is, yes, there were many mutations in the spike protein and particularly in the receptor binding protein, but one such mutation at the 501 amino acid position, which makes, and with that mutation, asparagine becomes tyrosine, that in fact caused increased hydrogen bonds and pi stacking. Sorry about that over writing there. But because of the increased hydrogen bonds, this resulted in better binding between, this is the ACE2 region that's binding with the receptor binding protein. Orange is ACE2, green is the receptor binding protein of the spike region of the spike protein. We found that compared to the wild and the mutant, there was enhanced binding. And we also know that with the alpha variant, yes, increased transmissibility was noticed epidemiologically. We also found that there were other variants that were found in the, again, this is the wild and the mutant. And when we look at positions, say 484 and 417, 484 being here and 417 being here, instead of enhanced binding, that binding was somewhat abrogated. We saw this with the Delta variant, and this, what you're seeing is again the receptor binding protein and the heavy chain of a candidate monoclonal antibody. So with reduced binding, as you see here, at both these positions, where the glutamic acid went to glutamine, and at position 417, lysine went to asparagine, what actually resulted was a poorer binding with monoclonal antibodies. So this kind of ribbon modeling gives you an idea of actually structurally what these mutations can do with regard to binding with the ACE2 or even binding with antibodies, which could result in antibody escape. Then came the Delta variant. The surge really began in end of February, and Maharashtra was one of the first states to report that surge with certain key mutations here. I'm highlighting them for you. It started in the Vidarbha region, and then we know the rest is history. Here is just a crystal structure of the spike protein. This is the receptor binding domain. This is the ACE2 protein. So mutations, not only the receptor binding protein, but at the cleavage site between the S1 and S2 of the spike protein, also not only increased transmissibility, but infectiousness of the virus. What you're seeing on your left is actually a heat map frequency with which certain amino acid mutations occur. And you can see here with the Delta, certain candidate mutations were seen at these different amino acid positions. And heat maps are used to see what are the mutations that are appearing with each variant of concern. And believe me, if you look at the Omicron, the number of mutations that are of intense color would extend to the entire length of the slide, literally. Many, many more mutations. So you can see the Delta variant taking off by about, started in December of last year, taking off really in February in Maharashtra. Rest of the country, it hadn't yet really peaked. but later on it peaked. And this B.1.617.2 is our Delta VOC, really hogging the show. You can even see the Alpha variant becoming very, very low in amount. This is the one in red, and this is Delta hogging the picture. These are some publications, and I spoke about the heat map. We know that there are some sublineages of the Delta, AY1, 2, 3, now we have up to 122. And again, in the heat map, you can see that some of the AY sublineages of the 617.2 or the Delta VOC starts developing additional amino acid mutations, not only in the spike region, but other regions of the genome. So coming to world data, today we know this GK is the GISAID nomenclature for the Delta variant. You can see it is literally hogging the whole slide. We are right up to December. Of course, the amount of data in December is a little less than the previous months. This is from the start of the pandemic. And if you look at the Pango lineage-wise, and you, as I hit the screen, you can see the alpha in red, the beta, which is in a teal blue, the gamma, which is in a deep blue, the delta, which is now in green, really hogging the whole global stage. And then now we have the Omicron appearing in royal blue. So I spoke about the Delta VOC, and it has many sublineages called the AY, AY1, AY.1 to AY.122 we have as we speak today. And we find that this has some geographical clustering. And when we look at different countries, in our country, it's still the classical Delta that is the big one. But in other countries, for instance, in Europe, it's AY.4. In rest of Asia, it's AY.29. But this is being mapped. They are collectively known as the Delta VOC. But this is a way of mapping the slight change in the amino acid makeup of the Delta variant, VOC. Today, when we look at what we have in December, we have the Delta here and Omicron beginning to assume significance. Of course, these are very few samples in the month of December. So Omicron looks far more magnified than it actually is. Really, Delta is still hogging the show. We come to India, where we have seen the second wave, how it went up, mainly the Delta being incriminated here. Our cases have come down. Now we are in the era of Omicron, and we need to watch this page. Again, India data showing Delta being the big player here, and Delta in this olive green, dark green, and this is the AY series, the subclades of Delta seen here in this very dark bottle green. And if we will just see an emergence of the Omicron coming here. So I think Dr. Panda had alluded to this. We were the first to have an EM image and the first isolate of SARS-CoV-2 in March of last year. And over the rest of the pandemic, Dr. Pragya and her team have been able to isolate not only the classical original strain of SARS-CoV-2, but the alpha variant, to be the first in the world to do so, other VOIs and viruses under monitoring, other VOCs. Here another VOC Delta, we were able to culture, and today we have a repository of over 300 isolates in the BSL-4. We also did interrogations of antibody escape, potential antibody escape against the alpha VOC. And when we compared it with the prototype strain of the vaccine, the Covaxin, we found there was no significant difference, at least with the alpha VOC, in terms of diminution of titers. When we came to the beta and the delta, both for those who were vaccinated and natural infection, these are the different amino acid changes. We found that with the beta, there was a threefold diminution of titers in those who were either vaccinated or had natural infection. With the delta, it was about 2.7-fold. So with these two VOCs, there was a diminution in antibody titers when vaccinees' antibodies were allowed to bind with these VOCs. We also looked at breakthrough infections while India has gone on to vaccinate, plodded on with vaccinating most of our country. And we analyzed some of the breakthrough infections, and we found that over 86% of the breakthrough infections were really Delta. That's not a surprise. Only 9.4% of these breakthrough infections in people who are fully vaccinated and recorded infections 2 weeks after the second vaccine were even hospitalized, and the mortality was very low. We also, I need to talk about the Omicron. Is transmissibility increased? Well, looking at South Africa, cases quadrupled. It's probably increased. Is there a severity of disease? Currently, no conclusive information to suggest that. Some suggestion that there have been increased reinfections, but this needs further monitoring. Effectiveness of vaccine, WHO is keenly monitoring that. But having said that, vaccines continue to remain critical to reduce severe disease and death, be it Omicron or anything else that comes along. The widely used PCR tests today do provide sufficient efficacy in diagnosis and effectiveness of treatment. Yes, corticosteroids and IL-6 receptor blockers continue to be effective in severe cases, and we need to look at the efficacy of Omicron against monoclonal antibodies and our antivirals today. These are just, again, ribbon models, and it looks very busy. Basically, the circles in pink suggest enhanced binding, circles in blue suggest poorer interactions, and if you look at the ACE2 and the receptor binding region, collectively, there seems to be better binding with Omicron and the ACE2 receptor. If you look at the binding of the heavy chain of a select monoclonal antibody, blue seems to be more in predominance, which suggests reduced binding. So collectively, with this select monoclonal, the Omicron binds a little less as compared to the wild or prototype strain. I would like to wind off with thanking my entire team at ICMR NIV. This was not possible. This is us giving you our COVID punch. Some of the key scientists that were involved with the study of VOCs and vaccine-related work. And thank you very much for your patient listening, both our campuses and the iconic BSL-4 that was much spoken about. Thank you.
Thank you so much, ma'am, for taking us through the nitty-gritties of vaccines of concern, which is a very hot topic in these days. Next, Dr. Pragya Yadav, as she's talked about, Dr. Priya has already talked about her in her role in variant isolation. She'll be doing the next talk on vaccine development. She is the scientist leading the Asia's first state-of-art facility to handle high-risk pathogens at NIV Pune. Her efforts and perseverance resulted in isolation of SARS-CoV-2 virus as well as its variants. She has played a critical role in vaccine development, doing the animal study. She has published more than 100 papers in this area, and she has been also she has played a vital role in the earlier outbreak investigations, be it Zika, Nipah as well. She has answered many unknown facts of virus and disease, which helped in strengthening the country's response, developing vaccines that made India self-reliant in this tough time. Ma'am, please, I request you to start your talk.
Thank you so much for introduction, and I'm really glad to hear the very beautiful insight from Dr. Mahendle sir, then Dr. Priya and Dr. Panda sir, and which really give insight of the ICMR journey during this COVID pandemic. But I'm sure that Gorakhpur is part of NIV, and this is something we have done new. But the remarkable thing is that we have done very fast. We have done in a huge scale, and that was all actually to the mool mantra behind the success of this ICMR's effort in this COVID pandemic. And I think we have to remember all through this journey in future, either it's research or any other aspect in the disease fighting, we have to be together, standing, holding hands of each other, then only we can get some success. And I'm going to just describe a few of the slides representing the work which we did during the COVID pandemic. And as we all know that, as Dr. Priya quickly defined the variant of concern, and which was actually 2021's highlight work from NIV and from all over the world, which fared the most. But in 2020, the main challenges, which was defined very well by Dr. Panda, the diagnosis and the developing different tests. And we could develop many indigenous tests in NIV, which can help not only in the diagnosis, but in the vaccine research that included even the antiviral SOPs and development of different ELISAs. And then in a time when we realize that this is not an outbreak, it's pandemic, we have to be having some kind of therapeutics or prophylactic in hand. So that was a vaccine, which was high demand. And then we did on different studies on different products from different pharma companies. And they also come up with some of the very good success story. But if we remember in the March when we were in a fear of the lockdown and we were keeping a very high speed to work on vaccine, there was many challenges. And the main challenge was to have the equipments, reagents, and the training of the new team, which we needed at the moment to surge our capacity and work. And also we have a lot of other challenges which came with the time. And with the help of everyone, we could actually we could reduce those problems, and we went on this journey. And some of the challenges was, the first was to have the virus in hand, because in virology, nothing happens unless you have the virus in your hand. And then once we have this vaccine product, prior to that, we should have animal model, their supply and their clinical trials protocols. And then during the second wave, we came across after the first phase of the vaccination, the breakthrough cases. And then new variants arrived, and then you have to see the pathogenicity, isolate them, and look at how they are working on the vaccine. So these were the main challenges which we deal with thought, and we work day by day, each new plans, new studies, and that's how we went ahead. As Dr. Priya quickly described, that we isolated the virus, and this virus was used not only for the vaccine, but creating so many different assays, supplying to so many pharma companies and other people who are working in the same direction in the benefit of the country. And the huge bulk of the virus was produced by a team of the member. They work around the years making antigens, growing the virus in a very, very huge quantity, which is really, I think, is an impossible task, which I never thought in the earlier time. So as we all know that there are so many platforms used for a different vaccine that included whole inactivated vaccines, recombinant viral vectors, bacterial vectors, DNA, recombinant subunit vaccines, synthetic peptide, live attributed. And we came to know this time the messenger RNA vaccine, which was produced by Moderna, Pfizer. There were many vaccines came in the race, and 8 of them has got emergency use licensing from WHO, and Covaxin is one of them. So in the time of the interest and need, it was decided to go for a inactivated vaccine quickly, and we collaborated with Bharat Biotech, and the work started quickly in April. So this Bharat Biotech has a GMP facility with BSL-3 infrastructure where they can make the bulk virus propagation. Generally, different adjuvants has been used in different vaccine platforms. In co-vaccine, initially there was 2 kind of adjuvant was planned, the LGEL and then LGEL plus IMDG. And we realized very quickly with the small animal studies that IMDG was sufficient enough to not only give the antibodies plus cell-mediated response, and that really helped these vaccines to work better. So once we had this formulation made by Bharat Biotech and characterized at NIV, prior to that, we did a very thorough investigation on the virus isolate, which we did in March second week. And we got 11 isolate. They were completely characterized on different platforms, including their transcriptome, their studies, how they are responding, what is their titer, what kind of stability they have. And we found that one of the strain was doing great, and it was decided to use them. Once the formulation was ready, it was tested in NIV on different platforms. The stability was tested, and we could fix that which one is the best to use. Initially, there were 3 formulations that included 3 microgram antigen, IMDG plus L-gel, and 6 microgram formulation L-gel plus IMDG, and 6 microgram with only L-gel. Currently, whoever has taken the co-vaccine, everybody is getting the second formulation, 6 microgram with L-gel IMDG, which was used in phase 3 and then further immunization in the country and abroad. 3 different animal models use biopsy, rabbits and also the rats, and they found that the vaccine was giving a very high immunogenicity, and also it was quite safe to be used. And this data actually boosts our further studies on non-human primates. DCGI came up with the rule that everybody who is trying to develop vaccine, they have to show the non-human primates data, and after that only the phase 3 data trial will be approved. So it became a very compulsory task to do. And so we went ahead, we planned this study, but there are many other challenges in the country that, like, we didn't have a non-human primate breeding center where you can have this pathogen-free animals. So we took all the approval which was needed at the moment from CPCSC, PCCF, and we captured these animals from forest. And it was a lockdown period, so even capturing monkey was quite a task. But our team, with the help of PCCF, could manage. We had 20 animals in this study, and they were given intratracheal and intranasal inoculation of the virus. But prior to that, they were immunized at 0 and 14 days with these 3 formulation, and there was 1 group kept as a placebo. After 28 days, they were challenged with the virus by intratracheal, intranasal route. Samples were collected as 1357. This is India's first study where non-human primates were used for such a study in a high containment facility like BSL-4. So we had a lot of things to change. There was not only the engineering changes, training the individual, including the new members from armed force medical colleges, and training our veterinary team, aligning 5 different teams to work together day and night so that we can have data on time and we can quickly release this data for the public domain. So different samples were used. They were monitored using different clinical parameters, which is defined for the COVID, that include temperature, immune responses, viral load, histopathology, and cytokine profile. We could see that after the immunization, antibody and neutralizing antibody could start raising in 3rd week of these immunized animals, but there was no response in placebo group. And slowly we could see that there was very high titer after we challenged with the virus. And the IMDG and plus L-gel group showed highest neutralizing and antibody titer. Further, we looked at the similar kind of response for the neutralizing antibody. When we tested after 7th day of challenge, when these animals were sacrificed, different tissues were collected. The most interesting data was that virus was present in different body parts and tissues, in the lungs, in different lobes of the lungs. But in the immunized animal, it was clearly negative. And that's given a very high confidence the vaccine is going to give a very good protection to those who will have 2 doses of the vaccines. And this study, there is a lot of details on this study, which even DG sir has highlighted in his release of the book Going Viral, and you can go through. And I quickly go to the next study, which we did, where we given hamster 3 doses of the vaccine at 0, 14, 35, and they're further challenged in a containment facility with the virus. And we found that those animals who are having immunized, they were protected and they didn't show the lung pathology as it was in the placebo group. Further, this study boosted the confidence on this vaccine. And among these, the 3 microgram and 6 microgram antigen with IMDG given a very good virus clearance, protections, and immunogenicity, and that was chosen for further clinical trial. In phase 1 and phase 2 trial, 375 participants were used of different age group, and 3 vaccines initially used, as we did in animal group. 75 were a control group, and we could see that there was 82.3 to 91% seroconversion. In the phase 2, where we looked at the immunogenicity, we found that 6 microgram showed a very good seroconversion, and that was chosen based on the animal and the phase 1 and phase 2 trial data. The choice of the dose was 6 microgram with IMDG. The phase 3 trial is one of the unique trial in the world, because this was the highest number of the participants in one single trial, which showed 78% efficacy against mild, moderate, and severe COVID-19, 93% efficacy against severe, reducing hospitalization, and 63% efficacy against asymptomatic transmission against the COVID. All these studies which I'm talking is published and in a public domain, which we can look at. So these are the different sites which were used for phase 3 clinical program, and that represented a huge geographical area and ethnicity of a country to have a confidence in the data. These people were followed for 6 months, and they were sampled to look at how the vaccine efficacy is, and we found that vaccine, even we could analyze the specific efficacy against Delta, because this was the time when the second wave tsunami was there, and the cases under placebo and vaccinated group were counted for the breakthrough and infections. So if we look at the maximum people got infected with Delta, that is 60%, and others, Kappa and Alpha also, some of the presentations were there. So if we look at this journey of the vaccine, it is done, the virus was isolated in March, and we had the approval in January for emergency use by DCGI, Indian government. And then in June, we got phase 3 trial data and now November 3rd, we had this vaccine approved from WHO. So that's one of the landmark achievement of ICMR in the history of viral diseases. And I assume that we will be able to do or demonstrate similar kind of performance for other viral diseases where we can control by developing a vaccine. But as soon as this journey was going on, as Dr. Priya ma'am has described recently, that in December there was surge of cases of Alpha variant in UK, and that given another kind of hit to us that we have to do more isolation of the virus, and we kept this isolation work continuously. And these different virus isolated, that included all the variant, and currently we are making efforts for Omicron. We could have all the variant of concern investigation, and that help in different studies against Covaxin, Covishield, Sputnik recipient sera, and we could demonstrate the data to confidence in our vaccine. So first, initially, we did isolate the Alpha variant, and we could demonstrate its effectiveness. Similarly, South, we could isolate Beta, Delta with the time. These were done with the different foreign travelers arrived in Delhi and Mumbai and from other different countries. And continuously, we made this effort, and more than 5,000 samples were processed for only virus isolation, and we could get around 300 isolates. They were characterized. They are kept in NIV's repository for future use, and currently we are using many of them. So if you look at the response of these variants on vaccine recipient sera, initially it was only naturally infected individual, and then the vaccinated 1-2 dose. But after a while, when the second wave came, then we had breakthrough. We have recovered cases specimenization, and it was a different category of the individuals who were there to study. So we have to plan different studies, and we set up a co-vaccine vaccination center where we in Aum, and we could enroll the people in the study, and we could use their sera for different studies. And Alpha has no impact on the Covaxin efficacy. In fact, those vaccinated individuals showed better in neutralization capacity in compared to the naturally infected groups. Similarly, we work on the Zeta variant, and it was also, though there was 2-fold reduction, but the titer was so high that it still can work. As soon as the second wave arrived in our country, we have initially Kappa variant, where we could demonstrate that it is having 2-fold reduction in the neutralizing capacity. And then further, this data was quite discussed around the world, because this was the first data came from India, and then later on many people followed on their vaccine. Similarly, we also work on the beta and Delta variants, and we could demonstrate that vaccinated individuals have the lesser reduction in compared to the naturally infected individuals, and the vaccination definitely protecting individuals once they have the 2 doses. Similarly, when we have the so-called Delta Plus, which was called later on Delta derivatives, which Dr. Priya shown a range of the Delta AY variants slowly mutated and presented, and we could show the data with the Delta AY1, that was first one, that there was lesser reduction in the immunized individual compared to the recovered breakthrough cases, which again boosted the vaccination program to be must in the country. So if we summarize all different variant of concern, except Omicron, which we need to do, they have been very good protections and they have very good neutralization capacity. In January, Government of India has approved 2 vaccines, Covaxin and Covishield. We did a study on Covishield and Sputnik vaccine. For the interest of time, not presenting here. At the moment, 13 vaccines are in clinical trial, and government has approved Zyco DNA, messenger RNA, Sputnik, Johnson's, Oxford, AstraZeneca vaccine in our country. We also did work on Zyco DNA non-human primates model and published this data as well. There are 8 vaccines which is approved by WHO, and our vaccine was not only the Covaxin, but Covishield was distributed in different geographical area of the world, and it is being used to fight this COVID war. At the moment, Dr. Panda sir has just presented quite a variety of vaccination, how it is India, but in a nutshell, 50% adult population is vaccinated, which is around 98 crore in our country. And this is the kind of representations where how and UP looks very good for the vaccine coverage. So I really congratulate all of you for very good vaccination regime to be followed. During the second wave, when we had seen the people who were having 1 dose or 2 doses, suddenly they get infected, but it was not the India. But many countries reported the breakthrough cases. Then there was challenge to see how these breakthrough cases are happening and what must be impacting. So I with Dr. Niveta plan a study, and then we enrolled 30 sites of VRDL, where we collected a specimen of those individuals who were having infection after 1 or 2 doses, and we found that those centers. So this is a phase of vaccination. In different 4 phases, government approved this vaccination program. We did this study during March to May, which was the peak of second wave. And we sequenced a huge number of the data, and we could include the finally clean data with the clinical details, 677 and data analyzed. And we found that those people who had 2 doses of the vaccine, they didn't land up in hospitalization, they didn't have the death, they didn't have the severity. So that was a great kind of basis to the community that, yes, you have to take vaccine. It is working still, as it was presented by other speaker as well. And we could see a high prevalence of Delta variant the same time presented in green color in different part of the country. And in the only northern part, we could see presence of Alpha and Kappa variant in a very low density. So we could see the same time that Delta variant was dividing in different forum, and it already formed sublineages 1, 2, 3, 4, which further developed and make the Delta derivative mutations. Similar kind of study we also did with NIH Chennai with Dr. Murekas's team, where we could look at the breakthrough cases versus non-vaccinated individuals to see if there is a genomic changes, if what is happening to those individuals, their clinical impact, their viral titer. And we could see in nutshell that those people who has 2 doses of vaccinate, further there was no death, there was no severe hospitalization, or there was no mortality. But in case of unvaccinated group, we could see the death and also severity and hospitalization. Further, in Chennai also, we could see Delta was mutating very quickly, and there was 4 sublineages already formed in May month. One of the study which I consider is one of the landmark study in during this pandemic, which was done in a very quickest time, and I congratulate Dr. Rajnikant sir and his team for working with us in a very short time and to achieve this target, and that is the immunogenicity and safety of a heterologous prime boost COVID-19 vaccine schedule. In Uttar Pradesh, there was a news that a group of people who got first Covishield, by mistake, they were given Covaxin, and that news came. I called sir, can we do this study? And immediately he got agree, because we don't know how this heterologous regime of the vaccine is going to work on these individuals. quickly a study was designed where we have homologous Covishield, homologous Covaxin, and heterologous group of these 18 individuals. They got both the vaccine. And the samples were collected by Dr. Rajnikant's team, and they were evaluated here, not only for the immunogenicity, antibody response, but also immune profile. And we could see that we did not see any kind of adverse event happening in those heterologous group. Similarly, we also looked at AFI, different parameters, and we did not see either of these high impact on these individuals as well. When we look at the IgG titer against S1-RBD and nucleocapsid, and also for the complete antigen, we found that heterologous group was having a very, very high titer in compared to only Covishield or only Covaxin group. Similarly, when we looked at their neutralizing titer against variant of concern, that included alpha, beta, delta, and we found that they showed a very, very high response and low reductions when we treated B1 versus variant of concern like delta and beta. And if you look at here, it was quite lesser response in heterologous group. So that study gave a really confidence that even this kind of clinical trials should be done in our country. And in fact, there is one clinical trial already going, and that data will definitely help if people can have the heterologous vaccine in coming of future or for the booster doses. So that's one of the very leading story of the vaccine, which I consider. And we further even evaluated these samples for age match control, and we found that in heterologous group, we could see a very good neutralizing antibody response. In heterologous group, we could also see a very good titer, and also there was a very good response for the immune system as well, where we could see the different parameters of immune system that included CD3, CD8 T cells, and they suggested that there was no major change in generalized cellular immunity among the vaccinated groups. So though the sample size was small, but it definitely gave a very good message that booster or the heterologous combinations can be used in our country in future. And we did not observe any major systematic AIFE, and their reactogenicity profile also was safe, and the humoral immune response, and they all gave the same kind of a message that this is a safe method to go. So during the COVID, we could publish 110 papers exclusive on COVID studies, and this was not possible without a great teamwork, which not included BSL-4. But we work with each and everyone who are willing to participate in the study or who are working to give a hand with their expertise. That included my three scientists, Dr. Reema, Dr. Anita, Sri Lakshmi. They worked very hard during this pandemic and to achieve this target. I must thank my technical team, who most of them are ladies, but they work continuously during this pandemic. A number of the scientific team that included Dr. Chidis from headquarters, Dr. Dilip, a veterinary group expert, Basaraz veterinary, and Dr. Gajanan, who is my collaborator in most of the study, and his team, they got trained to work in a BSL-3, and we work here in our campus in BSL-3 facility of BSL-4 continuously all 7 days. Dr. Himanshu, he did help in immunological study, Dr. Guraz on the PRNT, Dr. Gokhale, being such a senior member he was always with during our non-human primate study. Dr. Deepak, he came and joined during the pandemic to work on a lower position with us to help this country. I must thank Dr. Priya for continuous support in tough time. And during this study, we have two external experts from Command Hospital and AICTS, Colonel Sanjay Kumar and Major Gaurav Bhati. And this cannot be over without thanking our Director General, Secretary DHR, Dr. Professor Bhagwat sir, and his constant support, motivation, and guidance. We could do a number of the study. I presented only 20% of the data which we did. We have done plenty of pathogenicity study in hamster model. We have done a beautiful study on Zydus monoclonal study, which is published this week only, and many other study, which is relevant and timely we could do because we work really all through the time. We could receive a very quick response from Dr. Panda whenever needed on our manuscript approvals timely within a day. And Dr. Niveta, she worked with me all through this pandemic on different study protocols and taking help of all the VRDLs. I'm very thankful to Bharat Biotech. They were very good scientific partner for doing this co-vaccine studies and further their effectiveness study. And I also thank so many other collaborators from different institute of ICMR, including Dr. Borekar and Dr. Rajnikant sir. We did a wonderful 3-4 study with their groups. And I see a lot in they can do a lot of good study because North India has a lot of scope to work. There is untouched area and different diseases platforms are there. So I wish all the best on this great occasion of inauguration of the new building by Prime Minister of the country. And I look forward to work with your team and to provide any support, whatever need at technical scientific level. And I thank each and everyone in the team during the COVID. It was one of the most difficult time, not only for us, for the world, and we could perform, we could survive. That was the most important thing. We have to do so many measures, biosafety risk assessment, weekly screening, so many things to do that our team doesn't get affected because we need to enter to the BSL-4 facility. If we are infected, we can infect whole environment, we can infect our animals, and whole study will get compromised. So it was a huge war, and I'm glad that we could survive this, and hopefully we could also survive to Omicron and we could do it well. Thank you so much for the opportunity to present here.
We all know the hard work we have done during the COVID pandemic, and congratulations for the award which we have just received from the INSA. Thank you so much. As we are running short of time, we are very, very behind the schedule. So I will request all the speakers, please stick to your time, whatever has been allotted to you. So now my proud privilege and honor to invite Mr. Kaushik Bose, who is going to talk on the risk communication. I will request Tina to brief about the Kaushik Bose.
Dr. Rajnikant.
Yes.
Subir here.
Dr. Subir.
Yeah. I have a meeting for 40 minutes, 45 minutes. So I'm sure in between, you will break for lunch, I guess.
Yes. So what we are planning ki after Kaushik, I will request Dr. Sang Mitra. She also has a meeting. So we will start with Dr. Sang Mitra. We will break for the lunch. And after the lunch, when you will be available, then you can start.
No, it's okay. When will you finish the lunch?
Okay, after 2. After 2, no?
So I will join after 2.
Very good.
So meeting
after Kaushik, I will request Dr. Sang Mitra. Then we will have a lunch break. After lunch, then we start with you and Manju.
Correct. Done, sir. Thank you.
Okay, thank you so much. Thank you.
Thank you.
Thank you, sir. Mr. Kaushik Bose is Vice President in GHS India office. Yes.
We believe in the brief. Try to be brief in the.
I'm trying to be brief.
I think
let us say some 2 lines.
He has vast experience in the area of strategy planning and communications. He has been working with ICMR for the past 3 years, and he has played a very crucial role in all the communication activities that has been done through ICMR communications team. Please, Kaushik, I request you to.
Okay. So I will be the briefest speaker here. I don't have a presentation because I was under the impression that this is going to be a panel discussion. So I haven't prepared really in terms of a speech, but I would really like to engage every one of you to just start off with a quick question, which is, if you are, say, the government's communication manager or the communication manager of COVID-19, what is that one thing that you would have done differently? Anybody can actually respond to that. And I can't give a lot of time, so would request quick one-liner from everyone, if possible. No one?
Restrictions of flight from infected countries.
In terms of, you wouldn't have done it or would have done it?
I would have done it if I would have the opportunity to do that.
Okay. In terms of communication, is there anything that anybody would have done differently?
NCOs here?
No, I'm just asking. I'm talking to all scientists. That's an advantage. I don't have to talk to the communication officers. Any?
Can I say something? Can I say something, sir? I'm Amita Jain from KGMU Lucknow.
Yes.
I would have blocked the social media, especially WhatsApp. They have been confusing people and nothing.
Okay, I've got the answer. Okay.
You were saying something?
Please restrict or clarify the false information.
Yeah, miscommunication.
And not to propagate the vaccine hesitancy.
Okay, so
one point I would like to make, during the pandemic, there were so many experts in the country, and the public has a lot of free time to read each and every, and I think it was very pathetic and scary, making them scary feeling. So if we could have control on their speech, who to speak and what to speak, that could have been given a lot of better performance of the individuals as well.
Understood. Anybody else? Yes. Okay.
Sir, this is Milind Gore. Sir, this is Milind Gore from NIB, retired NIB. So one of the question is, we are not answering the simple methodology to detect the T-cell response, that is one, and the affinity of the antibodies which are produced in morbidity kind of group or normal kind of people. That affinity maturation has to be done as quickly as possible. It's a basic immunology, nothing epidemiology.
It's very scientific to that matter. I'm not a doctor here, by the way, and I'm not a scientist. I look at communication per se from a very layman's point of view. So, and I understand ICMR in past 1 year has gone through ups and downs in terms of communication. There have been a lot of criticism, a lot of accolades, a lot of appreciation of ICMR. There have been sections who have actually come out and actually said that ICMR has done a great job in terms of communicating what they have been doing. So from those learnings, what I would actually peg on is Dr. Panda's, and he is not here. What he mentioned is what is important is communication, how you're disseminating information, and community engagement. And while we are talking about these three pillars, we have to remember as scientists, we need to actually build three T's. We should be working on three T's, basically to develop trust, be transparent, and follow a timeliness pattern of communicating. So those are three T's which you should be actually looking at. Science in India and public health in India in general is something that people have traditionally not believed in as much in India, and it's always seen with a little bit of suspicion in terms of science, wherein the science is something that actually plays a crucial role in a pandemic situation like this. Wherein I think what we need actually, and this would be a nice open discussion in terms of how scientists can become a little better in terms of risk communication, in terms of how they need to actually look at community engagement, because public is finally what you are trying to target, and they do not understand science as much as you do. You are the expert in this field, and you need to actually reach out to the public as and when needed to actually prepare them in terms of how they can understand the disease better and take the interventions much better in future. So how do you do that? Anybody wanted to say anything?
No, sir. One thing is, I asked this question because despite of the vaccination rate in Europe and America and all that, despite of that, the second, third wave is reaching the peaks now already. So that's why these questions were coming. So anyhow, that's okay with
and
me.
I understand where you are coming from. In the break, I was actually telling Dr. Sanjay Mahendale that he actually presented a slide saying there are still unanswered questions. And those questions, honestly speaking, if you keep them unanswered, the media will actually have a great time actually pulling you up. But the thing is, we need to actually respond when science and evidence can back your statement. So as scientists, you need to be transparent as possible, wherein the science can actually help. Coming to the other point of social media, there is a problem of infodemic, and it is not only for COVID-19, but it's across the world on various topics. If you go and actually say want to review an iPhone 30, you will find there is infodemic in terms of some will say it's a bad phone, some will say it's a good phone. So it's not related to COVID-19, but remember, social media is the practical or reality of our world, and we'll have to accept and work within that system. How, as scientists, we actually respond to these social media misinformation and disinformation, or how we actually address those myths is something that we should be very clear about, because truly speaking, social media has also played a major role in terms of communicating the interventions which helped us in dealing with COVID-19, from mask wearing to distance, keeping distance, to various other things. So, I mean, social media also has a positive side and there is a negative side. And I think we need to actually recognize that and play around this. So quickly, if I want to summarize in terms of the things that you need to prepare for a risk, is basically in terms of keep your firstly build trust in science. That is one major thing that all scientists should actually work upon, in terms of make the public trust in science, because that is the only way to go. The second thing that you need to look at is have credible spokesperson in your today Dr. Panda has emerged as one of the most credible spokesperson for media and for various other things. Dr. Balram Bhargav has been doing that for a very long time. But you need a spokesperson who you can trust and who's transparent. Be consistent in whatever message that you are relaying. And again, as I said, 3 years back when we started working with the group of ICMR Institute I used to start by saying that you cannot fear media. You have to work with media and actually make them your partners. Today, I will also say that start digital literacy in the organization, because technology is not your, bane or foe, or, you can't be seeing social media or websites, or it has to be, so your digital literacy will help in terms of how we are going to leverage technology across this communication spectrum. One major thing is you have to sustain your media engagement, and something finally which I need to actually stress upon is the aspect that Dr. Panda actually spoke about, is intersectoral partnership and cooperation, where you actually work with the community far more closely in terms of communications, because you are at the position where you can actually interview, survey, understand where the misconceptions are and how you can address them. So working with the community in various other countries, well, smaller countries, they have actually done tremendously well. In India, during this pandemic, we have done to a certain extent, but we do need to do a lot more community engagement when it comes to, reaching out to the faith-based organization, faith-based leaders, community in general. When you're looking at various places where you can actually make an impact, you need to actually talk to them and make them understand their misconception, which you can address. So I will leave at this because the time is short, and as I said, I will be the briefest. But I would really like to understand if there are questions, apprehensions about communications that you have, and try to mitigate it if it's possible. Thank you.
Thank you so much. So we will break for lunch right now for half an hour. It is 1:25, and sharp at 2. I request all of you to please have your lunch and come back sharp at 2, and we will start the session 2 on One Health. And Dr. Subir is available, Dr. Manjura and Dr. Sanmita. So they will give the talk, and followed by that, there will be a session 3 on impact of climate change and vector borne diseases, and 4 on GIS AES. So I request all of you to please join for lunch in the backside of this building. So all the arrangements are there. We have to go there.
सोचना है ना, इसके बाद मैं यहाँ नहीं जा रहा
We are starting with the session 2 on One Health. Sorry for the bit delay because of the time consumed in the session 1. So the second session is on One Health, upcoming areas of research. The first speaker is Dr. Subir S. Majumdar. So he is a former director of the National Institute of Animal Biotechnology. He is going to speak on the overview of One Health Consortium in India. So RMRC Gorakhpur is also one of the partners of the One Health Consortium funded by the DBT. So again, there is minor changes. Dr. Subir is in a meeting, so he will join at 2:30. So Dr. Manju Rahe is available. So I will request Dr. Manju Rahe to speak on the ICMR initiative in the area of One Health. So I will request Dr. Ina to brief about Dr. Manju Rahe. Over to Ina.
Dr. Manju Rahe is a scientist at Indian Council of Medical Research and is a public health specialist by training. She is a nodal officer for coordinating research activities on a vector-borne disease like malaria, hepatic fibrosis, visceral leishmaniasis, and zoonotic disease at ICMR. She has been associated with and contributed to efforts towards the Institute of One Health at Nagpur. She's steering many research programs having policy implications in above-mentioned research fields. So I request ma'am to please start your talk.
Yeah, thank you, Ina, and good afternoon, everyone. I thank Dr. Rajnikant Srivastava to invite me over this meeting, and it's a pity I could not join physically. And it was very hearty to see the pictures yesterday of the inauguration. And I think it's a very momentous event yesterday, and it's a big achievement for ICMR to get our institute getting inaugurated by Honorable Prime Minister and in the August gathering of ministers, and it's a big event. So my heartiest congratulations to the entire RMRC Gorakhpur team in the leadership of Dr. Rajnikant Srivastava. It's wonderful work, and in such a short, tight time period, this institute has come up. He has seen us struggling with one, and he's correct. One really has to be really pushy in the matters of how the government sector moves, because there are so many bureaucratic approvals and processes which require a lot of energy to be driven. So I think it's gone very well. And I'm really sorry I could not join earlier this symposium, because in the first half that regional research platform meeting was going on. So once again, I thank everyone for having me. And today I'll just deliver a very brief talk on just giving an overview what is happening at ICMR as far as zoonotic infections research is concerned. So Ina, I think Payal has emailed you the presentation. Is it possible to share that?
Yes, ma'am.
Anyway, so by the time it's getting shared and coming on the screen, I'll just give a quick background. And I think after COVID-19 pandemic, the phrases like One Health, zoonotic infections, and bats and animals, they have come into forefront, and they have really taken into consciousness of people that we are impinging on the environment and the wildlife and the animal health. And actually, One Health is just not a phrase, but we really need to do something about it. And One Health many people have asked, what is One Health? ये सबकी health है क्या? Animal की भी, human की भी. So basically, it is One Health. And in fact, there is a very good journal with that name, One Health. So we have published a couple of papers also in that. So which is targeted for diseases, work on One Health, where all the partners like wildlife, human health, animal health, veterinary sciences, climate, environment, all these sciences come together because there's a lot of interface activities for human diseases. Human is not living in isolation. We are affected by an environment. So that's how all these parameters need to be taken care of when we talk about human health and transmission of diseases. So human cannot, we not survive alone on the planet. So having said that, that's a concept of One Health where all the partners and stakeholders, they converge at one single platform. And I think today is the occasion where Dr. Rajnikant has, kind of accumulated everybody from different backgrounds. I can see Dr. Deeman and Dr. Srivastav here from LF and from climate change. Dr. Deeman has been totally into it. So it's a very good kind of a galaxy of our star researchers and star scientists here. And it's wonderful. And so moving on by the time again, but moving on to the slides will come. I'll straight away come to the concept of One Health and how ICMR has been struggling from past many years, I think now more than a decade, on establishing this One Health Institute. Finally, with this COVID and our Honorable Finance Minister announcing an institute which has actually sealed that we are moving ahead with it. And even before that, we are working very closely with Maharashtra Animal and Fishery Science University, and they have given us 4 hectares of land to construct this institute. So earlier it was supposed to be a separate institute in zoonosis, then it became more broader on One Health. And so now this will be a satellite center of NIV Pune, a dedicated facility for research on One Health, capacity building, which will have BSL-3 and BSL-4 laboratories. So this institute will be housed in Maharashtra, in Nagpur. And in fact, 2019 August, Dr. Rajnikant and myself were in Nagpur. Prime Minister was supposed to, do the foundation stone personally, and somehow we could not get it done. But the institute has moved ahead, and with the Finance Minister's announcement and approval under Pradhan Mantri Atmanirbhar Swasthya Yojana, this has got a new impetus and moreover more of funds. So this One Health Institute will be a boon to the country for capacity building for this novel emerging infections, for even endemic zoonotic infections. So this is about, the slides will come, so I'll skip those because I've informed the group where we are currently on it. NIV Pune is taking lead on the development of the institute. Now, thank you. Now coming to the One Health, can we go back? No, this was not about One Health Institute. Can we go from the beginning? I'll be very quick and brief. So next slide, please. So I think this audience doesn't need a briefing where all ICMR's footprint is in the country. So we have 26 institutes, and this is the layout on a map. We are focusing on many of the health issues. So this is the basic from NCDs to communicable disease, definitely is large around consciousness. Next. So we all understand the importance of zoonotic infections. All 70% of all the emerging and re-emerging infections will be of zoonotic origin. So that is very evident from Nipah, Zika, now COVID-19. So it's time we should pay attention to the animal aspect of human health, in the sense where that should be curtailed. And One Health essentially is intersectoral collaborative mechanisms. And so where all these health sectors or all these different sectors are partners. Next. So this publication is, I have borrowed it from Dr. Maurya, and where these new infections are emerging, and India is a hotspot. It's a biodiversity hotspot from that angle. So all these emerging and re-emerging infection map is in front of you, and we should be keeping a very tight vigil on the emerging infection, as NIV has all the capacities. So now it is COVID, which has come, SARS-CoV-2. So coronavirus were there earlier also in the world. So this is a new variant or a new virus. So that's how we will proceed. Next. So we have seen in the past avian influenza, SARS, MERS-CoV, now COVID-2, and Nipah virus, then Ebola, CCHF, KFD have been with us from a long time. Now they've become endemic, and in fact, new areas are being identified where these infections are present. So these are all the viral infections which are emerging and re-emerging, and they have zoonotic origin. Next. So these 13 zoonotic infections have been identified in the literature, which have animal reservoirs, which are important from a human disease angle, and they are not in any particular order of priority, but these 13 diseases we work very closely on from ICMR side, and maybe more work is needed, and we would want to take up a lot of work on endemic zoonotic infections like brucellosis, echinococcosis, toxoplasmosis, Q fever, rickettsial infections. There's hardly any buzz around these infections. We do the research work, but that's how it is. Researchers will publish the work and it will die down gradually, but maybe we need dedicated national level programs to assess the burden, having a surveillance structures, and then launching control programs. Next. So these are the gaps which have been identified in zoonotic infections. There is non-availability, absent surveillance mechanisms or surveillance structures for these diseases, as I said earlier. So as a part of research, we have been tinkering along on these diseases, but there are, for most of the diseases which I showed earlier, there may not be dedicated programs from Ministry of Health and Family Welfare side to address these issues. And also the lack of diagnostic methods, especially point of care tests are not available. Laboratory based, very special or very sophisticated molecular tools are available, which are costly in terms of funds, which are costly in terms of expertise and infrastructure to be required. So these are the gaps. There is limited sensitization and prioritizations even by health authorities and the clinicians. How many of the doctors are suspecting brucellosis when they are seeing a fever patient of anorexia of unknown origin or acute febrile illness? The sensitization of the treating physicians is limited. So that's why they don't get diagnosed. And it's something like, Lyme disease or strep typhus or rickettsial infection. The moment we start looking for them, we find them. But until unless we do an active search, we will ignore them. Or they will be a differential diagnosis only, and they'll be, part of AFI bracket. So there is lack of preventive control programs, as I said earlier, and the novel pathogens will keep on emerging. So we need to keep a tight vigil on the novel pathogens. Next. So as I talked about that, these are the One Health approaches. And so the WHO definition is taking program, policies, legislation, research. These are the multiple sectors and which will have an impact on all these legislation and research. So they work towards a better public health outcome. So when we say public health outcome, basically influencing human health. But we need to take other paradigms of environment like animal and environmental conditions and animal disease, wildlife, veterinary. They are working towards better public health outcomes. So this is essentially towards human health. Next. So I talked about One Health Institute. We can quickly go through the slides. Next. So as I said, this will be interdisciplinary. Next. And capacity building and biosecurity preparedness. So this is again, as I said earlier, it's in Nagpur. We got land. It's got incorporated in Pradhan Mantri Atmanirbhar Swasthya Yojana. So we have also completed our pre-project activities where Dr. Rajnikant was visiting in Nagpur. We saw the land where the boundary wall has been constructed. It's also an action point for the World Bank as COVID-19 emergency response package. Next. And in addition to that, we have also formulated a high-level interministerial steering committee, where the minister, Honorable Health Minister, is the chairperson, and all the concerned departments are members of this committee, which will be monitoring the progress of this institute and the activities within. Next. So this symposium was organized on 12th of April. And this was chaired by our Honorable Health Minister, and DG ICMR was at the helm of affairs. So this had a very good participation of all our stakeholders. And the logo was also launched on that day. Next. And this special issue of ICMR was launched on the same day, where very pertinent research papers on One Health have been published. Next. So coming to the research activities of ICMR, which personally I've been driving, in the sense like, then I'll come to the NIV activities, which have been going on from past, let's say only a couple of years, but I'll go more back in time. So this is a very timely task force studies, multicentric study on Lyme disease, which is again a Borrelia infection spread by a tick, a deer tick, and again like rickettsial infection. The moment you scratch it, we will find it. Earlier in the literature, only reports from the Northeast were seen, but now even coming from hilly region and from Kerala, we have received isolated reports on Lyme disease. So we have launched this multicentric study with all these partners. So you can see on the map, multiple medical colleges and ICMR institutes, and AIMS has come up with laboratory support on this in this study. So hopefully we have launched it, but because of COVID, a lot of work was hampered. But now, just I think last month we did a first training on laboratory methods. Next. So this is a very, I'm very passionate about schedule. People do not complete the schedule, especially the 28-day, because see, people, dog bites, people get very afraid of the dog bite and they will go to the health facility, take a vaccine, but that sensitivity decreases with time. And India has a checkered history of not completing the schedule of the immunization. So the 28-day dose, that means the current schedule goes up to 1 month. So WHO is recommending a shorter version of the schedule, that within a week we can complete the schedule. And in other countries, the literature shows that the antibody titers are protective. They are neutralizing antibody titers. We can complete the schedule within 1 week with the protective antibody titers. So should India be also adopting that regime? So we spoke with NCDC. They are a little skeptical of adopting it without any evidence, which is right. So NIH Chennai will be generating that evidence of, what are the neutralizing antibody titers after 1 week schedule of 037 vis-a-vis the 28-day dose. Can we afford to skip the 28-day dose is a very crucial question. And this study will generate that data. And once that data is available, again, because of COVID, the study was pending and, no field work was able to done. In this study, we need to enroll volunteers, to see the schedule, and everything has been done. The study has been rolled out, and this data also will be available very soon, which will have direct implication on the policy of immunization schedule for rabies. Next. Can we move on to the next slide? Thanks. The study Dr. Sanmitra has spoken about if she had the session before me. This is on anthrax, and this is again a very crucial study on the mitigation and on the control program of anthrax. Every year we will see sporadic reports in the newspaper, because the tribal population has very close contact. Which have suffered from anthrax. This study has a very paramount importance. RMRC Bhubaneswar in this state government in laboratory structures, laboratory capacity to diagnose and for training and in capacity building and in sensitization of the tribal communities for mitigation of anthrax. They have also published a policy paper, and they have come up with a white paper or a policy brief, which they have handed over to the government. Next. Next. Last, and this was a multi-sectoral in the meeting. And also there was an effort towards from lab to field to community sensitization. Next. Next slide, please. Well, it's about to get over, Dr. Rajnikant. I'll stop at KFD. So this is the collaboration we have with ICMR for many years, and this MOU was signed in 2016 in the presence of then DG ICMR, Dr. Soumya. Next, if you can move the slides quickly. Okay, this was also funded under the task force studies on leptospirosis, TB, listeriosis, brucellosis. Next. So in this activity, we funded 3 large studies, which are findings of which are in public domain. Next. So this ICR funded as a matching funding from ICAR. Next. So this is by RMRC Dibrugarh. This was a lead study on mixed farming study, where the population in the northeast have a peculiar habit of rearing. No, this is not the habit. This is promoted by ICAR for livelihood. So they have poultry, they have piggeries, and they have this sheep and goats together in one single house, and even fishery, small pond containing fishes. So this is to enhance livelihood. But housing so many animals within the same premises allows jumping of species. So that study is about mixed farming and how that is leading to antimicrobial resistance and also leading to infections among the animal handlers. Now, this World Congress on Leptospirosis was held in 2019, just before COVID hit us. So this also was a very important and nice meeting. All the stakeholders came together, and leptospirosis outbreaks we hear each and every year. Next. So SARS-CoV-2, no need to repeat it. The ICMR has been at the forefront of this fight against COVID, and I think we have done a very good job. And thanks to the leadership of DG ICMR, ICMR has really gone into the new frontiers of vaccine development, and giving an indigenous vaccine to the country was indeed an achievement. Then serosurvey, genomic participation in the genomic consortium, where gene sequencing and all those has been done. And CVID surveillance also has been done, and maybe the findings are in public domain. Next. So this is a very dynamic dashboard on COVID-19, which all of us have accessed at some point of time, more so for updated information. Next. So anyway, so this is the older work which we can skip work on. We can quickly go through. This is the KFD work which NIV Pune has done and given to the country. They have developed diagnostics and vaccine. Next is CCHF. Can we go to the next slide? So CCHF also, NIV Pune has been at the forefront. Next. So this is the district Pune has always alerted the state governments in close collaboration with ICR institutes and veterinary institutes. They have worked together because simultaneous surveillance in animals and humans is required for all these alert systems. So these are the states where the presence of KFD and CCHF can be seen, and the years where the surveillance mechanisms have been in place. Next. So we all know how Nipah happened, and that also created a lot of panic in the country. But now gradually, in this year also, we saw Nipah cases in the country. Next. So capacity building, preparedness, outbreak investigation capacities are the need of the hour. Next. I think that's all. So a lot of activities are going on One Health, and shortly we will launch more research activities in this area. Thank you. I'm sorry if I overstepped my time.
No problem. Thank you so much. Actually, we are thankful that you could spare some of your time and you explained the initiative taken by the ICMR in the area of One Health. Thank you so much. And I would love you can visit here physically.
Thank you. I will. Thank you. Lovely to have you. I would to visit the place.
Yes, you have to visit. Thank you so much.
Thank you.
So, the next speaker is Dr. Subir Majumdar, who is available. He is visible here from right now. Sir, welcome you. And very good afternoon. Hopefully your health is good now. It was nice when I visited the NIAP in Hyderabad last month. So Dr. Subir Majumdar is a former director of the National Institute of Animal Biotechnology. He is going to speak on the overview of One Health Consortium in India. And we at the RMRC Gorakhpur, we are the partner of this One Health Consortium by the GPT. I will Dr. Ina to brief about Dr. Majumdar.
Dr. Majumdar has done his MSc from Gorakhpur University, and he has a vast experience in the area of animal biotechnology, genomics, animal production. I mean, the National Science Academy and Indian Academy of Sciences, and he is membership of multiple societies. He has published many papers in many international publication journals, and he has been an eminent researcher all through his career. Thank you, sir. I request you to please start your talk. Sir, please I request you to please unmute your mic. Stuck again. I'm so sorry. I think Dr. Subir has some connectivity issues, so I'll request Dr. Sangeeta Pati to please present her talk on the research on anthrax in India future directives. Dr. Pati is one of the most dynamic directors of ICMR. She has a vast research experience in the area of comorbidity and multimorbidity, health promotions, non-communicable disease, implementation research, health system research. As her own and as a director, I think she has been working on multiple communicable, non-communicable many areas. She is a recipient of almost more than 30 awards, from which 7 has been awarded in 2021 itself for the work. And she's a member of multiple committees and published more than 200 papers in her career. Ma'am, please I request you, please enlighten us on the research on anthrax.
Can you see my slides?
Not now.
You will be able to, I guess.
It's not useful. Okay, please go ahead. So Dr. Pati is not again connected, so we will go with Dr. Subir.
Yeah, now you can see. It has come.
Yes, please go ahead.
Acha. So thank you for inviting me and giving this opportunity to interact. I have heard Dr. Manley, Dr. Manjurahi, they all raised the concern about the need for animal-human interface work, and I'll try to finish quickly. I'll skip some slides because I know your program is going late. So this is about consortium of One Health, which is very much necessity in today's day to protect man and animals both. And I will quickly go that we know what are the major diseases, and our dilemma always remains when we go to the disease that it is a disease from animal to animal, animal to human, human to human, and human to animal. And it's very confusing for several people, especially for the medical doctors, that how to handle, how to understand what is a zoonotic disease and what is not a zoonotic disease. So we all know that there are so many diseases prevalent in India. Add to that bovine tuberculosis, JEV, CCHF, cystosarcosis, leptospirosis, etc. And major problem is coming, we all know, because of antimicrobial resistance, overuse of the antibiotics, deforestation, intensified agriculture, and one thing very important, illegal trade of wildlife. So, that's very, very important. And the transportation is very poor, unrecognized way they do. There is no protocol, and that causes a lot of issues. Although major diseases lies in rabies to leptospirosis, anthrax, etc. But very recently, it is a study from 15 experts, which is compiled here. HIV, Ebola, Nipah, COVID-19, and influenza are also coming up as a dangerous disease. Now, it's a vicious circle. If you just take TB, and you will find there is a bovine TB in wildlife, it's a livestock, it's also in human. And who is giving, from where, whom, how? Simple TB. It is going to become a very big problem as far as the animal and wildlife is concerned. We are worried that it will be zoonosis and reverse zoonosis. And if you see the structure, very, very difficult to catch hold of from where it is beginning, where going. Let us take brucellosis. We know that affects so many animals and human beings. And it was a dilemma how to test. Doctors were always worried. And there are so many tests out of which people think complement fixation test is or Rose Bengal test is better. But I think the worry always remained, especially in the animals, that which animals are vaccinated with brucella vaccine and which animals are actually infected with brucella. So what we have to do is we have to use modern science to really resolve these issues. Otherwise, we cannot address the surveillance issue because we need to know. So now, for example, most of the kits are based on LPS, so the upper layer. We have recently started dissecting brucella and find out which are the intracellular proteins of brucella, which can be released in blood. That will happen only if there is active infection. If it is just vaccinated with LPS, it's no active parasite. Now, what we are trying to do is brucella BM5 protein we are using to make a constant procedures, confirmed procedures, very well done, patent applied and now given to company Lateral Flow as well as ELISA. And this BMP5 protein can only be seen if there is an active infection of Brucella melitensis. And with this, we are going for graphene biosensors because by the time you detect Brucella in animal, it has given to already 7-8 more animals in the herd nearby. We don't want that. We want to detect this as soon as possible. So we are using very high-end graphene biosensors that ahead of time we can detect Brucella. So this kind of work NIB is undertaking not only to do surveillance, but also to check the infection. We know that ICMR has now made S19-4 per vaccine, what they call, and this is done with the help of Department of Biotechnology, and it has already been transferred, and it's a very big thing for our country. We also know that for our purpose, that how leptospira, so is flowing all over Bombay. These are one of the floods in Kalyan in 2005, and I have reduced the number of slides. So we have SARS, MERS, avian influenza. We know how we kill, and thanks to high security disease in Bhopal, who is really helping us in finding out how the pattern of the infection is going on in various tissues. Now, let us take, as I said, we have to use modernization of the techniques. So when you do PCR for COVID-19, it takes 4 to 5 hours. So we are now trying in our institution the gold nanoparticle based antigen antibody binding, where we can see it in 5 to 10 minutes, the electric current change. So as soon as the spike antigen binds to the antibody on gold nanoparticle, the flow of electricity will change, and that is very easily detectable. So in 5 minutes, you will get a reading, and that readout can tell you it's a positive or negative sample. And we have compared it with the human test samples, and also we have checked it with MERS, avian influenza or HIV. There is no cross reactivity. It only specifically detects SARS-CoV-2 antigen. So this is I have earlier shown you Brucella M5 intracellular protein, which can be detected only if there is active infection. Now I am showing you how you can increase the speed using the modern technology for detection. Now we come to animals. Lot of infections in human in zoonotic disease is really going from mastitis, because this is the active mastitis, clinical mastitis, and farmers are in very close contact with these animals, and practices in village are very bad, and they all get infected with disease resistant or antibiotic resistant bugs. Our job is to catch the animal when it is preclinical mastitis. If we can make out ways to detect preclinical mastitis, we can simply treat with a small amount of antibiotic and treat before it goes into this condition, which is untreatable. So we have developed another kit where you have to simply use iron nanoparticles, and very small amount of the bugs will be joined with it, and there is a procedure through which it makes clump. And you can see clump and say it's a preclinical mastitis. If there is no clumping, it's negative. There is no chance of mastitis. Here, ahead of time, you can treat with a small amount of antibiotics and make them better. So this is how modernization is needed for surveillance as well as treatment issues. But in last year, 2020, Professor N.K. Ganguly came to National Institute of Animal Biotechnology, and we opened our Center for One Health on 3rd of November, which is World One Health Day. And DBT has now given us a grant, which we named as Consortium for One Health, to address zoonotic and transboundary diseases in India, including the northeastern region. So, aim is to initiate and strengthen the surveillance system of zoonotic diseases through existing and newer diagnostics, as I was saying, to have platform for generating indigenous resources, for developing detection kits. We have to do that indigenous, because the exported kits are very costly. Imported kits are very costly. We have to develop vaccines, animal models of diseases. We have to dig out pathways leading to antimicrobial resistance in Indian subcontinent, and tracking points for intervention to mitigate AMR and its aftermath. That means epidemiological, sociological, all partners should be there to evaluate how this goes from one place to other also. The scope of the application lies in understanding the pervasiveness of the specific animal pathogens, their threat to animal health, their zoonotic potential, and threat to human health also, and for the incursions and or reappearance of the animal diseases across India. And we are initiating a One Health program with the ultimate objective of establishing intersectoral collaborations among veterinary, medical, agriculture, environmental, wildlife, meteorological, and other areas to detect, prevent, and control zoonosis and transboundary diseases. So network is to be harmonized and synergized with the state and district level authorities also for the animals as well as human health, involving local vets and doctors. We have got 12 centers in all other states, 6 veterinary and 5 medical. We have got 7 centers in northeastern states, 4 veterinary, 2 medical, 1 wildlife. And we have got 8 small disease investigating units of Northeast. We are helping them to establish centers for disease surveillance. Now, if you come to the objective, it is to establish a network of laboratories at centralized and field levels to estimate prevalence and burden of select disease through serological and other methods, to detect pathogens where needed by serological, that is antigen, or molecular tests, to model the data for disease forecasting. So disease forecasting is the most important thing here, I think, and assess the risk using artificial intelligence tools. To generate tools and generate detecting and treating emerging zoonotic diseases. So these are the centers: AIMS Delhi, AIMS ICMR, your center, RMRC Gorakhpur, AIMS Jodhpur, and then Dibrugarh RMRC, Nazrat Hospital, Gandhi Hospital, MGR University. These are the medical centers. And Gadwasu, Punjab, IVRI, UP, Northeast, Assam, Khanapara, Northeast, University of Veterinary Sciences, MAPSU, Nagpur, NIAB, Hyderabad, and Tanuvas, Tamil Nadu. They have taken responsibility and divided the country in this way. They will address the surveillance of animals. And these medical centers will only address the surveillance of the patients which come to hospital or their close relatives going to the houses of practice. That's the end for now. So I think in addition to this, it is important to see environmental, soil and pollution also. Soil health is extremely important there and well. So I think we are planning to incorporate such partners who are knowledgeable there. So we need policy development using research-based academic industry can come together. Regulations are to be monitored and to be brought in our favor so that we can do very quick surveillance, science and treatments, etc. Ensure that recombinant DNA technology is used for several treatments, vaccine developments, etc. And obviously the public opinion, stakeholders' opinion is important. Most importantly, funding is required. I personally believe that policy regulation and funding we can organize, but we must develop manpower, students who think that One Health is very, very important. Veterinarians, medicals, and wildlife health workers should come to the environmental sciences for guys so that the One Health is achieved. Coffee should be developed, those school of thought or subjects should be developed, and manpower is very much necessary. So we think they have given us the disease and they think that we have not taken care of them and we are the culprits. That's what is happening here. So I personally feel that the problem is very big and ground is vast. Human beings need to collate all their knowledge, including biology, machinery, artificial intelligence, for detection, prevention, and curtailing health effects of zoonotic diseases and reverse zoonosis. This should be inclusive of equal importance to human and animal health, and we will work for each other as per the motto of the NIAB, our institute, which is Animal Health for Human Welfare. With this, I'll stop sharing here. Thank you.
Subir, very informative, very elaborative presentation in a very time-bound manner. Thank you so much. So the next speaker is Dr. Sanmitra Patti, if she's connected. Dr. Sanmitra, are you connected? Not. So Dr. Sanmitra is not connected, so I will transfer Dr. Sanmitra from One Health to the vector-borne diseases. She can speak in vector-borne also. So now we can start now session 3, impact of climate change and vector-borne diseases. So actually Dr. Yadav had requested if you can inform me 5 minutes earlier, I will have to send a message. So before Dr. Yadav join, I will request Dr. P.K. Srivastav because he has to catch a train at 4. So I will request Ina if she can brief about.
So from here, going to take over.
So I will request Stuti to brief about Dr. P.K. Srivastav, and Dr. Srivastav will speak on lymphatic failure.
Good afternoon, everyone. So our next speaker is Dr. P.K. Srivastav, who is the former Joint Director of NVBDCP. He has vast experience in the area of vector-borne diseases and their control. His work on lymphatic filariasis is exemplary, which has played a significant role in the management of lymphatic filariasis in the country. Sir, I request you to start with your presentation.
Good afternoon, everybody. At the outset, let me thank Dr. Rajnikant, and it is really a pleasure coming here and then talking physically because I could make it, though it is a short visit, and I promise that I'll be coming for the future sessions, which will be on a larger scale. For the time management, I'll not speak much without wasting time. Okay. Okay. Thank you. 2 topics have been to the core of my heart. One is lymphatic filariasis. Though I started career in malaria, my email still remains, as you are saying, pkmalaria@yahoo.co.in. And these people, they know that our career started with malaria, but later on it was given to us because this disease was targeted for elimination in the country, and I have been the basic at the time of designing the whole project. The moment we talk on lymphatic filariasis, the image comes in our mind, which is shown on the left side, that swelling of the legs, lymphedema or elephantiasis. And then in the male, we also see the swelling of the scrotum. So these are the two major signs and symptoms, though there are other signs and symptoms, swelling of the leg, swelling of the breast. There are many other genital manifestations, but the basically common triggers are this. Now, since the topic is on the climate change, we know that this is a mosquito-borne disease. And the climate plays a crucial role. You see on the left bottom, there are three figures we have clubbed together, like tsunami, like tornado, like high wind velocity, and then there are heat, there are climate change, temperature, which we'll be talking later on the other authors. So the mosquitoes, total breeding and its area of influence, it gets affected. So on and so forth. If you go on the disease epidemiology, parasitology, and the pathogen interaction, the humidity, which is going for a longer period, the disease manifestation also remains same. That is why the filarial belt, which we used to call it, so far as India is concerned, we used to call it an Indo-Nepal border and Tarai belt. That is why most of the cases, but I'll show you in the mapping when you go on the western side also, it is not left out. So, because we are addressing to the research group primarily, not the program group, though there are many people from the program, they are associated with the work in a virtual mode. To any research to support the program for achieving its elimination, this is very, very important that we understand the life cycle. I'm not going to explain the life cycle, but the part which is inside the mosquito and the part of the parasite which is inside the human body, it is very, very essential to do any supportive research for the program. Nowadays, where the gap is that we do not want to go on the basics of the life cycle. That what are the changes which are made, because we receive lot of questions and answers on the every stage of the life cycle. L1, L2, L3, microfilaria prevalence in the stomach. The moment people, they will show in the WhatsApp the photo, sir, this is how we have got it. As if some gold mines they are found it. So this is very, very important. That is why I have shown this slide. Now, what are the factors which are influencing the total transmission? The point which is very important, mosquito-borne disease. So irrigation, water accumulation, urbanization because of what you call it as a supply of the water, drinking water in an indiscriminate manner. Somewhere it will be good, somewhere it will be overflowing, somewhere it will not be. Industrialization, industrial setup, aggregation of labors, migration, migratory movement, and from non-endemic area to endemic area, from endemic area to non-endemic area. Natural disasters, post-effect, cyclone or tsunami, or we have been many outbreaks, containment. Then natural disasters like which earthquake. So then resistance to the vectors. I mean, this is the basically behavior of the parasite or behavior of the vectors response to the controlled measures on the insecticide, or if you call it as a parasite, to the drugs. Then global warming, the area which were untouched, which were not under influence, they have been brought under the influence of the mosquito vectors and then leading to the transmission. Political instability. This basically are war. It does not allow us, the service providers, to go and enter into the area where actually their services are required. This is very, very difficult area. We don't call it as an insurgent area. We call it nowadays war area or far-flung area or inaccessible area. So basic sentence what we have learned during reading Pampana and Boyd's malariology, that beating malaria means understanding mosquitoes. So unless we study these two things, parasite or the pathogen and the vectors, it is very, very difficult to do any kind of research. So for LF, initially 83, 84 states were endemic. Now it has been reduced to globally. So now you can see that if you draw the line on tropic, this is basically The total plus minus, the whole area is endemic forever. The green one where the elimination strategies are being carried out. Now these are the two species, though there are three, but we will be talking on two because these two are prevalent in India. One is Butyraria bankrupti and another is the Brugia malai. So there is minor difference between it, and that is very, very important when we say that some area where elimination could not be achieved or elimination could not be sustained. So this is very, very important. And you see one research they have found out with the entomologist only that the W. bankrupti, they have got one subdiurnal periodic form, which is also found in our Andaman Nicobar group of islands, where initially it was thought that Aedes group transmits, not Culex cuncunfasciatus. Now the name has been changed down so many. This is third species. Down below we are talking only the yellow mark, Brugia W. bankrupti and Brugia malai, but there is another Brugia timoria also, that is also on the 5th row. So that is basically on Timor Leste Island. So that is the country which was last country which has seen its independence. So basically, when you talk of elimination, the endemicity is very important. Technically, endemic definition is that wherever any indigenous transmission is going on, that we call it as a scientist as an indigenous transmission. So the area is endemic. But when we talk of elimination of LF, we say that wherever microfilaria prevalence is more than 1% at community level, that is the endemic. So it is scientifically evidenced that if you bring down below 1%, the disease will die its natural death. It cannot be transmitted because this disease itself, it's a poorly transmitted disease. There are many probabilities. It is not like malaria. So that is why this curve shows that if you cover the entire community, you call it One Health, you call it as universal coverage, unless your services are covering the entire population, it is choice yours. You can cover in 5 rounds, 6 rounds, or you can cover in 12 rounds, or you can go on. Like when we took over the charge 2004, we started, 21 we are crossed, still we are doing mass drug administration. So we have also on scientific basis, we have changed a lot of strategies. Initially, we started with control in rural urban areas. And now what globally the people are doing, the mass drug administration, we did try long back 40, 50 years before. But the only thing is that now we are doing with 6 milligram per kg body weight. We tried at 4 milligram per kg body weight. So there are 5 times there has been changes in the strategy. We covered integrated, we approached, we covered rural area, we covered the PSC system. Finally, now we have landed for elimination with annual mass drug administration with initially started with DEC alone. Then we started with DEC albendazole. In 2006, we took a decision, and 2007 we started. And in 2015-16, we started as a pilot for triple drug therapy. Initially, ivermectin was not added because if you talk of whole world elimination, 1.2 billion population was to be covered. Where were the drugs? Where were the drug manufacturers? So these are the points which was operational research were done, and it was clear that ivermectin will be used only in that area where DEC gives a reaction, especially for African country where onchocerciasis and loa is present. Now we have to caution the whole process, so ivermectin has been added. There are adequate guidelines. I would request all the researchers or young people or the program people who have newly joined that they must go through. I don't think there is any question for the program related which is not listed. But the only problem is that people, they must read it, everything at the grassroots level till the district level and the state level, and even for the researcher, because these guidelines have been framed in collaboration with ICMR. I remember those days when we got money from WHO, we immediately, one strict signature I gave it to ECRC Pondicherry, 6.5 lakhs rupees, that you make these guidelines. And they were very happy, and that is why the logo is there. So then there are vector control part, which was not initially taken because of logistic reasons in filaria elimination. Control, it was there as a larvicidal approach. But now WHO has listed it as a third arm as a supplemental approach for vector control wherever it is feasible. Nobody is talking nowadays vector control, which is very, very important. And for that, this guidelines is available under national program. And please visit those websites. And if there is any question related on that, we will be very happy to answer. There are entomological surveillance also, how to do monitoring of the vectors, what to do, when to do, and how it is to be done. And 2 or 3 slides. So we have got somebody on the online they are talking. So there are plenty of opportunities, and I always give, and I have been during my regime or now also we advocate that people group they come to see LF for LF. The area it is almost endemic for LF also. So we can always integrate. What we can integrate, if you see the 3 circles, you see the treatment part can case management. Now, what basically on the vector control, which is more effective with the temperature and climate, the changing scenario, see the first 4 points, red color, this is high priority. Any work is to be done without the support of the technical skilled human resource or the tools, it cannot be done. So that is first important point that you have to skill your staff. The second point is coordination and bring everybody on one platform. And third is the basically uniform research, a uniform protocol, and then proper operational research, which is all of you have to support the program. Next. This is the last slide, most likely, that in 2004 itself, when we started first launch of this mass drug administration campaign, this was given that one failure should not be taken as a failure. Now, what they say that it should give credible assurance. People, they must have belief in you, and how you will do that will differ from area to area, different kind of communication, different kind of things. And this is true for this area. So wherever they have failed, don't say that you have failed. Say that these are the challenges. You have got another opportunity to work harder and harder to show that yes, you can do it. So I must thank you, all the stakeholders who have been contributing to all of us during last 10-15 years. I mean, I was looking for election since 2004. ICMR, PCRC, I mean, different centers, program, WHO, everybody. So, and more or less the states and the community. So thank you very much for this integration.
Dr. P.J. Srivastava, it was very informative talk, and I know your experience and expertise, which has played a crucial role in the management of lymphatic fibrosis in the country, as well as other vector-borne diseases, whether it is malaria, chikungunya, or dengue. And I hope that you will spare some more time and keep on visiting our center again and again. If Dr. Sanmitra is connected, Dr. Sanmitra, are you connected?
Yes.
Yeah, you are connected now? She is there. Yes. And Dr. R.S. Yadav is also connected. So Dr. Sanmitra was busy in a meeting. She has just joined. I will request Dr. Sanmitra if she can touch upon some of the issues which we were talking since morning. And she is a dynamic leader. She is an expert in various areas of public health importance. And she has played an important role, whether it was COVID-19, whether it was anthrax, and many other issues of the health importance. So I will request Dr. Sanmitra if she can touch upon some of the issues. Over to you, Dr. Sanmitra.
Okay, first of all, thanks for your very kind and overtly generous, as usual, introduction. So Thank you very much for giving this opportunity, and I apologize because of my unwanted or inadvertent delay, because today, in fact, it's very pertinent to say that today the meeting I attended was the crisis group meeting regarding the emerging and re-emerging zoonotic diseases, particularly in view of this Omicron strain. So, I mean, it's again sits very well with One Health concept. So, and the meeting went on, and I was ahead of. So, should I share my screen, Dr. Rajnikant?
Yes, you can share, but try to stick the time because we don't have much time. And I will request if you can finish in 15 minutes maximum.
Okay, how much time I have? 10 minutes?
Maximum minutes, 15 minutes maximum.
10? Okay.
15 minutes, 10 plus 5.
Okay. Is it visible? Is my slide visible?
Yes, visible.
Okay. So good afternoon, and as suggested by Dr. Rajnikant, I will try to be as much as crisp and to the point possible. And basically, I will be describing on the research activities that ICMR RMRC Bhubaneswar has been undertaking in the area of anthrax. And for all of us, anthrax is, of course, a very old and known zoonotic disease, but at the same time, it continues to remain in some pockets of India and still poses challenges for the system, for people, and for policymakers, so that it can be eliminated through a One Health approach. So basically, the work we are working on in RMRC Bhubaneswar is the mission of One Health. How can we use the philosophy or the principle or the strategy of One Health and demonstrate how anthrax, an endemic disease in a tribal district, can be controlled using this synergistic approach. So all of us know this. I did not say again reiterate, because all of us here together, we all believe in the importance of zoonotic, emerging and re-emerging diseases. And anthrax especially is more daunting because it affects rural, remote population, particularly tribal communities who live near wildlife or forest areas. And outbreaks are predominantly reported from eastern India. These are the red marked states which have been reporting anthrax. So primarily our transmission to human, because of its zoonotic nature, human cases are primarily dependent on contact with either infected animal or animal product, though no significant person-to-person risk has been demonstrated. And inhalation of spores from biovector is also known, but in tribal communities, more of eating the carcasses of the dead meats of animals. So these are three types all of us know, that is cutaneous, gastrointestinal, and inhalation. So I would just quickly go through it. And we usually in Odisha see this cutaneous anthrax, and wherein there is from the day 1 to day 10, day 1 starts with a pustular reversible cycle, which on then 10 it becomes a scar or dries up. And there is not much bad prognosis in terms of cutaneous anthrax. And however, if it is gastrointestinal or inhalation anthrax, then it has got case fatality rate quite high. So now let us look at Odisha. Odisha has been reporting over the last 15 years, 14 districts have reported some or other cases of anthrax and affecting 1,200 people. 8 districts have reported human anthrax cases, and Gorakhpur district is the most affected, with total reported cases is 354 and 9 deaths in last 7 years. So that prompted us to take this project in Gorakhpur district and demonstrate how One Health approach could be used for controlling, or at least to start to pave the path or roadmap for elimination of anthrax. So what we did is that to start with, we undertook a mixed method study to identify what are the possible roadblocks, because it's more of what are the implementation gaps, how are the programs being run, and what are the possible nodes of intervention, just bringing synergy between different departments. So what we found out is that one is low level of knowledge. Many tribal people didn't hear about or didn't know about anthrax. And there was not much interdepartmental coordination, and human resources, as always, was one of the bottlenecks. And people's behavior and cultural practices still was a problematic, or still was one of the risk factors for the anthrax. And these are the different responses when we ask people about how anthrax is transmitted, what are the causes of anthrax, which reflects that the low level of awareness among the tribal community. So this made us to have our first policy brief that how anthrax can be controlled in India, and this was the outbreaks, how can anthrax outbreaks be prevented in Odisha. So this is in fact the first of its kind policy brief on anthrax in Indian context. And after this policy brief, we got ICMR's grant to develop a One Health strategy for elimination of human anthrax from an endemic district of Odisha demonstration project. So basically that policy brief was useful or was catalyst for getting a grant and to demonstrate how One Health approach can be used. So basically what I will be describing is more of the field or more of the practice side rather than the lab side. So the project was aimed to study how the effectiveness or how public health intervention based on multi-sectoral strategy. So as all of us know, One Health means multi-sectoral. It involves multiple disciplines, starting from veterinary health and family welfare, women and child development, then forestry and wildlife, panchayat raj department. So multiple sectors were converged. And second was, how can we develop and implement a package of coordinated interventions using this One Health approach? And this strategy is so that it is replicable and can be reproducible or can be scaled up in other districts as well. So, and the secondary objective was to examine the situation analysis or to undertake a situational assessment, that is particularly with respect to disease burden, pattern and knowledge, and how can we develop a public health intervention. So it was an implementation research, right? Because we were aiming to demonstrate effectiveness, cross-sectional, and the setting was Gorakhpur district. And these are the different sectors who were involved in the study participants: healthcare sector, animal care or veterinary sector, as well as the community. So it was a multi-stakeholder perspective or multi-stakeholder participation. And this led us to our first publication, which based on our ground realities or a situational assessment, we registered this protocol, that is One Health approach for elimination of human anthrax. It got published in PLOS, which describes the protocol for elimination of human anthrax. And what were the findings? Now coming to the study findings, what did we find? So our baseline assessment found that we completed 2,640 household surveys and qualitative, which includes in-depth interviews with different stakeholders and focus group discussions with communities. This is the disease burden assessment. And the key findings in terms of the key findings were that low level of awareness and symptoms and low level of information on how anthrax is transmitted. And these are the different behavioral practices which we found to be key or crucial in the transmission of anthrax. And the mostly people heard on anthrax is from community rather than healthcare workers. So we thought of involving healthcare workers more as an information disseminators rather than media or other things. So what we could see is that the source of information has to be worked on. So we developed IC materials. Then knowledge and practices. We can see that the distribution of the knowledge about anthrax. In qualitative assessment, there are 5 themes emerged. One of the most important theme that we found is interdepartmental coordination was vital or crucial. Livestock vaccination, so that has to be taken up. Then developing an integrated surveillance network. 4th was diagnostic facilities. And 5th was how do we keep on or how do we continue our prevention and control strategy. So these were the 5 key findings of our qualitative discussion with all the stakeholders. So this also got published, one in ICMR, that is a qualitative exploratory study, and how can we develop an intervention package. And another was the landscape, we tried to landscape what are the different perceptions of our stakeholders regarding anthrax prevention and control. So my point of showing all this is that this elimination or One Health approach cannot be an overnight process. It has to be an evolving, it has to be an iterative process wherein all the stakeholders get involved as the strategy moves ahead. So what happened is that we finally got a great, I would say, very key policy change. That is, livestock vaccination was taken up by the district authority without any payment. So that because many of the people were not very interested to go for livestock vaccination because they had to pay for it. So the district administration, after being convinced, they took it up to their district fund, as a result of which now livestock vaccination is going on in the Gorakhpur district. Then now we are going ahead with the capacity building. We have developed a module on One Health training. So these modules were released by the district authority. And now all the stakeholders or the capacity building of different levels of worker will be started in phase-wise manner. Like which comprises program managers, data handlers, animal handlers, medical officers. So different levels of workers will be trained with different modules. We have developed packages or training materials. And also, another major findings what is very important to continue this elimination is that how can we have an interlinked surveillance system? I'm sure Dr. Manju would be focusing on that. How can we link veterinary as well as human surveillance or IDSP with animal outbreak surveillance? And how can we catalyze intersectoral coordination? And how can we increase community literacy on safe carcass disposal? And how do we change behavior? Because behavioral change is one of the most difficult things to foster in on consumption of dead livestock. And how can, even if the district started the livestock vaccination, how do we ensure that the adherence or the compliance towards livestock vaccination continues? So one step we have moved ahead in terms of laboratory diagnostic. Out of the key needs identified is that we have set up the molecular diagnostic facility at ICMR, our own institute. So one of the key needs has been fulfilled. And we are also looking at or developing how can an integrated surveillance work on, wherein there can be parallel reporting in coordination between veterinary department as well as health department. So this is our chain of case reporting, which we have suggested to the district, and district is working on it to adopt. First, the report will go to district headquarters hospital, and then formation of an outbreak investigations team, and sample will be collected. Then one sample will go for the state, and another will go to RMRC, so that both the state and the center works in hand. And now we are working on the risk zoning. So we are using the GIS mapping. We are now identifying particularly the risk zones for anthrax and how we can develop One Health outbreak response protocol. And since this project is going to be over in another 6 months, we would do a baseline. We have already done a baseline assessment, the knowledge, attitude, and the practice. Now we will do an endline evaluation. And of course, we will also analyze our past outbreak investigation report in 2 years. How many outbreaks have been jointly conducted by health and veterinary department? That is going to be a strong process indicator for One Health, because One Health is One Health when all the departments work together for a unified vision. So we will look in the past how many outbreak investigations for anthrax have been jointly undertaken. That will be one of our monitoring indicator or our processing. And these are our behavioral change strategies. We have made IC materials. And what we intend to do is that, or what is the submission before all the stakeholders is that, as all of us know, that zoonotic diseases are going to be one of the major cause of burden or major cause of morbidity and mortality in the coming days. So One Health approach appears to be the most prudent as well as potential way to address this either endemic or emerging or re-emerging zoonotic diseases in India. And the very purpose of this symposium fits very well with this mission. And with this, I would like to conclude, and my sincere thanks to Dr. Rajnikant and the symposium organizing committee and all the members here, because all of us are now working for this mandate of One World, One Health. Thank you. And thanks to all the team. Actually, they are the field workers. They are the real warriors. In fact, I'm just presenting on their behalf.
Thank you so much, Dr. Sanmitra. Hopefully now see you soon here physically in the scientific advisory committee, which we are planning to conduct as early as possible. And hopefully you will come and see the new institute. And this is the first day after the inauguration, and we are conducting this symposium from our conference hall of the new building. So thank you so much for a very interesting, very informative talk. And now I will proceed to Dr. R.S. Yadav from local to global, because Dr. Yadav is in Geneva. And I will request Stuti if she can brief about Dr. Yadav. So over to Stuti now.
Dr. R.S. Yadav is a scientist at WHO Department of Control of Neglected Tropical Diseases in Geneva. Dr. Yadav coordinated the implementation of the global vector control response against the vector-borne diseases, and earlier he headed the WHO pesticide evaluation scheme in the year 2013 to 2018. Dr. Yadav has also published hundreds of national and international research articles in renowned journals. And Dr. Yadav is going to present his presentation on the topic global scenario of vector-borne diseases. I would like to request Dr. Yadav to start his presentation.
Thank you so much. Can you hear me?
Yes, sir. We can hear.
Okay. Thank you, Dr. Rajnikant and other colleagues for inviting me to this symposium. And first of all, I would like to congratulate also Dr. Rajnikant for their new building. And this shows that he has been doing a lot for improving the institute's name globally. Now, he assigned me a very small topic, which is to present the global scenario of vector-borne diseases. So I will basically not speak much about interventions, but just to tell you where we are with regard to the distribution or the burden of diseases, vector-borne diseases. And, because in the WHO headquarters now, I coordinate NTD, GMP, TDR Joint Action Group on Global Vector Control Response. So this is very apt for me to brief you about the different vector-borne diseases that are prevalent globally. Starting with the list of diseases, there are a number of diseases for which there is an organized elimination or control program. So these are listed on top, which includes, of course, as you know, malaria, dengue, chikungunya, Zika, yellow fever, JE, leishmaniasis, lymphatic filariasis, cysto, onco, HAT, Chagas disease. These diseases have organized programs. Then there are other emerging and re-emerging diseases from different parts of the world. These are also listed below, and for which there are no organized programs because they appear as hotspots or in the form of outbreaks. This slide shows the global burden of diseases, and it shows that still malaria is the first disease with greatest burden of disease, followed by lymphatic filariasis and dengue and so on. I will not read this slide, but basically this slide was to show that there are a number of diseases that contribute to the global burden of disease. Now, starting with malaria. This is the statistics from the World Malaria Report, which was released yesterday only. And it shows that we have about 240 million cases every year. Compared to previous years, this year the incidence was more or less static. There was a small rise in number of cases, but there was 12% increase in the number of deaths in malaria, which could be attributed to COVID or for failure of treatment and control services. So this is basically this year's progress of malaria has been not so promising, and the number of deaths particularly have gone up against the expected decrease. Dengue has a greatest risk in terms of distribution, and as you can see that southern part of the globe is mostly at risk of dengue. And if we talk about India, then of course the entire country except the temperate regions are at risk of the distribution of dengue disease. In terms of reporting of cases to WHO, we are not getting data from many countries, dengue data, and therefore this statistics is not really representative of the true global burden. But this just tells us that number of cases of dengue are increasing as much as they are being reported to WHO. But of course, in 2019, there was a major outbreak of dengue in Brazil, and where you can see that the number of cases shot up like anything. But otherwise, the case fatality rate more or less is static. but the number of cases are increasing. And this probably also because of a better reporting by certain regions over different years. We are now making some dengue burden studies just to assess where we are in at least endemic part of the world. Most disturbing trend now is that dengue has already made a foothold in the African continent. It was believed that it was not such a big problem in Africa, but now everywhere you can see that there are outbreaks of dengue in the African continent. And many countries of Africa are now reporting more and more number of this. And this also shows that the vector has really distributed throughout the African continent. Again, countries south of Sahara are at greatest risk of dengue in the African continent. Now, comparing between malaria and dengue, you can see that although the global population at risk is more or less similar, the number of countries endemic with malaria or dengue, if you compare them, dengue countries are more in number. And in terms of the infections per year, dengue is also higher than malaria. But of course, in terms of number of deaths, dengue is still much lower than that of malaria. So dengue, therefore, is an equally problematic disease. Although countries are not putting in adequate amount of resources for surveillance and control of dengue as much as we have global contribution for control of malaria by donor community and by domestic budgets. Chikungunya, we do not have more recent statistics, but a risk map was prepared in 2015, and which shows that again, countries south of southern part of the globe are at risk of chikungunya. Sporadic outbreaks everywhere. Zika is more or less prevalent. Even in some temperate countries, Zika outbreaks have been reported, maybe because of the importation of cases. But Zika is very well widely distributed. And this year, 2021, there were some cases also reported from India, particularly in UP. So you can really pool all Aedes-borne diseases together. Then this map again is representative of those diseases, the different slides that I earlier showed you. That southern part of the globe, which is warmer, still at risk of Aedes-borne diseases. Although chikungunya cases have been reported even from Europe, and this is because of the migration of or establishment of Aedes vectors in the warmer part of Europe. So this is the impact of climate change. That southern part of Europe is now becoming endemic to Aedes-borne diseases. Japanese encephalitis is still restricted to the Southeast Asian and Western Pacific regions of the world and elsewhere. Lymphatic filariasis. So almost 900 million people are at risk of lymphatic filariasis in 50 countries. And the greatest burden is still in India. Currently, of course, about 50 million people are infected every year. This statistics is of 2018. But it shows that there was a 74% decline of the LF cases since the global program on lymphatic filariasis elimination was started 20 years ago. Preventive chemotherapy or mass drug administration is still the main interventions for LF control or elimination, whereas mosquito control is just a supplemental strategy. And for a couple of years, even vector control was not even considered as an intervention for LF control, but more recently, there is an interest that vector control or mosquito control can still contribute, particularly in those areas where the disease is at the verge of elimination and where mass drug administration doesn't work because of the poor access or poor coverage or poor acceptance of mass drug administration. So vector control can actually root out some of the residual number of cases. That is what is the current thinking. In terms of schistosomiasis, the disease is still prevalent in the African continent, but also in Indonesia in some islands. But mostly in other parts, it has either been eliminated or is at a very, very low level. Although 78 countries and territories are endemic, 51 countries are still in need of mass drug administration for treatment. But there are recent, and considering publications, there are chances that the disease may be prevalent in Nepal, Myanmar, and India. And if you look at the recent publications, people are of the opinion that some cases may be reported from Southeast Asia in other countries than Indonesia. Human African trypanosomiasis, as the name shows, is prevalent in the African continent. There are two types of trypanosomiasis, which is transmitted by rhodesians and by Gambians. So these are the two species of trypanosoma. And the distribution of the two diseases, as the map shows, that again is in Africa. The rhodesians is more prevalent in the eastern part of Africa, whereas the Gambians actually is more prevalent in the western part of Africa. Onchocerciasis is the, those of you who have visited WHO headquarters in Geneva might have seen this picture on left side, that an old man being led by a child, which is the river blindness disease. There is a statue in front of the main door of the WHO building. River blindness actually is prevalent again in Africa and southern part of American region. And this year, we have, for the entomologists, developed a manual for entomology for control of for onchocerciasis. So that is a little contribution that we are making. Chagas disease is the African trypanosomiasis and American trypanosomiasis, and it is more prevalent in the American region. But because of some importation, the cases are also being reported elsewhere in different countries. And now coming back to the leishmaniasis. So leishmaniasis, as you know, VL is more prevalent in India, Nepal, and Bhutan. In India, Nepal, and Bangladesh. Although the incidence is much lower in Nepal and Bangladesh now, with India also making a great contribution in reducing or eliminating the disease. So in 2020, actually 98 of the 200 expected 200 endemic countries and territories were actually endemic for leishmaniasis, which is CL and VL. And particularly for VL, Southeast Asia is the main contributor, whereas for CL we have Mediterranean region and African continent, and also some cases from the South American region. This is the map showing the endemicity of visceral leishmaniasis worldwide, and it shows that some countries are really full of this disease. So this includes India as well, but also Brazil and eastern part of Africa. So they report a large number of VL cases. And in terms of contribution now, of course, the total contribution of Eastern Africa is much higher than of South America and India together. CL is, which is cutaneous leishmaniasis, which is also prevalent in India. I mean, it's not reported, but we are aware that sandflies are there, and there may be sporadic cases of cutaneous leishmaniasis in Rajasthan and parts of Gujarat, although there are no reports, at least at this map shows. But there are cases from Pakistan, Afghanistan, and Eastern Mediterranean region, and also the northern part of the African continent.
And they switch off all mobile phones and other electronic items.
Can't hear you.
Can you hear me?
No.
Because somebody muted me. So I would just a minute.
No, we can hear you.
Okay, thank you. So scrub typhus is the disease which is now showing a disturbing trend of increase. Although on left-hand side, these are the number of outbreaks reported by the Indian surveillance program, but in real sense, there are much more number of cases of scrub typhus. Apart from India, we are aware that this disease is highly prevalent now in Nepal. There is an increase in Sri Lanka, in Maldives, and even Nepal program are developing, or rather they have drafted a manual for control of scrub typhus. So scrub typhus is the one which is to be now considered as part of the control program rather than just being a neglected disease. And therefore the cases are not being captured in routine surveillance system. Okay, so if you take several diseases together, this is a composite map of 9 major vector-borne diseases, and you can see that almost 80% of the world's population is at risk of at least one or more major vector-borne diseases, with nearly half of the population is at risk of 2 or more diseases, and the main diseases are malaria, LF, dengue, leishmaniasis, JE, yellow fever, Chagas, HAT, and onchocerciasis. And once again, it shows that the southern part of the globe is at a greater risk of vector-borne diseases than the northern part, which is very obvious that the northern part is temperate and maybe their health systems are better organized. So transmission potential of the southern part, the warmer part of the globe is greatest. And that shows in this map that these diseases are more prevalent in the southern part of the hemisphere. Now, the last slide, which is my direct responsibility in WHO headquarters, which is that in 2017, World Health Assembly passed a resolution on a global vector control response after the outbreak of Zika in Brazil and other parts of South America. So the DG established a committee which drafted this document, and this was then adopted in the World Health Assembly. So this is a strategic approach for control and elimination of vector-borne diseases by 2030. And as much as we have included this element in different diseases strategic approaches, and the Global Vector Control Response, or GVCR in short, actually has 4 major pillars. The first pillar is strengthening inter and intrasectoral collaboration. The second one is to engage and mobilize communities. The third one is to enhance vector surveillance as well as monitoring and impact of interventions. And the fourth pillar is to scale up interventions and tools that are effective in local settings. There are 2 foundations of this strategy, one is to enhance vector control capacity and capability in the countries, and to increase basic and applied research and innovation. Seemingly, these strategies are not different from integrated vector management or previous strategies, but what is different in here is that the country resolved that domestic resources will be mobilized for control of vector-borne diseases, which was never so emphatically accepted in the World Health Assembly. But in this particular adoption of this strategy, all health ministers resolved that they will mobilize or try to mobilize as much as possible domestic resources in order to control of eliminate diseases. Now we are seeing that donors, most of these control of vector-borne diseases are donor dependent. And this was one driver that in the World Health Assembly, this was discussed emphatically, that unless countries mobilize their own domestic resources, no donor will come forward always to support your program. Donors are still contributing, for example, Global Fund or Gates Foundation or other donor agencies are still giving money for control of diseases. But what is important is that in this strategy, we are now trying to emphasize and telling the countries that they should also mobilize their local resources as much as possible, because no more unlimited money is going to come to you. And WHO's role is only to now provide technical support, guidance, and training, and can play a convening role for developing guidelines or guidance document. But we can no longer provide big money for control of vector-borne diseases. So that was the message in the end I wanted to give you. I think that was my last slide. And thank you so much for giving me this opportunity. within the limited time, I could not really provide more information about strategies or interventions from the WHO headquarters. So thank you so much, and over to you. I can't hear if anybody is speaking.
Dr. Rajnikant.
Yeah.
Can't hear.
Hello. Can you hear now?
Yeah, I can hear. Yeah, yes, please.
I think there was some technical issue. So I was just appreciating the presentation you made. You just described about the global scenario of various vector-borne diseases from the dengue, malaria, chikungunya, Zika, leishmaniasis, lymphatic filariasis, and the strep typhus. In Gorakhpur, we are studying with the strep typhus because the 50% of the AES is happening because of the strep typhus. Now we have just now prepared a proposal for pan-India study of the strep typhus. That was one of the most neglected diseases and people were not aware about the strep typhus, the problem. But now we have started working on the strep typhus. So thank you so much for very elaborative, informative talk. And definitely the part 2, we will get some opportunity some other day that we will also request again you to describe about the part 2, that is vector control. What are the global strategies for the vector control? Thank you so much, sir.
Thank you so much, Dr. Rajnikant. Actually, also in my presentation, 2 messages I wanted to give. One was that now strep typhus is the problem, and other that vector control needed to be boosted, and actually countries should really put in resources. So thank you so much.
कृपया ध्यान दीजिए, विमान में ईंधन भरा जा रहा है। सुरक्षा को ध्यान में रखते हुए कृपया सीट पर बैठे रहें, लेकिन सीट बेल्ट ना बांधें।
Okay, bye-bye.
Okay, Yadav.
Yes.
This was really very important message because we are not breaking for the tea. अपनी सीट पर बैठे रहे, बेल्ट बांधे रहे, tea will be served here only. So we will save some time. Thank you so much.
Okay, thank you. Bye-bye.
Sir, thank you so much.
Okay.
So Dr. J.P. Sir, do you want to say something?
No, not at this stage. It's okay.
So now we have with us.
You can enjoy your tea.
So now we have with us a climate man because we all know we are suffering from the global climate change, global warming, sometimes the disasters. So we are all worried about the climate change. And Dr. Dhiman, he has been working since last so many years on the climate change. He was running the full-fledged Center of Excellence on Climate Change. So Dr. Dhiman is here, so I will request Studi to briefly describe about the personality of Dr. R.C. Dhiman, then we will request Dr. Dhiman to start the presentation.
So Dr. Dhiman did his master's in zoology with specialization in entomology and his PhD in medical entomology and parasitology. And he also received a training in malariology, satellite remote sensing, epidemiology, and climate information for health. And the research interest areas of Dr. Dhiman are epidemiological investigations and early warning of outbreaks of malaria and dengue, and ecological change detection using satellite data, impact of climate change on vector-borne diseases, and vector control. And his scientific achievements are development of cumulative rainfall, NDVI, El Nino, temperature condition index, and sea surface temperature as tools for early warning of malaria. He also demonstrated application of satellite data in delineation of mosquitogenic conditions, and he assessed the impact of climate change on malaria and other diseases by the year 2030s and beyond using PRECIS, PRECIS and Cordex climate models. He also set up BSD ICMR Center of Excellence for Climate Change and Vector-Borne Diseases. He also participated as WHO temporary advisor on several occasions. He has published over 110 publications in international and national journals. And I request Dr. R.C. Thiman to start with his presentation.
Thank you, Dr. Stuti. At the outset, I thank Dr. Rajnikantji for kind invitation. Because of him, we enjoyed the inaugural session, and we are sitting on the first day in this conference. Yeah.
So sorry, those who are virtually connected, there was some electricity issue because the generator was not connected, but again we are back, and Dr. Thiman is also connected. So over to Dr. Thiman to start the presentation.
Sorry for the inconvenience. Am I audible? I am happy to share the experience on climate change and vector-borne disease in the presence of Dr. J.P. Narayan, who guided and encouraged us when he was in WHO. Actually, the word climate is not new in the context of vector-borne disease. Our country was first in 1914 when climate and malaria were related, and even the forecast also it was being done for Punjab. But now climate change has cropped in since 1990, and we are much worried about the impacts of climate change. So because here many newcomers, new scientists, students are there, so I wish to clarify climate variability is slightly different from climate change. The day-to-day or year-to-year variations in the climatic conditions we talk, that is climate variability, and changes in the climatic conditions over a period of 30 years or more, that is climate change. So in the beginning, we were assessing the impact of climate change by 2100-2050. But the government of India through Minister of Environment, they asked us what we will do by 2100. So we should have some near-time projections of impacts. So then we started working for near-time projections. So what is the importance of climatic conditions in vector-borne disease? The diseases are seasonal. Why they are seasonal? Because they are climate sensitive. It affects the life cycle of mosquitoes, the climatic conditions, the developmental cycle, the development of pathogen in the body of mosquitoes, their survival. Everything depends on climatic conditions. Whenever you see distribution of any disease, please think over why the disease is confined to this area. It is basically because of the climatic conditions. We talk about ecology also, but that ecology is also determined by climatic conditions. The type of temperature, rainfall, humidity determines the vegetation and then the ecology. Because of low temperature, we do not have the disease distribution in some areas. So we should know what is that lower temperature. It means the knowledge of thresholds is very much required for assessing the impact of climate change. Rainfall, we know it's very important. It creates the breeding habitats. Even it can flush out the existing breeding habitats also. In dry conditions also sometimes outbreaks can come. So this dynamics is very complex. From area to area it differs. When Dr. Gore was there, I studied this Gorakhpur area. It is full of waterlogging. So this has to be related. Means landscape mapping. What is the relationship of this waterlogging with AES? That has to be. Then which areas are outbreak prone, which are not outbreak prone? That also we can determine based on the climatic conditions. So everybody knows about these projections by IPCC, Intergovernmental Panel on Climate Change. That is the scientific body in the internationally. It provides projections for the 2100. We expect around 4 degree rise in the temperature, sea level rise up to 0.59 meter, and erratic rains. Means whenever we want rain, there may not be rain, and there may be rains when we do not want. Means sometimes disasters, droughts, floods, these are likely to happen. These are major vector-borne diseases in our country. We have 6 diseases for which we have national program. But for some diseases like KFD, scrub typhus, we do not have any national program. Dr. Yadav highlighted the importance of scrub typhus because we get some data from IDSP. Even sometimes research papers provide more data from that particular area. So scrub typhus is an emerging infection. Similarly, KFD, there is no active surveillance, though some active studies periodically sometimes they are taken, but not a national program. So that is why we are worried about what is the impact of climate change, how it is affecting the distribution of vector-borne disease. So you can see from this map, KFD was confined to only Karnataka. Now we are in Kerala, parts of Goa also. So these questions force us to think, what is the impact of climatic conditions? Why don't we project the future scenario of the disease that we can do? Dengue, Uttarakhand was free from dengue. 2009, we received one outbreak we witnessed. Himachal Pradesh is reporting outbreaks. So these are hilly areas. These are the new emerging diseases. CCHF, leptospirosis, typhus, these are the emerging issues. Before assessing the impact of climate change, we should have the knowledge of thresholds of temperature or relative humidity. For some diseases like malaria and dengue, to some extent, we know the limits of temperature between which transmission of malaria or dengue is possible. You can see from the slide, 18 to 32 degrees centigrade within this limit transmission is possible, though optimal temperature is 24 degrees. This scenario of temperature itself describes how the disease is highly endemic, low endemic, or no endemic. This is the impact of climatic conditions. In dengue, slightly lower threshold is there, 13 to 35 degrees centigrade. For chikungunya, almost same parameters. For Japanese encephalitis, exact thresholds are not known, but based on the occurrence of disease in Gorakhpur, we derived that JE occurs between 20 to 32 degrees centigrade temperature. Same situation was for Kalajar. Exact thresholds are not known. No experimental studies, but based on all literature, we say that 7 to 37 degrees is the limit between which transmission can take place. For KFD also, we derived these parameters from Shimoga. This table is just to highlight, if the temperature is 20 degrees, the development of parasite in mosquito will take 22 days. If it is 25 degrees centigrade, it will be shorter, 12 to 14 days, it will be over. So if the temperature is low, transmission will be very slow, it will not be highly endemic. If the temperature is conducive means when we call air conditioned temperature like Jharkhand, Chhattisgarh, Odisha, comfortable temperature for mosquitoes to live, survive, and development of pathogens. rainfall, we were not knowing, we know that rainfall is related with malaria, but how much rainfall, we were not knowing. So based on 20-30 sites, we studied this aspect. We studied some outbreak-prone districts in different parts of the country. And then we identified, yes, district to district it varies. From some areas, 80 millimeter rainfall is enough. In some areas, 200, 300 millimeter rainfall and the threshold of transmission is required. Here you can see from this map, this part remains with saturated soil. Here the lag period is there. Outbreak of 1 month is not causing the conditions in the same month. If rainfall occurs in July, it will lead to outbreak in August or September. So it depends on the soil conditions that the lag period between rainfall and occurrence of disease or outbreaks is very. Here in Rajasthan, you can see 2 to 3 months lag period is there. But in eastern side, even same month or 1 month lag is sufficient. So these are the thresholds of rainfall we derive for so many districts. It is a published work. If somebody wants to have detailed knowledge, you can have the idea. In Rajasthan, even more than 70 millimeter rainfall. We have identified even the month, in which month, if this much rainfall occurs, outbreak may be there. But one thing we should keep in mind, if there is no parasite in the community, nothing will happen. So these parameters we have to keep in mind. Means parasite load should be there. This just to highlight the importance of rainfall. In Sri Lanka, outbreaks occur when there is no rain. In our country also, there are some areas, rain always does not cause outbreaks. Even drought conditions can also cause it. So because of the diversity, geographic diversity in the country, we should analyze district-wide at least. Here you can see in Sri Lanka, this is wet part, this is dry part. If in the dry part, heavy rains are there, outbreaks will come. In the wet part, drought will lead to outbreak. So this is the intricacy of rainfall. So that is why analysis has to be monthly basis, district to district. Even in some hilly areas where the terrain is undulating, even within the district there are variations. This is the effect of temperature. Why we say Kerala has more dengue, southern India has more dengue? It is because of the climatic conditions. You can see in Punjab the temperature is from 10 to here 35 degrees. So all the months are not suitable for transmission. Only few months are suitable. But in Kerala you can see most of the time the temperature is 20 to 30 degrees. So here the temperature is most conducive for transmission of dengue virus. That is why you can see here in Punjab, sometimes the extensive incubation period is the time required for development of pathogen in the body of mosquito. It may extend up to 74 days. It is 5.809. So only in post-monsoon season, Punjab is suitable. But in Kerala, you can see almost all the seasons, all the months are suitable for transmission. So it speaks about the genesis of high endemicity or how high the incidence of dengue. For Japanese encephalitis, you can have this idea. Here rainfall is there. It is accumulation of rainfall. And in accumulation of rainfall, Culex mosquito, the vector of JE, will breed. We have the knowledge of biology. The cleanest water will be required by Aedes mosquito, then by Stephensi, then by Culex species, and then by Culex. It is the ecological succession of choice. There is one rule of ecology. Two species having same type of requirement cannot exist together. So this is the logic these mosquitoes have adopted. One will breed in dirty water, one will breed in container, one will breed in rice fields, open water. So this is the logic. So knowledge of biology is essential for studying all these impacts. So here you can see the lag period is up to 3 months. You can see here the rainfall is started from May, June, July, August. And then you see the peak of cases. So this is the importance of lag period. So this is because the vector is Culex. Coming to Cash forest disease. I was in NIV for some time. So I used to read the publication of Dr. P.K. Rajgopal, sir. So I was having deep interest in KFD. So somehow because of this aspect of this Center of Excellence, I got the opportunity. So we studied KFD also. In KFD, we have seen that area has to be forested. There has to be leaves on the ground because ticks will breed. After heavy rainfall, when the rain stops, then only the ticks come out and transmission occurs. So here you can see this peak of cases comes after cessation of rains. It is not just after during rain or post monsoon. After when the floor of the forest becomes dry, then only the outbreak. So based on this knowledge, we can derive the parameters, and we can give warning for outbreaks. Coming to impact of climate change, we have used Codex model. That resolution is 50 kilometer by 50 kilometer. So for whole country, based on the climatic conditions required for transmission, we have generated these maps. And you can see here, this is baseline map, this is projected map. So even before this, we have used one earlier model that was precise. District-wise information is available. How many months are suitable? How many months will extend? In Himalayan region, there are foci, not a single month is suitable now, but after 30, 2-3 months are becoming suitable. So these types of maps are showing opening of windows of transmission in some areas in Himalayan region. Himalayan means you can say Uttarakhand, Himachal Pradesh, Jammu and Kashmir. Northeastern side, extended transmission, high intensity. In some areas, no change. So this is the utilization of these maps. We can plan that these are the new areas and we can go for early plan. So the even change detection between the changes. How much is the change? So here you can see from this changes in minus also and plus also. Means extension of window also and sometimes reduction also, because in Odisha very high temperature. So if there is further rise of 2 degree temperature, there may be some months when transmission may not be possible. But we have to have the knowledge of which vector we are talking. So that vector, if it is fluid, it will enter into the forest. It will not die. So what we are expecting, the reduction will be there. There will not be reduction. And mosquitoes are highly adaptive. They can survive in Rajasthan. They can survive in Himalayas. So they know how to survive in Rajasthan. So at least because of high temperature, mosquito will continue to survive. The same way the projections we have studied for dengue also. So what we see in these maps, that in Himalayan region, some foci are opening.
एंटरटेनमेंट है RMRC के लिए.
सर कई लोग जुड़े हैं ऑनलाइन.
But we can detect now this one. You can ask them to know. So same way we studied the impact of climate change on dengue also. The major finding is that in the Himalayan region and in some parts of Rajasthan, the window is extending, and in some areas in Himalayan, window is open. So this is the change. We can detect the change. These are the areas where change in transmission windows is there. For Japanese encephalitis also we try to generate these maps, but in addition to climatic conditions, the basic requirement for J is waterlogging. So that waterlogging has to be mapped over this, then only it will be acceptable. So at present you see the highest transmission is appearing in southern India. What about Gorakhpur? It is showing very low. So it was hub of Japanese encephalitis. So some local parameters about the ecology of that vector also have to be considered. We have talked about the impact of climate change. So climate vulnerability we know, but throughout India, because we have toured many places just to verify the things. In Western Ghat, you can see climatic suitability is there. Southern India, malaria should be suitable for all the 12 months transmission, but endemicity is very low. So what is the reason of those low endemicity? In Chennai, Tamil Nadu, the temperature remains most of the time 30, 34 degrees. So that upper limit is also not very much conducive. That's the reason. In Western Ghat, we can see because of better capacity of human beings. Punjab, climatically suitable, but malaria is very, very low. This is because of the better because of better economic
कोई कनेक्टेड होगा उसका बच्चा होगा अब वो कौन है पता नहीं
कोई बच्चा
वो तो
Can I request all the person those who are connected virtually, they can mute their mics, please. If required, only they can unmute. Otherwise, please, it is requested, please mute your mics.
So adaptive capacity of community, like in this area, in addition to climatic conditions, we have to see the capacity of the community to cope up with the adverse impacts. In Himachal Pradesh, we studied by going through questionnaires and we found their adaptive capacity was good. In Punjab, it is very good, and you can see from this map the darker points, good adaptive capacity. But you see some parts of southern Bihar, means Jharkhand, Chhattisgarh, parts of UP, they are having lower capacity to adapt themselves. So climatic vulnerability, then adaptive capacity of the community, capacity of the health system. All these things combinedly, we can say that this area is highly vulnerable. So this type of studies are required. Most of the work what I am showing is already published. So you can see from the literature. So what we learned from the assessment, either new foci of transmission will emerge, and these are emerging in northern parts of the country. Intensity of transmission in some areas will increase, in some areas will decrease, and some areas there is no change. So the question comes, what should we do by having this knowledge?
445.
That I will share with you under adaptation measures. This was based on models, but on ground also we studied impact of climate change by having the evidence whether climate is really changing, whether vector distribution is already changing, or availability of disease has also started coming in or not. So for that we have established three field units in different parts of the country. Basically in Himalayan region, you can see the locations, and we generated data of climate, vector, and the disease. Nowadays, we need not depend on IMD data. You can have these gadgets. These are available in 15,000 rupees, and you can install in the house. You can get daily, hourly temperature, night, daytime analysis. You can do very well these types of gadgets. This tidbit is for recording temperature. What we have learned here, one temperature is not only responsible for transmission. Three types of temperatures are affecting the dynamics of mosquito-borne disease or insect-borne disease. What is that? Water bodies for mosquitoes, indoor temperature because it rests most of the time, outdoor temperature because it is breeding. So these temperatures are different. Outdoor temperature is something else, indoor temperature is different. So this is the dynamics of temperature, and most of the time mosquitoes passes their time indoors. So this study gave us the idea that in Uttarakhand, outdoor temperature was very cold, but the mosquitoes collected from indoors, they were found positive for mosquito parasite, malaria parasite. So it means indoor temperature was warmer, suitable enough for transmission of malaria. So what is the impact of climate change? Actual impact, we were having a field station, we generated this data. In hilly area or some areas, 2 to 3 months availability of vectors was there. Only 2 to 3 months, and the density of vectors was up to 30 man-hour density. But recently, in 2009 to 13, we did this data, and we found that mosquito density has reached up to 130, and our density, and mosquitoes, the vectors are available for 7 to 9 months. So this shows the availability of mosquitoes for longer time, and their density has also increased. And we got malaria positive cases from hilly areas of Almora and Nainital. There were children also. There was no scope of migration. To eliminate the migration, then you can have this idea that the mosquitoes collected from the houses were found positive for parasite. So you can see, and even in the month of November also, Preparedness was found positive. So November temperature outdoor is not suitable, but indoor temperature was suitable so that mosquitoes and parasites were surviving. So in such a situation, transmission can take place. Recently, this paper has come up yesterday. KFD. The left-hand side map shows the reported distribution of KFD, and the right side is based on the bioclimatic factors. This is the projected scenario of KFD based on distribution of ticks. You can see these areas are low, high, or moderate based on the distribution of current. So these types of models give us the idea that we should have that in mind, that these are the possible potential areas which can have the expansion of disease. For KFD, we have provided this map. So the limitations of this type of work remains. If there is good intervention measures, nothing will happen. The projected scenarios, we should not worry about them because malaria is in elimination mode, leishmaniasis is in elimination mode. So if we go for strengthened intervention measures, nothing will happen. We eliminate the parasite. We should not worry about the climate change. Many countries have eliminated. There is no impact of climate change. You have to eliminate the parasite. That if there are ecological changes, then we change the whole scenario. Like in Assam, minimus is not available because of deforestation. Tulis species has come up. I cannot show all the slides here, but we have studied that. Now, Tulis species is pairing, and that is resistant to DDT, so it will become a problem. These types of ecological changes can alter the scenario. So in adaptation measures, we have learned two things, climate variability and climate change. So in climate variability, by studying the impacts like air and correlation coefficient, we have identified so many parameters which Dr. Stuti explained. This cumulative rainfall. This is publication based on cumulative rainfall of some months, we can predict that the coming months we will have outbreak. So one can have this publication to go through. Then normalized difference vegetation index. In some areas, because of undulating terrain, the rainfall does not stagnate at that point. It goes somewhere else. So rainfall of some parts, it goes and stagnates somewhere else. So if we relate the relationship between rainfall and that disease, there will not be a relationship. So to overcome this, there is parameter of satellite, it is vegetation index. It is, the basis is water stagnates and there is growth of vegetation. Then we find out the correlation. It is very much useful in desert area. Rajasthan, Gujarat, we studied. For desert area, the normalized difference vegetation index is there. Another temperature condition index. We found this parameter useful for northeast, where vegetation is very good, all the time good vegetation. But if temperature is slightly increased, that gives very good moisture and that is very suitable for survival of mosquitoes. So we studied the outbreak of malaria in Tripura and we found this parameter is very good. I am not showing all the things because of shortage of time. Then there is one parameter, El Nino Southern Oscillation. Before 6 months, or if you go through the website of Climate Prediction Center, NOAA, you have the projection for coming next 12 months. You know, coming 12 months are going to have heavy rainfall or normal rainfall. These things are available. So based on El Nino Southern Oscillation, we can provide some projections that at least coming months are going to have wet or dry phenomena. So it gives bit better time to be alert. And then you utilize all the other parameters. Then case mean ratio, just based on availability of cases, we can determine that malaria outbreak is likely to come or not. Then thresholds of rainfall, we have identified if this much rainfall in this month occurs, it may lead to outbreak. So these tools we have identified, we try to hand over to program, we validate this tool also, but in addition to rainfall, there is requirement of intervention measures also. What is the parasite load? Already there. So there has to be some parasite load. If this much rainfall occurs, then only the outbreak will come. So this we are going to refine. It's just to highlight that this vegetation index will work in Barmer, Bikaner, Kutch, but it will not work in Banaskantha, Mehsana, nobody is from Gujarat, Patan, Dr. Rajnikant is from Gujarat. So he is from Gujarat, so no problem. So Kheda and Banaskantha, full of vegetation, so NDVI will not work.
मेरा चेहरा एकदम 360 डिग्री 180 डिग्री घूम गया है Even Dr. Ashish Sharma worked there. We can't forget him.
So this is the TCI. You can see in outbreak area. If the TCI in the month of April is around 40 or less, outbreak is likely to come. We tested this TCI in Tripura. There was outbreak of malaria in 2015 also, and we found yes, in the month of April we can go for this indicator and we can detect outbreak. This is the impact of El Nino. This is also published work. In this area, if there is rains, this area will have outbreak. This part of the country, if there is drought, it may have the outbreak. So this type of information provides lead time. 4 to 6 months ahead, we can know that the coming months are going to be suitable for outbreak or not. So now coming to the adaptation measures for climate change. So in climate change, we have learned that new foci are likely to come up in Himalayan region. What should we do for new foci? Only health education. Because we have seen the areas which do not have the disease, people are not knowing what is chlorophyll. They don't know. They don't have any nets. So health education has to be given because this is the preventive measures to avoid the bleeding. Yes. Yeah. So yeah, I was asking about I think Stuti, that any type of mosquitoes. No, mosquitoes will come for some months, maybe 1 or 2 months. So then they will make out their houses, they will pay their homes, and they will start breeding indoors. Maybe it is
retention is not there. Yes,
So in new foci, health education is the only method. We can educate the community about the breeding habitats, preventive measures, and what are the preventive measures if you fall ill, and these are the symptoms of disease. In already endemic areas, because of the extension of windows of transmission, the timing of spray is likely to change. So we have to analyze this district-wise, that you were going for round in the month of March or August. And if the extension is for all the 12 months, then you have to see the timing and number of rounds of spray. That will also change. Then only it will be effective IRS. In long term, health system has to be strengthened because in some areas, deficient health system is there. So then only we can go for this. So this is just to share with all of you. Now we have national program on climate change and human health. There was national vector-borne disease control program, but seeing the importance of climate change, Government of India has established this department in 2019. And just like national program, we have state nodal officers, district nodal officers, two consultants almost each state, and they are being trained. We have been training since in 2020 also. We train 30-40 persons at a time. They are being trained. These are the threats of climate change. So capacity building, their health adaptation plans are being prepared. We have submitted draft also. That this has to be done. Identification of hotspots. So I will suggest for this area also, like for this station also, identification of hotspots is essential. Then training needs, capacity building, logistics. I had written way forward, I did not write because Dr. Rajnikant has given the theme of emerging, re-emerging design, what should be done. So I thought of just writing, mapping the ecology of JE. What is the ecology of JE here? So that can be mapped. Then script types, ecology of script types. Because it is different from Rajasthan, different from Mizoram. So you have to find out where are the sites of rodents and mice. That has to be mapped. Then based on that mapping, you can say this area will be free. This area, high risk. Then vulnerability of communities also. We have already undertaken some community-based surveys. So you can find out these communities, I think, very much vulnerable because of so many socioeconomic lower indicators. In dengue, what are the most preferred habitats? And what is the relationship with water supply? These two parameters you can study very well. Leishmaniasis also. Eastern part of UP is also endemic for leishmaniasis. Last month we were for assessment of leishmaniasis in West Bengal. But this part can be very much, it can claim for elimination if you, this institute like RMRC, go and survey those areas and you can pinpoint the villages. Based on village level map, you can say that only 5 villages are endemic for this leishmaniasis. And you will be, I think, first to say that yes, we have eliminated this leishmaniasis from this area. The landscape epidemiology. Because while coming here, you can see a lot of waterlogging. From the plane itself, one can find out what is suitable, what is strange here. Full of waterlogging. This waterlogging is suitable for bullets, some other mosquito, some other disease. So it has to be related. So landscape epidemiology can be utilized. So satellite, GIS, climate, all the other basic biology of mosquitoes, parasites, viruses. And I wish that this institute will be a hub in this area and it will be international. It will cater the need of Nepal, Bangladesh, and all this portion. And it, like script address, you may be the leader of it.
Yes, we have
I
to
wish you all the best to you and your team.
Thank you so much, sir. Thank you. I think we need a one-day full-fledged symposium on the climate change and the impact.
These are very innovative.
Yes, very good, very good.
And we had started giving training also. I think they were here. When Gorakhpur was in Bhubaneswar, so some 12 persons from ICMR and 12 from state governments. We started hands-on training. How to create a map, how to analyze, not theoretical training.
Yes.
How to find out the relationship. Is it important? Correlation, lag period, generation of map, GIS, remote sensing, everything hands-on. This just my experience. Thank you very much.
Okay, sir. Thank you so much for your valuable time. Very informative talk. So many areas you touched upon, and I think we have seen the sharp rise in the dengue, and definitely it was because of the impact of climate change. So thank you so much for very important informative talk. Definitely we will find another day for more discussion on climate change. Now we are moving to the last session 4 of AES research experience and future needs. So we are just changing a minor change in this program. We have speakers Dr. M. Bore, Dr. Manoj Murekar, Dr. Amita Jain, Dr. Vijay Bondre, and Dr. Mahima Mittal. If I ask each and every person to speak individually, I think it will take 2 hours. And we are already running ahead of running shortly behind 1 hour, already short of the time. So what we are planning that instead of having an individual talk, can we convert it to a panel discussion? So Dr. Murekar, he has worked extensively in this area and he has a vast experience working on JE and AES. So I will request Dr. Manoj Murekar if he can moderate this session, and we would like to hear the experience of Dr. Bore, Dr. Amita Jain, Dr. Bondre, and Dr. Mahima Mittal while she was in the PRD Medical College and working with the ICMR, and now she has joined AIMS. So I think that will be much better. So I will request Istuti, Dr. Istuti, if she can brief about Dr. Murekar, and then I will request Dr. Murekar to moderate this panel discussion. Over to Istuti.
Dr. Manoj V. Murekar, he is the director of NIE Chennai. Dr. Murekar's research interests include infectious diseases, epidemiology, vaccine preventable diseases, and disease surveillance and outbreak investigation. Dr. Murekar was also awarded the Major General Sahib Singh Shogate Award of the Indian Council of Medical Research for his contribution to the field of viral hepatitis among the tribal population of Andaman and Nicobar. Dr. Murekar also worked with the World Health Organization Western Pacific Regional Office as a consultant and professional staff member in Papua New Guinea. and Philippines. He has published more than 100 articles in peer-reviewed journals, and he is the associate editor of the journal PMC Infectious Diseases. Now I would like to request Dr. Manoj V. Murekar to start the panel discussion.
Okay, can you hear me?
Yes.
Good afternoon, everyone, and thank you, Dr. Rajnikant and team, for first of all for entering into new house. Big congratulations to everybody, and also for inviting me for this session. And as Dr. Rajnikant has just informed, now we are going to have a panel discussion, and we are going to maybe how much time we have, Dr. Rajnikant? Half an hour, or if you can specify, then we will accordingly.
We can go for 1 hour, and those who want to share their slide, they can share their slide, but not more than 5 slides.
Okay, so let us not have any presentation. But what I think there are five speakers for this session initially planned. So what we will ask is every speaker will first talk. The first part is research experiences on working on JE and AES. So we will ask every presenter to maybe in 3 minutes tell as to what tell me some summary points from their work in Gorakhpur on JE and AES. And then following that, we'll have second part of the panel discussion where we'll work out the future areas for research, because what we really need to do at this point is identify what areas this center or this institute should work so that the burden of AES further goes down. So without further delay, I'll request Dr. Gore, who was officer in charge of NIV unit at Gorakhpur, and I have a long experience of working with him. So, Dr. Gore, can we start with you? If you can briefly describe.
I can do it. But I spent 10 years in Gorakhpur, and stopping me to talk even for 10 minutes is I protest with Rajnikant to start with. And for everybody who are there in RMRC Gorakhpur, they can watch. I have sent the slides. So read those, saw this, and I have given advice also for future. So other than that, I do not want to talk anything more than that.
No, Dr. Gore, I will take this moderator's prerogative. I will give you 5 minutes to talk about your experience of working or establishing NIV unit, and your experience initially in...
No, unless you see the slides, you will not understand where you are now and what I've entered in. So I'm sorry, I'm not going to talk anything about it. You know everything what I have done.
But there are a lot of...
I'm actually leaving the meeting.
No, Dr. Gore.
Proceed. How many slides do you have, sir? How many slides?
No, we will have full...
Please go ahead, no problem. We can hear you, we can listen to you.
So open the slides first.
Okay.
Okay, next. Next slide, please. So I started with 2005 when there was an outbreak, and I went to Gorakhpur and started JE ICMR LISA. Then I continued in because outbreaks was there continuing in 2006 and 7. We isolated 76. Next slide, please. Next slide, please. So in 2008, because after approval and all that, I reached Gorakhpur and taken over the RMRC, OIC as a NIV unit, and carried out the work line and other things were there, and we got a lot of data just because of sitting at it. Okay, next slide, please. So this is the situation we got in. So within 10 days, there was a flood, and without anything else, there was nothing else around it. And from there, I started to NIV Gorakhpur. And the background of the second slide, background, that is your RMRC is there. Next. Next slide, please. This was the situation in Ward 6 in Gorakhpur, BRD Medical College, and the situation has improved. Next. And the condition of the water contamination and sanitation and other things was not around there. Okay, next. We started a job and collected the things and collated the entire data. Next. And this is the GPS based, and the clusters where AES was there, and that has not been followed further in other situation. Next. And just because of the looking at the line list, one can come to this kind of conclusion, because which are the hotspots are there, and AES and JE and other things. Next. So this was the situation. JE was very low because the vaccination had started, and AES continued to increase. Next. And we got the enterovirus RT-PCR in CSF and rectal swab also. And that is what is the Basti group, Basti division was having very low concentration of GE or AES, but it was very high in Gorakhpur division. And that was associated with the land and other things was also there. In addition, the water logging also was there. Next slide, please. So we started, by the time 2010, we developed the lab and we started doing on our own, the PCR and everything else, tissue culture was there and all that. With help of PATH and other things, we carried out the efficacy of the attenuated vaccine. Paper is published by Tandale. Next. And this is what our lab at that time we started. Next. So in 2011 to 14, all the groups, VCRC, CRME, NARI, NIE, ERC was there. And ERC that time, now in NIV unit in Mumbai. So they found 86 enteroviruses in normal children in that region, just in Gorakhpur. And there is a huge contamination of water everywhere. And that was there. Another important thing is NARI carried out a socio-behavioral change program to provide the model. And this was taken over by the CM Sahab, and which is labeled as Dastak in UP, because even Prime Minister also approved it, kind of thing. NIV and other things, CDC unit came and looked after the lab and approved it. Next. This was the kind of documents we made. One with first one is Dr. Kushwaha majorly, and the second line is by the Sima Sahaya of Nari. And these are very useful for the RMRC people now, the staff. They should read those things, find it out, and it will be very useful for them. Next. So then we started, in 2012 to 2015, I started the establishment of RMRC. And the main theme was the service and research and on different diagnostics and other things was there. One of the problem is that the design of the lab. We required the animal house, but it has not been developed in the thing. There are a few suggestions. I will talk to Rajnikant later. Next. And organization plan was, which is in documentation was there. And that has to be looked after, because one of the theme is, do not make a department, malaria department, filaria department, or JE or AES department and all that. Combine everything. All immunologists people should come together in one lab and whatever the thing, epidemiology and 1, 2, 3, 4 different designs are there. So they should combine together and discuss the entire thing, because one disease will have a different angles from environment to immunology to other things, and that is what is needed next. And these are the groups you all know, and that is what the job of RMRC is very huge, and that is what is there. Next, please. So one of the thing is the staff which is going you are taking now. One of the thing is, in addition to the diagnosis and other things, the officers should take the students, and because they will be TA or PhD students and other things, and they will work combine with the health system for UP and other people. And for the bioinformatics or bioinfo or whatever you call it. So we want to develop mobile-based, COVID-based kind of thing from each disease, tuberculosis and filariasis and EES and everything else. Earlier, when I was there, dengue was not there, but now because of urbanization, dengue also has increased, and like we have seen in Lucknow, we'll start getting the encephalitis by dengue also in another 1 or 2 years. Next, please. And good luck. And if you want any advice or any things, I am always available on my email and WhatsApp also, and etc. The phone numbers and emails are there with Rajnikant. Thank you.
Thank you very much, Dr. Gore. Thank you for your sharing your experiences, also about words of advice for the future activities of this institute. We'll come back to these future activities a little later, but maybe now I'll request Dr. Amita, if you can talk about AES etiology in India.
Sir,
that is
sure.
what your talk. Madam, you want to share slides? I mean, I don't.
I want to share slides if you allow me, though I have shared my presentation with Dr. Kamran too. I won't mind sharing my slide. So just give me 1 minute. Let me open it.
But also, if you can, maybe 5 minutes or 7 minutes.
No, sir. I'm there.
Thank you.
So just a minute. Okay. I've shared it if anybody can.
Yeah, we can see. Yeah.
Okay. So I'll be starting now. And I'm so immensely thankful to the organizer for this opportunity. Thank you, Murekar sir, for giving this opportunity to me. I think we are running really short of time, so I'll be trying to finish as soon as possible. I bring you greetings from my beautiful alma mater, King George's Medical University. So the introduction, I don't think we have to go for this audience. I just want to bring out one point here, that the definition of acute encephalitis syndrome was actually, this was the term which was coined by World Health Organization, and the purpose was syndromic surveillance of JE. So they have included every possible etiology in this, so that this was kind of a screening definition. That was not a diagnostic definition, though we know that the viruses are most common causes, but because of the loose definition, a lot of other causes are included into that too. As per WHO, this is a person of any age, any time of year, with acute onset of fever and change in mental status. So anybody fitting into this, if we see clinically or carefully, probably everything which has infectious nature and the neurological manifestation will fit in. The definition also does not talk very clearly about the term acute. So after long of deliberation, it was decided that let's say take 14 days as it was a consensus that 14 days will be taken as a cutoff for this. There are other terms which are related, and they also kind of included in acute encephalitis. For example, encephalopathy, acute meningitis, meningoencephalitis, and if we look carefully, the etiology of all the three is included in AAS2. So AES is not only encephalitis, it has the etiology of anything which is acute in nature, involves the brain, and is with fever is acute encephalitis. There are more than 100 infectious agents. Viruses are predominant cause. Other infectious agents like bacteria, fungus, parasites, spirochetes, even chemicals and toxins are included. They change with season, geographical location, age of the case. Some are not directly causing encephalitis, but are causing encephalopathy. So there are many causes, and the viruses are predominant cause. If you look at this slides, it's really busy. These are the viruses which are known to cause encephalitis. The ones in orange or red color are the ones which are commonly reported from our setting. Japanese encephalitis, now even West Nile, herpes group of organisms, the whole group, and even the enteroviruses. So these are the common viruses which are causing encephalitis and are reported from India often. Rest are not reported from India that often. Viruses which do not cause encephalitis directly, but as a disease complication, they are not neurotropic viruses, but they, as a disease complication, they cause encephalopathy or encephalitis. And there is a long list. We can see the dengue, a common cause, common pathogen which is isolated, which is detected in these cases, chikungunya, rubella, influenza, measles, mumps. And I think there are occasions when all of us have picked up one or two cases of influenza, parainfluenza, Nipah, adeno, parvo causing encephalitis. So they are often being detected from CSF. Rabies virus is an endemic in nature in India and causes serious encephalopathy. Then there are a lot of non-viral agents, and at this point of time, non-viral agents are taking over the viral agents. Not to forget that scrub typhus is one of such disease. Cerebral malaria is one such disease. Leptospirosis is one such disease. So these diseases are commonly now being picked up and are being diagnosed as encephalitis, though this is a very exhaustive list. So if you look at all the causes, I have probably enumerated around 100 infectious agents here. Then not to forget the non-infectious inflammation. And then there are a lot number of causes, even head injury, Rice syndrome, diabetic coma, acute disseminated encephalomyelitis. In Bihar, we have frequently talked about lychee associated. We still do not know where there's no consensus on the pathogenesis clearly, but it's occurring as an outbreak often, and this is one of the disease. What I'll be showing you some data is about that AES data in UP and Bihar, which we have taken as a study, one in UP and one in Bihar. We have data like that. That's kind of, we can show you a trend starting from 2012 till now. So it's almost a 10 years data, which we have been publishing from time to time too. So if you look at that, JE has been consistent since then, around 7 to 10%. Rest of the causes, they are not that often. The other one, which is dengue virus. Chikungunya has started occurring after 2016. Before that, it was not there. Scrub typhus, since 2014, we have started reporting scrub typhus as an important cause of encephalopathy. Then there are some bacterial causes also. So patients which report as encephalitis, sometimes they test positive for strep pneumoniae or Haemophilus influenzae or something like that. Occasionally, even Mycobacterium tuberculosis, there is an acute exacerbation and patients present as encephalitis. We have in our panel around 35 pathogens which can be taken which we detect often in a case of encephalitis. However, after doing that much of effort, we cannot make etiological diagnosis confirmatory in more than 50% of cases. Sometimes if we go extra broad, we can go up to 65%. Beyond that, they are not being diagnosed. The common causes which we have diagnosed in last year, scrub typhus, JE still 8%. Wherever we are using IgM as a cause, as a diagnostic test, lot of cross reactivity. It's very, very difficult to work out that this is a single infection, co-infection, cross reactivity, co-positive. See, we have even trying doing PRNT, took the help from NIV and one more friend in business, but not much help was offered by that. So this is what it is. Co-positives are very often, and it doesn't seem logical to talk about co-infections. So they are probably cross-reactivity. So if you look at the summary, scrub typhus, 30% plus minus 2, JE 7 to 10, dengue, HSV, entero, varicella. This is last 2 years data. Some bacterial causes. In Bihar, there is an AES-like outbreak often, and we do not know the etiology still clearly. Some say it's a heat shock syndrome, some say it's the lychee toxin, some say still there is an infectious etiology which we are not able to pick up. So there are a lot of theories, no comment on that. Why we have to make an etiological diagnosis? It's a bad outcome disease. We have to understand the epidemiology, and if we do not understand the etiology, we will not be wiser in future. We have to plan immunization. Unless we knew it's JE, we have never thought about vaccination, and we have seen the impact. The JE positivity has come around for 40% to 8%. We have to chart preventive strategy. So unless we know the etiology, how will we know how to prevent? Then appropriate control measures like water hygiene. If it is enterovirus, we have to go for the water hygiene. If it's JE, we have to see that the pigs are kept in isolation and things like that. Public health intervention. And top of all this list is the patient management. If we pick up a cause for which we have a therapy like herpes or scrub or bacterial, it makes sense to save the life. Early diagnosis saves the lives. If you start the treatment early, your patient outcome is going to be entirely different. If you look at the current scenario, it has improved significantly. And I'm mainly referring in terms of UP. It has improved significantly in terms of research, healthcare facilities too. Vaccine against JEV and their treatment options which are under trial for Japanese encephalitis. Following vaccination, JE encephalitis has gone down. However, the number of total AES cases have not come down really, though mortality has decreased and encephalitis due to Japanese encephalitis virus has decreased. However, there have been some emergences of new viruses like Chandipura, Nipah viruses in some part of the country, and non-viral etiologies are somehow getting more common. Since 2012, the multi-pronged approach helped us to control the encephalitis, especially in Gorakhpur region of UP, to a large extent. It was not possible. We could not imagine that we will be able to control this disease. This was like a light nightmare every rainy season. Multi-pronged approach, organized and well managed approach, and commitment has shown AES cases have declined since 2012. Important interventions which have been done are, one is JE vaccination. All the children in endemic area are given one dose of SA 14-14-2. The Dastak Abhiyan, that is door-to-door campaign to cause awareness. Cleanliness drive, provision of safe drinking water. Better equipped healthcare facilities. The time matters from patient to the hospital, from home to hospital. Time has been reduced, and that golden hour matters. If the patient is managed early, outcome is different. Government and NGOs have provided proper nutrition to AES cases as well. Alternative professions so that they can shift from pig rearing to some other profession, or they can do the pig rearing in a more scientific manner. To the children who are challenged due to the sequelae of JE, they have been provided special schools. Vaccines for under a universal immunization program for all children, for measles, for example, mumps, rubella, polio, etc., has helped to reduce the AES. And control of mosquitoes, that has also helped. So vector control has also provided good support to the program. Looking at all that, it's our algorithm, and we have seen that some of the people are using it and are happy. A two-tiered approach of diagnostic evaluation is advocated. One algorithm at the treating hospital, which is usually a district hospital or a CHC, and for a reference laboratory, which is a high-level equipment-intense laboratory with all technologies updated. So for a treating hospital, the aim is to look for causes that can modify the outcome of patient if identified early. For example, if we diagnose malaria early and give treat cerebral malaria early, you don't have to shift your patient and you can manage that. Similarly, antibiotics, similarly, if you can say that it's due to the scrub typhus, you can manage your patient locally. It should be simple to perform tests, no sophisticated laboratory or equipment needed, and the training should be minimal. So looking at that, it looks like very complicated, but if you look at it, if we can diagnose, so most of these laboratories are able to do ELISAs and rapid tests. So RDT for malaria is very good. JEV, they are being trained to perform the JE dengue ELISA locally and scrub typhus ELISA also. So now the training is for all these laboratories to perform ELISAs for JE, dengue, scrub typhus, and chikungunya, which they can perform locally and diagnose these etiologies there. All of them are being trained to perform a lumbar puncture. So they have to do a tap, CSF tap, do the routine CSF examination, do some basic ELISAs and RDT for malaria. They have the facility for doing some biochemical tests, which they can perform. And with all that, some of the disease where the outcome changes with the rapid therapy changes. Initially, they were not trained to do the molecular assays. And with COVID, now every lab, every district lab is being up-geared to perform the molecular assays. Maybe tomorrow they start doing tests for things like herpes and all here too. So for the high-level laboratories where the samples are being transported from district hospital to the laboratory, all the molecular testing and the confirmation of ELISA results are suggested. So this is a lot of etiology, around 35 etiologies in our panel, I've already said, and we can look for that. So I'm just concluding with this, that it's a mixed pot etiology. It's not a single etiology, and AES is a syndrome. It's not a disease. So anything which involves brain with fever is AES. There are more co-positives, and this needs clarification. I seriously feel this is not co-infection, and we all will agree co-infections are not that common. It may occur, it's an endemic zone, but not that often. Arbovirus co-infections or co-positivity is very common. There are pockets of scrub typhus infection too. So it's a treatable disease, and if we can prevent it and can start treatment early, we can save lives. And we should not forget the bacterial pathogens, though we focus on viruses when it comes to AES. We should not forget the bacterial causes too. With this, I conclude, and thank you very much for your patient hearing. Thank you, sir, for giving me this opportunity, and I wish all the best to Dr. Rajnikant and his team. Thank you. This is some snapshots from my lab.
Thank you so much. Thank you. Dr. Manoj, over to you.
Yeah. Okay. Thank you. Thank you, Dr. Amita, for nicely summarizing or talking about the etiologies of AES, and especially the two important takeaways from your presentation is the 3 or 4 etiologies are very important: Japanese encephalitis, subtyphus, dengue, and some of the bacteria like H. influenza, type pneumoniae, which could really help in management.
Sir.
The algorithm that you and Niman's team led by Dr. Ravi, which
Yes, sir.
that
Yes.
was piloted in different districts of Gorakhpur, is really useful. And we'll come back to this when we talk about future priorities for this institute.
Okay,
So may I now request Dr. Bondre, Dr. Bondre, only 5 minutes for you. Sorry.
I will take 5 to 7 minutes and just share the slides.
Thank you. Thank you.
Okay. These are visible?
Yes, yes.
Visible.
Okay, first of all, I would like to congratulate Dr. Rajnikant and the team ICMR RMRC for the inauguration by the Prime Minister of this country, the new campus, the same campus. So, I call it as a Purvanchal acute encephalititis syndrome because this is mostly restricted to some regions which are falling in the Purvanchal. So, am I audible?
Yes, sir.
Yes, sir.
So the journey of NIV or journey started to Gorakhpur in 2005, as Dr. Bore said, when I was directed by the director to become a central team member and investigate what is happening in the Gorakhpur. Especially, this was the first time the massive cases were admitted in the hospital. So during my investigation of 4-5 days in the region, I just got the catchhold of some human clinical samples, and when we tested at NIV, we found that about 35% of the specimens, what we got 45, among them 35% were JE positive. And when we isolated the virus, we find that the virus is more or less just like the virus which was identified first time in 1978 as a massive outbreak. And then after 2005, we deputed our team every year during the entire season of the years in the Gorakhpur region. So what have we found during the decade? The IgM positivity began to reduce from 2006, which was established to 12% in 2010. And now it is lying between 8 to 10% depending on the seasonal variations. So along with the JE, we also detected some component like the enteroviruses because the water channeling and other systems are not that standard there. So most of the enteroviruses were detected, and these were also the pathological changes were also detected in the biopsies of some of the patients what we performed there. And whatever the agents are globally known or unknown, we tried to identify with multiple resources, multiple collaborations. We did not got any answer for these collaborative studies or any of the individual studies. So to support the investigation there, Dr. Gore, under Dr. Gore, NIV established the Gorakhpur Field Unit in 2008. And we took care of the manpower development, their appointment, their training, laboratory establishment, purchase of different equipments, and giving the, calling the staff from the Gorakhpur for the training at NIV. And during this time, our search was going on, but still there was no answer. We also conducted a lot of animal serosurveillance, human serosurveillance, and JE was found to be the predominant in animal as well as the human cases. Along with the JE, we also identified hepatitis virus and some other scanty viruses. To get the answer, we had a collaboration with the Columbia University with the suspected isolates for the characterization and the human clinical sample. However, they tested it by multiple assays, which are very high-class assays like viral isolation, random amplification, mass spec PCR, next generation sequencing, but all the investigations were found to be negative. So what we understood during the last 10 years, 2005 to 2015, that historically 7 districts of Eastern UP are more affected by the AES. And during the period of 1 decade, about 29,000 AES cases were hospitalized with about 21% death. And annually, more than 85% JE and non-JE cases occur during the particular season of July to November. And most of them, about 90%, belong to the low socioeconomic strata, and they have the pediatric cases. Now, if you see some of the pictures here, the seasonality of the infection was more or less standard for years together, whether it's a JE or the AES. They were going hand by hand during July to September. And the age group was mostly affected. You see the picture. the 1 to 10 year or 11 year is the most affected age group, whereas the AES was less documented in the elder population. So during the time, we also documented the introduction of new strain of JE. So we also started looking what is the impact of the import of new strain and its establishment, whether the vaccine, which is based on the AC14-14-2, is going to be protective or not. But we got the good successful results. In between, we also had the collaboration with the IGIB for the genomic characterization of some of the agents. Apart from JE, we did not got any more success. We also tried to push the human clinical samples into the monkeys at NIV, but apart from detection of parvovirus 4 and parvovirus 19, there is no success. Again, we had whatever the results we got from the Columbia University, they just confirmed that whatever the detection we had, JE and enterovirus, they were correct. And after that, when I joined the Gorakhpur unit, apart from JE, I started looking for multiple agents, more than 30-35 agents. And till my investigation was not going more than 25 to 30% etiological identification. So there was a huge question. In between, there was a suggestion from ICMR with the help of the expert team, Dr. Gupta, Dr. Gadkari, Dr. P.L. Joshi, who started looking into there is a necessity of looking into the bacterial infections like scrub typhus and rickettsial infections. So that was the time we started looking into, when Dr. Manoj Murekar was also there, part of that, all the investigations. So the most of the cases were documented from 7 districts of UP, 3 adjoining districts of Bihar and bordering areas of Nepal. And individual contributions by state health organizations, multiple institutes, NIV's contributions, lot of efforts by the pediatric one, they were all not coordinated very properly. That is why then BRD Medical College and ICMR took up the challenge of establishing the AES cell for streamline processing and collection of the sample, testing of the specimens, their archiving, their storage, creating a database and giving the reports in very time, and the data can be used for the epidemiological and diagnostic details. So the cell was established with Dr. Mahima Mittal. And we at NIV, at the Gorakhpur unit, we developed some of the algorithm for testing of the agent, which include most of the suspected etiology associated with AES in the country. And after approaching, we were with straightforward approach of testing for multiple agents, JE, measles, mumps, rubella, dengue, West Nile virus, and all the agents. We got that in 2016-17, the etiological identification was reached to more than 80-85%. That was the time when we took up the scrub typhus, and we found that whether it's a CSF or serum, the patients are having more than 60% of the positivity for scrub typhus, along with 10 to 15% and some 20% of the other things, including the dengue virus. And after that effort, whenever it was communicated, you can see the lower graph. After implementation of the proper treatment at PSCs, CSCs, and whatever the centers were available, the death rate really started coming down after 2016 and 17. This was one of the very successful story I can call it as. There are some of the generic analysis of scrub typhus, other rickettsia, dengue viruses, what we isolated from that region. And this was the outcome of the team effort from all the staff members of the that time Gorakhpur unit, NIV Gorakhpur unit. They had a lot of good publications. So I will come to the research mandate afterward. So definitely I would like to thank Dr. Soumya Swaminathan, who was the Director General and Secretary Director working that time, Dr. D.T. Moria, who was the Director, Dr. Milind Gore, who was my ex-OIC during that time, Dr. Nivedita Gupta, who was very much instrumental in supporting the unit in whatever the emergencies, Dr. R. Lakshminarayan, who was working as a Senior Administrator Officer here at NIV, he has supported in very extreme ways. Dr. Kushwa, who was very much instrumental to take initiate the collaboration between the NIV and the BRD Medical College. Dr. Murekar was always a partner in all the...
Dr. Bondre, can we just wind up in
Yes, Dr. Mittal, Dr. Guptesh, Dr. D.K. Srivastava was very much support to us, Dr. A.K. Pandey, and all the team members of the BRD Medical College. Thank you.
Thank you very much, Dr. Bondre, for describing your experience of work during the last 7 or 8 years when you were at NIV Gorakhpur. So while there were several efforts happening from ICMR side to understand the etiology of AES, the Department of Pediatrics was one who was managing the patient and managing not only patient but managing the entire show. There was a lot of political pressure always when deaths were happening, and it was earlier Dr. Kushwa and then Dr. Mahima Mittal who were leading the fort, and she has been basically treating and managing the patients in last so many years. So I think I'll hand it over to Dr. Mahima Mittal for sharing her experience of managing pediatric AES patients. Over to you, Dr. Mahima. There are 38 slides. If you can finish in 5 minutes, we'll be very happy.
Nice to be amongst family again. And I always think like NIV earlier and RMRC now, it's family for me. I've worked a lot with them and I've done great work with them. And I congratulate Dr. SD Khan for the RMRC building, beautiful building being built here. Sir, I will take 5 minutes only, don't worry.
Okay, sir. You can take 7 minutes, no issue.
You have time up to 5:30.
You deserve 10 minutes, Mahima.
So I will not waste much time. All of us here know what the scenario was here at BRD. The first outbreak, it all started with the first outbreak in 1978. And ever since we have worked, and earlier the main etiology behind the AES here was JE, and as a clinician, I would like to put up some clinical presentations that were present at that time. The patients coming to us were basically coming with convulsions, altered sensorium headache with a short incubation period, short duration fever. And sequely, in such case, the mortality was quite high. It was around 38-31%. And there was a high sequely in these cases, ranging up to 45%. And this is how we would see the patients. And with time, there was increase in the resources, the NIV came in, we got more diagnostic services, the number of beds increased, and the JE vaccination started. And so we could see that there was a decline in the JE, but the AES numbers remained the same. So again, the dilemma was as to what was causing this AES. Clinically, we could see that there was a difference in the clinical presentation of patients, and these patients presented with more of hypotonia, and there was a bit of edema in those patients, and they did not present to us with convulsions. They mostly presented to us with altered sensorium. So we kept on looking for different. This is how the children used to come with us. To us, and the periorbital edema that we can see here, and hypotonic child. And if we could just look at the children and differentiate that this is JE and this is something else. And then, like Dr. Gore, Dr. Kushwaha, and all the stalwarts, they did some good work and they brought out some etiologies. And at that time, we thought it was enterovirus, and everything pointed towards this etiology. Because here also, the patient presented with multi-organ dysfunction. And around Gorakhpur, in Lucknow, and everywhere, the enteroviruses was coming out as a main etiology. So this is what we believed. And since the treatment was again supportive here, no definitive cure, so we were doing our bit, treating these patients, but there was no decrease in mortality. So we started looking for other etiologies, and in around 2014, there was a team sent by the ICMR from the Manipal Center, where they did a study on 250 cases. And they suggested and they found that there was a high rate of scrub typhus. There was 61% scrub typhus positivity. And so our treatment pattern changed, and we started giving azithromycin to all the patients who were coming, all AES patients. And we were skeptical about the diagnosis. We did not believe that it was scrub because we did not see the kind of change in mortality pattern that we were expecting after giving this treatment. So as clinicians, the points that were supporting in favor of scrub was a high proportion of IgM and a multi-organ involvement. But our queries were, why could not we see the kind of scar that we see, which is diagnostic for scrub? Then why is it is affecting only the young children? Why not the adults? Then our query was why AES is the primary presentation, wherein scrub was described where the most common presentation was pneumonias, and that we were not seeing. Then cases with non-AES manifestations were not widespread. So there were some queries in our mind, and we were not ready to believe, although we were giving treatment, but we were not ready to believe that it was scrub. We wanted more proof as to this is scrub. And we did not see the decrease in the mortality. So we did some great work with Dr. Murekar and Dr. Rajnikant, Dr. Bondre, Dr. Gore, everyone here. And so all of us under the aegis of ICMR, we did different kinds of studies. And Dr. Bondre has already said that the main problem or the main difficulty in getting a proper test done was a proper quality of sample that the NIV was getting. So this is I think this is the most important quality step that was taken, the development of the AES. And I must say that this is, I think, the main point for the success story that we are talking about. Because the kind of sample that we could provide with the establishment of the AES cell led to the diagnosis of this, the etiology behind the whole AES thing. And we had a proper data collection also with the help of the NIE. We had a great software where we could put in all our data and then analyze it later. So this is the algorithm which we followed. And the clinical features were just the same: the abdominal pain, hepatosplenomegaly, edema, platelet reduced in platelet count, slight rise in the transaminases, and we could delineate the scrub and the JE also. And the major question that was coming to our mind was, why are we not seeing the decrease in mortality? With the data that we collected, we could show that when we did a subgroup analysis, the patients who were scrub positive, the mortality rates are definitely quite low as compared to who were not positive. So this is one query which was answered by this. And one more query was, why is it affecting only the children? So we dug in our data and we looked for what was the reason. So we took data from the adult side, the medicine side, and the pediatric, and we compared the two. And what we saw was even the adults were coming with scrub. But since we were only testing the encephalitis patients, we were not testing the non-encephalitis patients. And the adults were coming with the presentation was more of liver involvement, more of respiratory involvement, and less of the CNS involvement. So scrub was there, even in adults, but we were not testing for it. So this is all Dr. Murekar's doing that we could see, and the other agencies which we had collaborated with, where we could show the zero. This is the NARI study, where we could show the zero prevalence in the community. And just rapidly, we could, the VCRC did this, where they had collected the setting traps and collected the rodents, and we could show the vector predominance. Then the study with the Murekar sir, which we had done in the community, where we could show the IgM positivity in acute febrile illness. And so we could show that the large pool of vectors who are infected with Orencia, then there is infection in the community, and there is a pool which is presenting with acute febrile illness, if not treated early, could lead to AES. So this is what the whole idea of the AES cell and all the collaboration led us to a diagnosis that we could definitely say that scrub typhus is the most important etiology, and which is treatable. The best part was that it was treatable. So the state government took a step ahead and made azithromycin and doxycycline available in all the health centers, and early administration of this has led to a reduced number of patients coming to BRD, and this is the graph now. there's a large reduction in the number of cases coming as well as the mortality. So I would say that this is a success story. This slide has already been shared by Dr. Bondre. I just wanted to show this slide because I would like to congratulate all of us that after 2016 we are able to only 10 or 15% of patients we are not able to give a diagnosis to. Most of us have been able to diagnose a case and whatever was treatable was treated. So that has led to a decrease in mortality. And so the lessons learned here are that collaborative teamwork is the key to success. So we should not work as individuals, as AIMS or BRD or RMRC, unless we collaborate and do work. This is the kind of success we are going to get. The need of quality improvement initiatives and leaders in research should come forward for such collaborations. So the way forward is, so it's a treatable cause, so we need awareness among the healthcare workers. All has been already been taken up. So and most importantly, what I feel is we need a point of care testing for scrub typhus. I think somebody is already doing work on that, and a continued surveillance, which RMRC I think is going to take up. Thank you so much and congratulations.
Thank you.
Thank you. Thank you, Dr. Mahima, for nicely describing your experiences of working on AES for the last more than 10 years. And the lesson that you mentioned, lessons learned, I think one important point was collaboration. And I think we have not mentioned the we have not taken the name of Manipal Institute. So I think he was the one, Dr. Arun Kumar was the one who first identified IgM scrub typhus antibodies in about 60% of the patients, which provided a diagnosis to a large proportion of AES patients. And also, I must mention here the contribution of VCRC, which documented the presence of infection in rodents, as well as presence of infection in mice. So now, having gone through the history, maybe next 10 minutes, Dr. Rajnikant, if you allow us, we will 10 minutes we'll just discuss about future priorities on JEAES for this center. And maybe I'll again start with Dr. Gore if you are around. Maybe can you briefly tell a couple of priorities, just 2 lines or 3 lines, because we don't have much time. Dr. Gore? I think he has left, or
I think he's not connected now.
He's there.
Gore, sir, in your opinion, sir, what should be done or what the center should do in the area of AES and JE? Having known or having fully known that now we know the etiology, we know how to manage the patients at very, very early, how to refer them early. So what should be the priorities for research for this institute? Over to you, Dr. Gore.
The thing is, from the starting point of the scrub typhus positivity and all that, which is there, of course, scrub typhus is there, but the percentage of scrub typhus is very low, because as a rule, scrub typhus can generate the huge disease in anybody, and person can die also. But when I studied my sero survey samples, 20% of children were positive for scrub typhus. None of them had any IES or anything. And the data which has been generated from the starting point to even today, there is a huge IgG in that. And the scrub typhus testing kit which is there, it has a mycobacterium cross-reactivity. So none of us have looked at it. I tried to do it, but by the time the kits were taken from me to ERC that time, and Dr. Nivedita did not return it. So that is what is there. One has to understand IgG, IgM, ELISA, cross-reactivity with the mycobacterium, and there are multiple things. So unless that is proven, I do not believe the scrub hypothesis is etiology.
Okay. So the point well taken, Dr. Gore. Maybe Dr. Rajnikant, if your team can make a note of this point, looking into the cross-reactivity. Anything from other than that, Dr. Gore, or you're done?
No, I mean, that's enough because I wanted to leave it just because you are a friend. I
agree. Yeah. Okay. Dr. Amita, any advice for this institute for the research in coming years? Madam, are you there or? Okay, in the interest of time, we will request Dr. Bonere to for his thoughts.
So during my working, we are getting whatever the subtypes IgM positive cases we are getting. So there is some literature that the IgM antibodies against subtypes can persist for a long time. But what is the ultimate long time? Because this is the region which is very much endemic for the subtypes. If the case is if the person is harboring the antibodies for 2 years, 3 years, and suppose he comes with some other pathology or some other infection to the hospital, and we test it's a subtypes IgM positive, so that will mislead the clinician while treating the patient also, and that will create a problem. During my working there, I found some of the JE positive cases, they were already vaccinated. Now, why it is happening? Whether the JE vaccine, whatever is the vaccination, the protective immunity is there, is big challenge, or is it what is the longevity of the protective immunity against the JE SA40 vaccine, so that the person can also develop the susceptibility after a few years of vaccination, or is it the new strain which is introduced, because we documented 1 to 2 different variants of the genotype 1, and unfortunately in most of the Southeast Asian countries wherever the vaccination is performed for the JE, the genotype 3 strain is no more available. This is all genotype 1 strain and this variant. Now, even in the vaccinated people, we are getting the JE positivity or the disease, neurological disease, and the patients are admitted. Apart from that, there are there is a very much emergence of dengue there. What we detected during my working there. So all these aspects must be taken forward, and there are some vaccine preventable diseases where good vaccines are available. So it's a public dialogue must be initiated for some kind of things. This kind of vaccine preventable diseases. There is a disease like rabies, which is very much prevalent everywhere. There is a disease like JE, whether the JE vaccination everybody is getting. So that study can be followed up for the which will help Government of India to further implement the control strategies there.
Thank you. The point you mentioned about persistence of IgM antibodies is a. I remember this issue to be discussed when we were working there, and I'm sure Gorakhpur RMRC will take up studies on that. The only issue is confounding because of recurrent infections that has been happening. But you could carefully design such studies. Also, duration of protection because of JE vaccination, and there are definite markers for protection in terms of neutralization tests. You can certainly plan some studies in that regard. Since this session is on JE-AES, we will only restrict our talk or discussion on JE-AES, and will not go to other vaccine preventable diseases. Dr. Mahima, your thoughts on future priorities for this institute? Mainly some clinical studies, it will be really great.
So as a clinician, what I would like to know is the etiology which I can treat. So if be it scrub or not, this dilemma, there would always be this dilemma. But if we see a response, I would treat it as scrub. And I have seen that response, especially in the AFIs which were admitted to our hospitals. There was a dramatic response in those cases who were acute febrile illnesses.
and within a day or two, we could see the response. So if you ask me, I would treat him, whether it is scrub or not, I would treat him as that. And apart from that, herpes is treatable. So we could improve our diagnostics, because right now what we are doing is only doing the test for only those which we are ordered for. Like the clinicians say, they do it. So we could improve in that way. And certainly we would, in the periphery, to diagnose scrub early, because more than 3 days fever, giving a presumptive treatment is not what we should be following, because later on it could lead to some resistance if you start giving azithromycin and doxycycline to all patients. So if we could just diagnose it there, a point of care, if you have a test which could be done in the community itself. So this, and one more thing, the disability, the sequelae that we have in the community, it ranges from around 15% to 30%. So we have to look at the rehabilitation needs of these disabilities in the community. So these are the three things which I think
Thank you. I think these are very important points.
Manoj, can I talk one point, which is useful for Dr. Rajnikant, because there is affinity maturation of IgM. So in rubella, because despite of having the rubella vaccine, there are women in the pregnancy, they get a IgM, and that time they started 3 molar urea testing. And if somebody, because the one has to see it, affinity maturation, because memory cells, if it is stimulated, it will generate an IgM for a short time. And that is what is happening in many places, even in dengue or JE or West Nile and other things. So affinity maturation or affinity testing has to be carried out for scrub hackers or even JE also. Because Dr. Bondre said, despite of having vaccination, children are showing the IgM. But that is just because of a memory cells are getting activated. It might be something else.
Yeah, I agree, Dr.
It's an immunology, so I do not know.
So I'm sure in the group there are immunologists and lab experts, they will take care. But my simple point is, this is a live vaccine, and the positivity, IgM positivity could also be because of vaccination, maybe just for consideration.
No,
so,
I mean, our study showed that there is a steep down from the 64. Yes. In 1 year, it decreases to 13% in Bardwan, in PATH and other things. So JE is not stable antibody. So,
okay, I can see Dr. D.K. Srivastava in the group. I will certainly, it will not be good justice to this panel discussion if we don't ask his thoughts about future research for this institute, because he was the one who was, along with Dr. Mahima, leading the fight against AES. So Dr. Srivastava sir, if you can give your thoughts about future ideas for research for this institute.
Thank you, sir. Today I am here just for sharing.
No.
So I am keeping myself reserved for the future. I will convey to Dr. Rajnikant. Thank you, sir.
Sure, sir. Yes. Okay, Dr. Rajnikant, if you don't mind, I will just share a slide which I had prepared. I am not going to make my presentation, but I had when I prepared my presentation, I also thought some of the research priorities on JEAES which could be considered by this institute, and so which are listed here. So one is, now we are saying that the burden of AES, JE is coming down, but careful documentation of the surveillance data which is generated by BRD will be really useful, especially the age distribution, the trend of disease, as well as the case fatality ratio over the years. That will be very good documentation. Can also be a good publication toward this. The second important point in the area of JE, Japanese encephalitis, what we thought was, when we conducted a survey in 2015, the coverage for second dose was still at 40%. And even the NFHS 5 survey, which the findings which have come up recently, at a national level, the measles second dose coverage is very low, less than 30%. So it might not be a bad idea if your institute can consider conducting quick surveys. In 2015, what we also observed was about 1/3 of the children who are attending vaccination clinics are missing JE vaccine. Because there are several vaccines which are given at the same time, and there is a tendency from health workers to delay the vaccination. You take a pentavalent booster now and come for JE little later or so on. So that also could be considered as a part of the vaccination coverage. There is again, Dr. Bondre mentioned that vaccine effectiveness studies findings have come up, so that need not be done. But if you feel, you can still consider. Another area which I thought is about interchangeability of JE vaccine. And now all of us know that besides SA14-14-2, there are 2 more vaccines which are there in the program. That includes Genvac vaccine, where Dr. Gore was a part of it in development, as well as a GU vaccine, which is again inactivated SA14-14-2 vaccine. So there are 3 vaccines in the program, and it's possible that a child who has received first dose with 1 vaccine would receive another dose because of migration or whatever reason. So ICMR is now starting a clinical trial to see the immunogenicity of interchange regime. So it would be nice if your institute also could participate in this trial. The next area is treatment of JE patients. And Dr. Amita mentioned briefly about this, newer treatment modalities for JE patients. In fact, there has been at least 1 trial conducted in KGMU about use of minocycline in AES patients. And what she found was, although the mortality reduction was not there in both the arms, the disease outcome was much better in the arm which received minocycline. So again, a trial in JE patients to see what are the sequelae of JE patients could be considered. And the last point in JE, which Dr. Mahima also mentioned, is rehabilitation of JE patients. We know that 1/3 of the patients will have long-term disability, and there is a program for management of the disability of these patients. But again, assessing it, I know even Dr. DK and his student had conducted a study to this effect, but some kind of a study to give the rehabilitation measures for such patients will be really useful. Well, in the area of AES, because of strep typhus, we again are saying that there is a decline in AES due to strep typhus, and whether it is because of use of doxycycline or azithromycin in AFI patient, we don't know. So a quick survey of prescriptions of AFI patients would be very useful to know whether this decline is because of the use of this particular modality or otherwise. And this point also Dr. Mahima mentioned that some kind of clinical algorithm for diagnosing strep typhus patients at AFI, acute febrile illness with strep typhus or suspected strep typhus at peripheral health facilities need to be established or need to be developed, so that we don't give treatment empirically, but we give treatment based on some clinical criteria or even some basic laboratory criteria. And the POC or a rapid diagnostic test, low-cost test, a very highly sensitive test, if it is developed by this institute, it will go a long way. The last point is I remember that in 2015-16, Government of Uttar Pradesh invested heavily in equipping these ETCs, encephalitis treatment centers, for early management of these patients with AES and prompt referral. But what is the contribution of this ETC towards reduction could also be considered as an operational research project. And besides that, I know you also discussed about some of studies on One Health, because this is a disease which has a zoonotic component, this has a disease which has an environmental component. Some studies covering all the 3 approaches or all the 3 areas could also be considered. So these are just my thoughts. You could consider whatever you feel most appropriate. And maybe from the audience, if you have any suggestions you could give before we close this.
So I think, sir, these are very valid and very relevant points which we have already described. And some of the points we have already included in the 3 ideas which we have shared with the ICMR from the health minister point of view, because he was asking a few new ideas. So how we can further reduce the burden of JE and AES in the Gorakhpur region. And you have already mentioned about the vaccine efficacy, safety, coverage, vaccine interchangeability, then clinical algorithm, new drugs which are in the pipeline. So definitely we will work together, make an action plan, future action plan, what we can do. I think today's discussion with the experts like Dr. Gore, Dr. Mahima Mittal, Dr. Amrita, and others will be very helpful, making a good action plan for the future studies. Thank you so much, sir.
Thank you very much. Thank you.
Dr. Nath.
Can I? JP, sir.
Yes, sir.
Sorry.
Can I make a couple of suggestions?
Please,
Just
sir.
out of my head. I think maybe might be useful to analyze the surveillance data as obtained in UP, in Bihar, and in Northeast. Try to compare, because we know the seasonality, the risk factors are quite different in different states. So I think that might be, rather than discuss about a particular area, I think if we can, that's number one. Number two, I think, the risk factors are quite different in UP and that obtained in Bihar, for example, Muzaffarpur. So if we can do a uniform case control study methodology applied maybe across India with sample size, so that, so we have data that can stand on its own as far as UP is concerned, as far as Bihar is concerned, or, for example, in Assam. And third, I was wondering, because I think the different interventions being applied, and they seem to be effective to a large extent. In UP, we have, say, doxycycline, presumptive treatment with antibiotics. And in Bihar, we have the nutrition part, or the glucose supplementation, and whether we can evaluate the effectiveness of different interventions being applied in different. And finally, I think, the Gorakhpur, the UP experience need to be documented and shared, because I think clearly it has demonstrated, as I was going to mention, the decline in the incidents. We have not seen any spike in cases or outbreaks as we used to see every year. And also the mortality has also come down dramatically, it seems. So I think that experience, I think, need to be shared as well. So these are my just open thoughts. Thank you.
I agree with you, sir. All the 3 points are very important. Looking into surveillance data of UP, Bihar, and also northeastern states, doing a case control study to identify risk factors for AES or specifically for AES due to scrub typhus, and effect of interventions will be really useful. So, Dr. Rajnikant, I hope you have taken note of these important points.
Yes, I have taken the note. Okay, so thank you so much. Thank you very much. So with this session, I thank Dr. Murekar for moderating this session, and a very, very important point have emerged out, and we will work on those points and prepare the proposals. With this, we have come to the last valedictory and concluding session. And with us is Dr. J.P. Narayan. We all know he has been very senior medical scientist in the area of communicable disease. He has worked even in the area of non-communicable disease in WHO, in NCDC, and sometime I think he was in ICMR also. And currently he is helping us.
1 year, in 83.
1 year, no, sir. Yes, I remember. And now he is advising and guiding us for our Geelong Field Station. And if Dr. Surekha Kishore, I came to know that she has also joined. AIMS Director AIMS, Dr. Surekha Kishore. Is she connected? So I will request Dr. J.P. Narayan for the concluding remarks, sir. Over to you, sir.
Thank you. Thank you so much for the kind introduction, Dr. Rajnikant. Let me also congratulate you and your team for the inauguration of the impressive new building at RMRC Gorakhpur, a major milestone for your center. Regret that I not able to join you in person, but I think I'm glad to see many friends and colleagues, virtually. As we come to the close of this very, very interesting, very informative symposium, I think we have covered many, leading health challenges of the present century, starting with a wonderfully insightful keynote presentation by Dr. Sanjay Mandale. And also I'd like to congratulate all the speakers who have comprehensively covered various aspects. This was a brilliantly planned and extremely informative symposium, especially for someone like me, who has been out of the system, so to speak, for quite some time, and presently secluded in the faraway Himalayas. So that's why I'm sort of all dressed up for the winter. I just like to, with your permission, share just a few points. And I promise that I'll be very brief. Maybe take about 5 minutes of your time. In the symposium, I think we have discussed extensively the lessons that we have learned from the COVID pandemic. In my view, the biggest and the most important lesson is on highlighting the critical and fundamental importance of a robust health system for surge capacity, especially the human resource part of it, such as epidemiologists, laboratory personnel, which are the backbone of our ability to not only detect quickly and respond rapidly to any unusual health event that confronts us. Given that district epidemiologist positions are still vacant in many, many districts in India, it seems to me that we have not really learned our lesson. You will be surprised to know that we have in Himachal 12 districts, and none of these districts have an epidemiologist. While under IDSP, we are expecting that every district should have a district epidemiologist. So the second, I think, lesson, in my view, is the issue of inequity globally. And, this inequity is fueling not only the risk of mortality associated with COVID, but also the access to COVID vaccine. And as we have seen clearly very recently, that lack of access to vaccine has led to breeding of new variants. As a matter of fact, this new variant Omicron, emerged in South Africa and Botswana, primarily because there has been very low coverage for vaccination. So I think it's a global and a national issue with regard to inequalities in the society and the social justice. The third lesson is, I think we need to also learn from other programs. While we were talking about behavior change, one of the programs that I worked for many, many years was HIV/AIDS program, where, behavior change and communication was the bedrock of prevention. And there in HIV/AIDS program, I think we were primarily focusing on behavior change through interpersonal approach. Maybe media approach is important to provide information, but media approach cannot bring about behavior change in people. So behavior change through interpersonal approach, or NGOs who have access to the population who trust them, and also, providing an enabling environment for behavior change to occur. So I think this approach is, clearly important. The pamphlets may not bring about behavior change, but I think interpersonal approach on a sustained manner, I think will do that. Another lesson that we have learned is how a multi-pronged interventions used in India, in line with Indian culture and tradition, can benefit us all. Be it use of Ayurveda, yoga, nutrition, modern medicine, and vaccines. As a matter of fact, Ayurveda and yoga became so popular as never before during this pandemic. And I've seen also some of the clinical experts coming on TV and talking about yoga and also about Ayurveda and the importance of nutrition. So I think this is also important. Now, we have talked also about climate change. Now, in fact, climate change and the pandemics have many parallels. Both are defining public health challenges of the 21st century. And their impacts are huge, threatening public health security in a major way. And both climate change and pandemics affect the most vulnerable in the society and disproportionately affect them, especially the elderly and also those who are poor and marginalized in society, who are not only at the great risk, but also not the least able to fend for themselves. And finally, I think both climate change and pandemic health sector has a central role to play. But the response requires a multi-sectoral and multidisciplinary approach, and the actions cutting across all relevant sectors. So therefore, I believe that the health sector has a very critical role to build evidence on both the health and the economic impact of climate change and the role of social structures in responding to climate change and advocacy, for both mitigation and also on adaptation measures that are needed. So finally, I should like to acknowledge the stellar contributions made by RMRC Gorakhpur, especially in the area of acute encephalitis syndrome in UP that we have been discussing. And I think it enhanced our understanding of AES in terms of its epidemiology and also in terms of risk factors and how early treatment with antibiotics can save lives. So as a result of this, as I mentioned, it seems that the incidence and the mortality associated with acute encephalitis syndrome has come down quite remarkably as far as UP is concerned. This I consider as a classical example of how evidence developed locally can lead to policy formulation and implementation. And that can obviously, again, save lives. I therefore like to congratulate RMRC Gorakhpur and its staff, both present and the past, for a job well done. And as a matter of fact, I was listening to the Prime Minister yesterday. He also acknowledged the contribution that RMRC had made over the past many years. So I believe that, sky is the limit as far as RMRC is concerned in terms of research and also, providing evidence for public health action and also for its field station at Kelong. I see also there's a great potential, a lot of challenges, but great potential that the full field station can contribute to enhancing, health and well-being of tribal population in remote district of Himachal Pradesh. So I stop there. I wish you all the best and thank you very much. Namaskar.
Thank you so much, sir, for your valuable comments. As you rightly said, sky is the limit for the RMRC Gorakhpur. And in last 2 years, we have already reached from the land to the 30,000 feet above the sea level in Kelong. So this is our progress. So you can understand we can touch the sky. Thank you so much. With this, we have come to the end of a very interesting, very informative, very elaborative symposium. And I thank once again to all the speakers for their very, very important talks and for their presence. They could spare time and enlighten us. I also thank all the participants, those who were connected throughout the symposium, and this stretch up to from 5 to 6. So, but even then they are still interested to take it further. But many of the speakers, they have to catch a flight. So we will end here. I will request Neha Srivastava for formal vote of thanks. So over to Neha.
Hello. Good evening to all. I am Neha Srivastava, PhD Young Scientist at RMRC Gorakhpur. It gives me an immense pleasure to deliver the vote of thanks for this event to all dignitaries assembled here and connected virtually. First of all, I, on behalf of whole RMRC team, would like to propose hearty vote of thanks to Dr. S. Mahendle sir for gracing today's event and delivering the inaugural address. I am sure that all participants have taken note of your suggestions and will be discussing the action to be initiated at their level. Next, I would like to thank Dr. Samiran Panda sir for his excellent presentation on overview of COVID-19 pandemic response in India. Next, I would like to thank Dr. Priya Abraham Madam and Dr. Pragya Yadav Madam from NIT Pune for brief introduction of SARS-CoV-2 variants and their hard work on vaccine development for COVID-19. Next, I would like to thank Mr. Kaushik Bose sir for his interesting discussion on key points of risk communication methods. Next, I would like to thank Dr. Subir S. Majumdar sir, Dr. Manju Rahi Madam, and Dr. Sanghamitra Pati Madam for their interesting talk on One Health research, its importance in India, and initiatives taken by ICMR towards One Health research. Next, I would like to thank Dr. R.S. Yadav sir, Dr. R.S. Sarma sir, Dr. P.K. Srivastava sir, and Dr. R.C. Dhiman sir for giving important talks on impact of climate change on re-emergence of vector-borne diseases in India and its transmission and how these issues can be addressed. Now I would like to thank Dr. M.M. Gore sir, Dr. Manoj V. Murekar sir, Dr. Amita Jain ma'am, Dr. Vijay Bonde sir, Dr. Mahima Mittal madam for sharing their experiences and contributions towards JEAS research in UP and giving future directives towards JEAS. Last, I would like to thank Dr. J.P. Narayan sir for his effective talk and suggestions for RMRC Gorakhpur. Last but not the least, I would like to thank torch bearer of this event, Director Sir, Dr. Rajnikant Sir, for having this really interesting symposium at RMRC Gorakhpur. I hope in future also we will have such great scientific events at RMRC. Now I would like to give huge compliment to all scientific team, technical team and IT team, Yogesh Sir and Ms. Priyanka, for this systematic execution of this event, and Dr. Anna ma'am and Mrs. Stuti ma'am for guiding the whole event, and for Tubina ma'am for her positive presence at this event. Thank you to all. Thank you so much.
Thank you so much. Thank you everyone.